During the final 8 weeks, in preparation for delivery, most babies settle in a head-down position. About 4% of babies don't get head down. These babies are said to be in a breech presentation. Up until the year 2000, a woman carrying a breech baby had 2 choices. She could have a vaginal breech delivery or a cesarean breech delivery. In 2001, one of those options
Now it's gone, everything we built together, gone. All the memories we made are gone. What you said to me, tell everyone you're dead to me, gone. Gone, gone. I slept like hell last night, thinking about what you said. Please do not promise me anything again. And maybe I'm paranoid, if I am you're to blame. Please never promise me anything again. Now it's gone, everything we built together, gone. All the memories we made there's nothing new for me to say. Why? Sweating through the sheets, shaking in bed. Visions of her naked in my head. But I went off and chose myself instead. Why is my mind? I don't know why.
teamwork makes a dream work. Hell, I had some help.
I didn't think you'd understand me. How could you ever even try? I don't wanna tiptoe, but I don't wanna hide. But I don't wanna feed this monstrous fire. Just wanna let this story die, and I'll be alright. We can't be friends, but I'd like to just pretend. You cling to your papers and pens. Wait until you like me again. Wait for your love, love. I'll wait for your love. Me and my truth, we sit in silence. Baby girl, it's just me and you. 'Cause I don't wanna argue, but I don't wanna bite my tongue. Yeah, I think I'd rather die. You got me misunderstood, but at least I look this good. We can't be friends, but I'd like to just pretend. You cling to your papers and pens. Wait until you like me again. Wait for your love, love. I'll wait for your love. I'll wait for your love, love. I'll wait for your love. Know that you made me. I don't like how you paid me, yet I'm still here hanging. Know what you made me. It's something like a daydream, but I feel so seen in the night. Something new, it's only me, and maybe that's all I need. We can't be friends, but I'd like to just pretend. You cling to your papers and pens. Wait until you like me again. Wait for your love, love. I'll wait for your love. I'll wait for your love, love. I'll wait for your love. I'll wait for your love.
make tonight the weekend. I don't wanna wait, I don't wanna wait, I don't wanna wait. Got no reason not to celebrate, baby, I just don't wanna wait. Swimming in the deep blue, got me thinking about you. I'm just trying to dive right in. Wanna spend tonight like the last night of our lives, chasing all the love we can. And now, oh, I'm in a sea of lights, and all that I can see is you. And now I'm dying to feel alive. So baby, let's try something new. Let's make tonight the weekend. I don't wanna wait, I don't wanna wait, I don't wanna wait. Got no reason not to celebrate, baby, I just don't wanna wait. Tonight's the weekend. I don't wanna wait, I don't wanna wait, I don't wanna wait. Got no reason not to celebrate, baby, I just don't wanna wait. I've been chasing so long, every right that feels wrong, rather be with you instead. There's something about it right here, got me seeing so clear.
O'clock, but yeah, it might be birth time by then, so no. Yep. So yeah, welcome everyone. Just want to honour the land that we're on today, the Wurundjeri people of the Kulin Nation. Always was their land, always will be, honouring all those in the past, those currently with us, those holding babies, and those babies still to come in the future. So just acknowledging that space, and welcome everybody.
Hi, everybody. Thank you all for getting up and coming and spending 2 days with me. It's very exciting for me to end my trip in Melbourne. I've been in your country for a month. It's been amazing. I've had an amazing time here. Sort of hate to see it winding down, but we're gonna have a good time over the next 2 days. Let me give you a little heads up of what we're going to do. This is not just a lecture, it's a conversation. The best way to learn, when you're little, maybe repetition, but when you're older, it's storytelling. So will be a lot of stories being told, and I hope they're not just by me. The issue is, because we're starting a little late today, we're probably going to go till at least 6 o'clock. You say, well, how can 2 lectures take 9 hours? It does, because there's a lot of conversation that goes on, a lot of things we talk about, and what happens is you guys begin to open up, and then we have a dialogue. And I've learned so much from the differences between our countries and how things go, and I really want to continue to have that happen. So feel free to speak up. There's, it's not a didactic lecture here. The way the day is going to work is, how many of you have seen the Heads Up documentary? Just the one. And you saw it, was that because we showed it? I saw it a long time ago. Okay. Heads Up, the Disappearing Art of Breech Delivery is what I'm going to start with. It's about a 32-minute documentary made by my friend Elliot Berlin and director Mel Morrow, and it was done I think it premiered in 2014, but it was shot over like a 3 or 4 year period of time. And I'll get to that in a second. I'll preface it in a second. Then I'm going to do a lecture called Breech, the Other Way Babies Come Out. And this is more about sort of why we're in the predicament we're in, how did we get here, why do doctors sort of have a problem with breech delivery, among many other things, what can maybe we do to try to change things, what are the real facts behind breech birth, and what are women being told? And why are the two like this far apart? Because that's what we're up against with breech. And then we'll have lunch, and then we'll have a second lecture, which is the meat and potatoes lecture, which is breech insights and maneuvers and methods, and with a lot of videos that we'll break down. We'll go over them. There will be the simulations will all be tomorrow. I think we're going for dinner tonight. Many of you are going to go to dinner tonight. That'll be fun. And then tomorrow we're going to start, if I can get Joe and Michael here, about 8 o'clock. You don't have to be here at 8 o'clock, but some of you could be here at 8 o'clock, because we're going to have two Sophies set up. One will be in upright breech position, one will be in lithotomy breech position. We'll practice with both of them. And because we have such a large group, normally we try to cap it around 15. But I think we have about 24 or 25 people coming, which means that it needs to take more time to get everybody to get enough demonstrations and practices. And then that'll be the morning. And then we'll finish about 11:30. So we'll go from about 8 to 11:30 just doing demos. So there'll be a lot of coffee time, a lot of tea time. You can meet around and talk while other people are doing them, but I would like everybody to watch for a while to see how people are doing it. And then what I end up doing is getting some of you to do the pushing, because you can learn a lot from that too. And then I can walk back and forth and just sort of see what's going on. We'll break for lunch. Then I'm going to do, and probably a working lunch tomorrow, because I'll start talking about twins tomorrow. I have a whole lecture on twins, and that takes about 3 hours, a little over 3 hours to talk about twins. Then the rest of the day, we'll be we'll be back to the simulators, and we'll be practicing things like breech extraction and internal pedalic version, which are things you may or may not ever use, but they're very valuable skills to have, especially if you go off in the bush or go to a third world country or something like that. You don't have access to a scalpel. It's a very good thing to know. Plus, every time you pull a baby out by its feet from inside, you then have to do all your other maneuvers that we were practicing in the morning. So you're going to get double practicing breech. And I'm hoping that by the time you leave here tomorrow that you're all going to say, I'm not an expert in breech, but if I had a surprise breech, or one of my colleagues called me and said, I got a surprise breech, what do I do? You could go there and you could probably solve the problem. And most of the time there isn't a problem, but when there is a problem, you know how to solve it. And you know what to watch for, and the baby will tell you what those things are on. So that would be my hope. So let me just ask a question. Who here is not a midwife? What do you guys do? Oh, you're just mom?
I just support free birth.
So in other words, you're still a birth worker. So a doula, is anybody that's a doula here, solely a doula? So you're all midwives, or all birth workers, so to speak. And there's nobody here is just a mom, besides being a mom too. Okay, so this is good. So I know who my audience is. And then, so how many of you have actually done a planned breech? Just like 3 or 4, 5 of you, okay. How many of you have been surprised by a breech? So about 2/3 of you. And how many of you have never actually been at a birth where there's a breech baby, besides Michael? So have you been at?
Just in the hospital, just watching.
Just watching. Okay. No, but that's a good question, because again, I forget, but how many of you are public midwives who work in a hospital setting? All right, and then the rest of you are home birth midwives or birth keepers? Okay. All right. Do you have any starting questions for me? Do you guys I tell my origin story a lot, but some of you probably haven't heard it. I mean, how many of you listen to the podcast, by the way? So good many of you, okay. So I can just start out a little bit if you want me to tell a little bit of my origin story. Some of you are nodding. Okay, because how did I get here? Because I'm not your typical obstetrician. I told it last night with Rhea, but I'll say it again. I grew up in Minnesota, which is a state in the north central part of the United States. I had a very normal youth. I grew up in the 50s and 60s. I was born in 1956, so you can figure that out for yourself. Lived through a lot of decades. So I grew up there. I really had no desire to be a doctor. It was never on my radar screen. I liked being outdoors. We spent all our days outside in Minnesota. And you say, well, it's really cold there in the wintertime. Yeah, well, we were outside in the wintertime too. We never stopped kids from being outside in the snow. So I thought that maybe I wanted to do something outside, like be a marine biologist or something to do with the forest or something to do with large wildlife like moose and deer and things like that we have in Minnesota. So that was where I was headed. So I went into, after high school was pretty much everybody goes to college in my country, at least back then they did. And I had no direction, but I went into the College of Biological Sciences. And so I had all the prerequisites done. I had things like physics, organic chemistry, biochemistry, all the stuff that you had, calculus, all those things that you had to do in order to get into medical school. But I was never intended to go to medical school. But then some of my buddies said they're going to go to medical school or they're going to apply to medical school, so I had no direction. And quite frankly, I had a Jewish mother. And if you've ever heard stories about a Jewish mother, they want their sons to be doctors. So I made my mother very happy, and I got into medical school at the University of Minnesota. And then some strange things happen in life that you cannot ever account for ahead of time. Sometimes they're serendipitous, sometimes they're what we call sliding door moments, where if you would have turned left, you'd go this way. If you would have turned right, your whole life would have been different. So in my third year of medical school, the first 2 years of medical school are essentially classroom and laboratory and anatomy lab. And the second 2 years of medical school in my country are clinical rotations. There are certain core ones that you have to take, like internal medicine, surgery, OB, pediatrics. And there are certain electives that you can take, including things like ear, nose, and throat, dermatology, pathology, radiology, those sorts of things. So one of the electives I took was hematology oncology, which I'm not sure why I did it, but I just did it. And it was a pediatric rotation in hematology oncology. And I saw kids dying and kids with fungal infections of their brain from all the immunosuppression. And we were up at night taking care of those people, and it was very depressing for me. Then my next rotation was serendipitously OBGYN, and I didn't know anything at that time. I didn't know you don't need to cut a medial episiotomy in every single woman. You know, I didn't know every woman needed to be on her back. I didn't know that you needed to cut the cord immediately and take the baby to the warmer. But we did all those things. But I was up at 3 in the morning catching a baby. And I thought that this is remarkable. And this is really what I want to do. Because of that, and because OBGYNs get to do a little bit of internal medicine, they get to do surgery, they get to do endocrinology, they get to do some psychiatry. And they get to do what I really wanted was longitudinal care. Longitudinal care is where you take care of people over time. There's only 3 specialties that do that: GPs, internal medicine doctors, and OBGYNs. Everything else, you're sort of a whack-a-mole doctor. Somebody comes in with a ruptured appendix, you take care of the appendix, you never see them again. You know, somebody comes in with a detached retina, right? You do eye surgery on them, they get better, supposedly, not me, but they get better. I don't know if you know, I've had 6 surgeries on my right eye in the last year and a half, so it's been a journey. And then you never see them again. That's not what I wanted. I wanted the continuity of care. So when you're totally unprepared, when you're naive but enthusiastic, you have to apply for residency programs at the end of their 3rd year, early 4th year of medical school. You're 24, 25, 26 years old. You really don't know what you want to do. You've never had any world experience because you've been going to college for 7.5 years straight, and you have to make this decision. So I chose OBGYN, I applied to different residency programs. They interview us, we interview them, and then it all goes into a computer. And one of these very sliding door moments is the 3rd Wednesday of March in the United States at 1 o'clock Eastern time. You get an envelope that tells you where you're going to be spending your next 3, 4, 5 years of your life. It's called the match. I think you might have something like that here. I don't know how your doctors decide where they end up. But so I opened mine up and I matched in Southern California at Cedars-Sinai Medical Center, which is a very nice hospital in Southern California. It was my 3rd choice. So had I got my 1st or 2nd choice, my life would have taken a totally different path. But I ended up in Southern California, and I was very lucky at that time because we're talking about the early 1980s now. And the world was a different place California was a different place in the 1980s. California was still the place of the Beach Boys and the Eagles and that sort of thing, a very free feeling, but I never had to enjoy that because I was working 40 hours a day. If there is such a thing as 40-hour days, but we did work 40-hour days. I would work 5 in the morning till 9 p.m. the next night, go home and sleep for 8 hours, and come back and do it again. They finally changed the laws in the United States that residents can't work that many hours in a row, but that's what we were doing. Anyway, we were affiliated with LA County USC Women's Hospital. USC is University of Southern California. So it was the big county hospital in Los Angeles. And at that time, it was the busiest hospital in the country, which we didn't know was an advantage. We thought it was like we're working our asses off. But they were doing about 22,000 births a year there, which is about 65 babies a day. And I was there for 4 months, every other day. So that's 60 days, 65 babies a day. You can do the math. And if you're seeing 65 babies a day and 4% of babies are breech, you're seeing 2 or 3 breaches every day. And 40%, not 4, one out of 40 pregnancies, or 2.5%, are twins. So you're seeing 1 or 2 sets of twins every day, and I'm there for 60 days. So I got a lot of exposure, and it was just considered normal. It was really considered normal. It was actually considered desirable. We fought over who gets to do the breech lady in room 6. That was what we fought over. They never had names, by the way, the women. They were just the breech lady in room 6. That's not something I would ever do now either. And I didn't learn this stuff in residency. Everything I learned since that time I learned from you guys, from midwives. But I was very well trained. So I came out of residency very well trained, but extremely medicalized. I often laugh at myself because I was the crazy guy in the hazmat suit at the end of the bed with putting your legs up in stirrups, covering your legs with blue drapes, washing your vulva off with betadine, and catching your baby. And then, actually, in those days I was delivering your baby, and then I would cut the cord immediately. As a matter of fact, every now and then we'd drop a clamp on the floor because we were reaching for the clamp so quickly to clamp that cord immediately. And then we'd hold the baby up and show you the baby, and then we'd walk the baby over there and set it down in the warmer. And the nurses would do all these things, and eventually the mom would get her baby back wrapped like a burrito with a hat on, no skin to skin, no nothing. And we thought that that was normal. And I did that for a good decade, even though early in my career, another serendipitous moment, because in 1986, when I came out, you didn't come out like you do now, doctors do now, and get a job, working a shift, being paid a salary. You had to build your own practice from scratch. So I covered other doctors when they were on vacation. I assisted them in surgery. I worked at free clinics. I covered emergency rooms. And one of the things that happened to me, again, very fortuitous, was that I was approached by some local midwives who I had no knowledge of because we never really got exposed to them in residency other than when they brought in some sort of disaster, because we don't know the other things. And they asked me if I would take their home birth transports. And I said, sure. But I didn't say sure because I thought home birth was a good idea. I am very certain that I thought it was a bad idea. But I did it because I could make money doing that. So that started me on a road to learn a whole different thing, because they would bring their clients in, and because I wasn't that busy and because I really liked the relationship part of the practice, when a woman came in from home, I had never met them before. I would show up at the hospital, and I'd usually try to get there before they got there, so that when they walked in, I would help them get them through the admission process as a favor to them and the midwives that I was becoming friends with. And I would spend time talking to them while they were waiting for their epidural, and then eventually they'd get their epidural and they'd start them on Pitocin, and they would take a nap, and most of them would end up having vaginal delivery. But there'd be a lot of hours in between where I'd sit in the lounge with the midwife, and we would be chatting, and I would start to learn and listen and hear a whole new way of doing things. Why are these women choosing this? How can you do this? What happens if this happens? And they had answers for everything, and they were very well educated, and the clients were very well educated, far more so than my clients. We had no training in breastfeeding. We had no training in nutrition. We had nothing like that during residency program. And they started to tell me a different way of doing things. And I got very interested in it, and I got invited to come to some of their open houses and their meetings, and I would go. Partly I was going to market myself, was part of it. I mean, ultimately I probably had an ulterior motive early on, but it just started to infect me. And I really began to see that what I'm doing and what I know applies to about 15% of women. And the other 85% I knew nothing about. I didn't know what normal was, because we won't ever see normal. If you ever watch The Business of Being Born, there's a scene in there where they ask the three female residents, have you ever seen a normal birth? And they all look at each other like, no, we haven't. Because they're never called to a room to watch normal. They're only called to the room when it's time to do something. So that's how they see birth. So I began to feel a different way of doing things, and I began to see that there's an advantage to this. So 10 years out, in 1996, 95, 96, I started a collaborative midwifery practice with 2 certified nurse midwives at a hospital in Ventura County, which is just north of Los Angeles, because Cedars-Sinai at that time did not allow midwives to have privileges. And we did a really good thing going for 15 years. The midwives took care of all the normal stuff. The well woman exams, the menopausal stuff, the pap smears, the prenatal visits, the normal deliveries. If a woman had an abnormal pap smear and needed a colposcopy or biopsy, I did that. If a woman had an ectopic pregnancy or an ovarian cyst, I would take care of that. If they had breeches or twins or they needed a C-section or a vacuum, I would take care of that. And we had a really good thing going, but we were never accepted in the community by the other doctors in the community. And you've heard this story probably over and over again, how doctors who do things differently often are the ones that get picked on the most and they get ostracized. And that's sort of what happened to us. And even though I have a very strong constitution in nature, it wears on you that you get peer reviewed for something and that they don't get peer reviewed for. And they do things that are outrageous and wrong and nothing happens. And I come wearing the wrong colored scrubs because I came from Cedars to this hospital. I get written up for wearing the wrong colored scrubs to a birth, that sort of thing. So you see what's called sham peer review and gunny sacking and these things where they pig pile on you. And after 15 years or so, and we had a C-section rate of about 7% in our practice. The average C-section rate in that hospital in the 90s was probably 25, 26%. So we were less than 1/3 the C-section rate, high satisfaction rate. We took all comers. So it wasn't like we were comparing low-risk midwife patients to high-risk doctor patients because we took all patients. And after 15 years, they were really tired of us. Mainly the anesthesiologists and pediatricians were very nervous about our patients because they had been brainwashed by the OBs to think that things we were doing were dangerous, like breeches, like twins, like VBACs. And so the hospital eventually then banned VBAC. Then they kicked the midwives off staff. Then they told me they were going to ban breech delivery. And we got into an argument about that. And it's the old golden rule. If you know the golden rule is them that has the gold makes the rules. So they got to make the rules. And they said, well, we can't really legally kick you off staff, but you're up for renewal this fall. We're just not going to renew your privileges. So you can fight with us if you want or don't fight with us if you want. So I talked to a lot of good advising people, including my midwife colleagues. At that point, been 25 years I'd been sort of backing midwives. And they all told me, Stu, just come and do home birth. And I thought about it. I said, well, if I fight them, because my nature was to not take it and to fight them, they said, what are you going to win if you fight them? You'll win the right to stay at a hospital that's looking over your shoulder everything that you do, because if you beat them, they're going to come after you. And I said, well, that's not a good choice, so come and do home birthing. So after 25 years of backing midwives, I had never been to a home birth. And I was a very supportive doctor. And so 2010, I went to my first home birth. And it was lovely. Thank God, it was lovely. That the first 10 or 15 of them were just these beautiful butter births that you guys like to call them. And so I got very comfortable doing home birthing. And I always went with a midwife. And then I became a preceptor for several midwifery schools, and I had always had a midwife student with me. And there was often a doula. And so I didn't have to do much. I'd go to the house. I have male energy. I kept myself out of the room most of the time. I'd be on the couch with my headphones, listening to music. And I would come in, but I would provide confidence to the family, especially the dads. And we had a really good thing going. And then I started to get bolder. And I said, well, if I was doing breeches and twins in the hospital, why did these women have to get this medicalized, algorithmic way of delivering their twins? Why can't I do them at home? So I started doing them at home. And then I thought about diabetics. I was approached by some diabetics, type 1 diabetics, who are unbelievably well controlled. Probably have better blood sugars and take care of themselves better than most of our other clients. But they were on an algorithm at the hospital. You need to have ultrasounds and NSTs and be induced by 38 weeks, and baby needs to go for observation, which is the worst thing you can do to a baby that's born to an infant of a diabetic mother, as an infant of a diabetic mother, is take the baby away from the mother to the nursery to be observed in a box. So I started doing diabetics at home and hypertensives at home. And then I had written a book earlier in 2004, and it came out with a new edition in 2010 called Fearless Pregnancy. And then I'm not an academician, but I felt like there was enough data here, so I started to publish a few papers. I got Rick Safries on board with me. We published a paper on breech. We've got one coming out on twins. You guys all know Rick Sif from Breech Without Borders. And then I began to teach. Then I found out about the Sophies and their moms at a conference, and I said, these are great teaching. And I started to teach. And so And then after 40 years of being on call, 2 years ago, I decided that that was enough. And I didn't want to, it was taking a toll on my health and relationships as well, as you all know. And so I stopped taking call in 2022. I bought an RV, traveled around the United States. I taught breech and traveled in my RV. It was a great summer. And then now this is what I do. I do online consults. I do the podcast with Bliss. I've been doing the podcast since 2013, so for 11 years. Bliss has been with me the last 7 years. And then I go around and I teach this 2-day course. It's a passion for me because the skill is otherwise will die out. You guys are the torchbearers of breech because obstetricians are obtuse and will never get back to doing it. Even if the young doctors want to learn it, the establishment or the system or the older doctors will tell them, you can learn it, but you just can't use it. That's what they'll tell them. So we need to do it because it's simple. When you see the numbers and the actual numbers, and then you realize how they decided to get rid of it, I guess it won't baffle you because we live in what are called the stupid times. Pretty much everything that's being done by big corps and big government and stuff like that seems opposite of what common sense people would do. I got to meet yesterday Michael, who makes the Sophies and her mom here in Melbourne. Jamie took me over there. This guy he's an engineer and he has more common sense than anybody on Ranscog or anybody on ACOG. You know, there was a famous interviewer, he's passed away now, named William Buckley. I don't know if you know who William Buckley was. Did a show on the United States called Firing Line on public television. And he once made a statement, which is very famous, and he said, I'd rather be governed by the first 500 names in the Boston phone book than the entire faculty of Harvard University. Because there's more wisdom and knowledge in those people, in the plumbers and the housewives and everything else than there is in these people with lots of letters behind their name. But somehow these people with lots of letters behind their name become the people that tell you how to do your job when they've never been to a home birth, like me. So that's how I got here. And I'm really happy that I did. And it was twists and turns. Had I only decided not to go to medical school, my life would have been different. Had I not matched in Southern California, I can't think how different my life would have been. Had I not done my obstetric rotation immediately after my hematology oncology rotation, I'm not sure that I would have had the appeal. I might have ended up doing ear, nose, and throat, who knows, something else, and it would have been entirely different, but I'm so lucky. And part of the reason I'm lucky is because I've walked on the coattails of midwives and I've been able to absorb what they've taught me and not rejected it. And that just happens to be my nature. I challenge everything, I question everything, but if something makes sense to me, then I adopt it. And the midwifery model of care, I was never exposed to until those few days where I would sit in the lounge with a midwife and just listen. The wisdom about why she would ask me questions. Well, why are you doing a vaginal exam every 2 hours? Well, I have to plot her progress on the Friedman curve. And then she would talk to me about the Friedman curve and how, and so a lot of the stuff that we're going to talk about in the next 2 days, I'm just sort of a megaphone for the fact that I am my ancestors, just like the dedication we give to the land here. It's the same thing here. I have a slide tomorrow with all my mentors on it, so that I can remember. And all the people that came before them, that I taught them, that then they taught me, and hopefully you'll pass on. So that's me. Any questions about that? Okay. I know that I'm going to try to get through things fast, but I can't. I just talk. This is just the way I am. So what we're going to do now is we're going to take 30 minutes or so, and we're going to watch this documentary. It's a great way to start. Again, it's called Heads Up. And what I'd like you to listen to, I don't need to tell you this because you will, but listen to the women. The women's lines are not scripted. Nobody gave them cue cards and told them what to say. But what they say is so powerful. There are 6 stories of 6 different women in this. And every one of them has something to say that resonates with me and will resonate with you. And then there are 3 doctors in it. Dr. Wu has since passed away, sadly, because he was one of my mentors. Dr. Crane, who's in his 80s, who's still practicing, and me. And then my friend Elliot Berlin, who's the chiropractor in Los Angeles, who almost sees all the, like all the women who need Webster technique and breech things. He's the guy that everybody goes to. So he is an entrepreneurial guy. He decided he was going to make a documentary. So he's the producer of this thing. He's in it. And I just hope you enjoy it, and I hope you're moved by it. And afterwards, I really would like to have a little conversation. So if you see something in there or want to know something, I won't preface any more. You want to ask why or make a comment about something that was said, please maybe jot notes or write it down. The other thing I'll tell you as business is that you'll be getting all the non-video slides. So all my presentations today and tomorrow, you'll get this, I'll send them to Jo, she'll distribute them, so you'll get all the slides. So you can take notes if that's how you best remember things, but don't spend a lot of time trying to scribble things, or you can take pictures of the screen, but you're gonna get the slides anyway, okay? Everybody's gonna get them. Any questions? Not one. Okay, all right. So should we do it? All right, hang on, let me get this back up. Oh, my legs are so sore. I walked around the lake yesterday by the center, whatever that lake is called, by the Pullman Center. Yeah, it's cold. It's cold and windy. Okay, so this thing just starts right off because it's my copy. So here we go.
Human pregnancy lasts about 9 months. During the final 8 weeks, in preparation for delivery, most babies settle in a head-down position. About 4% of babies don't get head down. These babies are said to be in a breech presentation. Up until the year 2000, a woman carrying a breech baby had 2 choices. She could have a vaginal breech delivery or a cesarean breech delivery. In 2001, one of those options disappeared, almost entirely.
I would have liked the option to deliver a vaginal birth with my baby.
I felt that I could have done it if the doctors would have just let me.
It's a risk versus a risk. There's not no risks in either option with breech birthing.
Do I see myself having a cesarean? No. I don't, not in my vision.
I look in the mirror, I see this mocking smile of my C-section scar.
I was robbed of a chance to have an experience.
They're told that, oh, breech, the head could get stuck and your baby could be asphyxiated and you'd be fooled to have a breech delivery. And that's what you hear. But that is far from the truth and far from the whole story.
I'm not married to the idea of a vaginal breech birth. I'm married to the idea of having an option.
Breeches are much safer in terms of delivering them than anybody would imagine. I think that's the bottom line.
But why are we turning a deaf ear and a blind eye to this important skill that needs to be engendered to give women choices?
My name is Sarah, and this is my husband Doug, and we are 39 weeks pregnant with our first child. At 34 weeks, my midwife was doing a pelvic exam, and she looked at me and she's like, maybe you should get an ultrasound just to be sure. So I went for an ultrasound. At 34 weeks, my doctor confirmed that she was breech.
It was a little scary when we were told the only option really that he was going to give us was a C-section.
I didn't really understand why, and honestly, I want to have a vaginal birth.
I was basically the only choice they had other than a cesarean section in pretty much most of Los Angeles. You have to hold it down, and the green light will come on, and then let go.
I feel like she needs to come out vaginally. It doesn't feel like this is an emergency situation.
So this is probably where most of it will happen, is in here.
All things being equal, breeches should be born in a hospital setting because you have the ability to have general anesthesia should you have that emergency. The problem is all things aren't equal.
The reason why we stopped doing vaginal breech delivery was based on a single study that had some flaws.
A paper came out called the Turn Breech Trial, which definitively showed initially that the outcomes for breech deliveries were worse by vaginal birth than by cesarean section.
And in 2001, the American College of OBGYN came up with a position paper. It was published in their book here that they put out every year, the compendium. And that paper said that unless the baby just was falling out upon arrival, that we should section all breeches.
It didn't take long before nearly every doctor in North America stopped offering vaginal breech delivery as a choice, because who wants to go against the newly established community norm?
It died in residency programs, and it certainly, the economic incentives to do it for doctors was completely wiped out. 2 years later, they took a critical look at that study and found that they included a lot of things in there that shouldn't have been included in there, like unplanned breech deliveries, preemie breech deliveries, breeches with congenital anomalies, and once they had corrected for those things, they found that, wait a minute, you know what? That isn't the way it should be.
Planned cesarean delivery is not associated with a reduction in risk of death or neurodevelopmental delay in children at 2 years of age. Elective cesarean section does not guarantee the improved outcome of the child, but may increase the risks for the mother compared to a vaginal delivery. The original term breech trial recommendations should be withdrawn. Dr. M. Glazerman, 2006.
Dr. Glazerman is a researcher from Israel, and he reanalyzed all of the data from the term breech trial. And he was among the first to come out and say, we made a mistake here.
To the American College of OBGYN's credit, in 2006, they revised that recommendation.
But by then, the damage was done. I don't think that anybody coming out of residency program has ever, certainly not done a breech, let alone seen a breech.
Cesarean delivery will be the preferred mode for most physicians because of diminishing expertise in vaginal breech delivery.
The case of breech, we need to take action yesterday, because the doctors who are left that can train new doctors, they're dying out.
I would have liked the option to deliver a vaginal birth with my baby. I could picture my birth. I've pictured this calm, low light environment, soft words and love in the room, and just this feeling of peace to welcome our baby. And my doctor wanted to schedule a C-section. My doctor said she had been trained in medical school to deliver breech, but no doctor would deliver a breech baby because of lawsuits and liability. It wasn't even a choice. It was, you have a breech baby, we're gonna do a C-section. I felt surreal, kind of was just on this table, and any second they were gonna pull my baby out, and I was able to hold the baby, but I didn't feel that connected to the baby at first. I think besides my body feeling numb, I felt numb to her. And I remember crying in the surgery after my husband left with a baby, and just kind of, the doctors are, talking about their day and going over, Laker scores or something, and I'm alone on this table. I felt very, just sad.
Ultimately, whatever a doctor feels, or whatever a hospital committee or administration feels, the decision really doesn't belong to them. It belongs to the individual patient.
The problem is that there's nobody that's going to get enough training to do vaginal breech deliveries in the modern world.
Eventually, people are going to be coming into the hospital breech, not knowing it, with a button of vagina, and no one's going to know what to do, and that's going to be a real tragedy.
Because I had the picture-perfect pregnancy, I also imagined the picture-perfect labor and delivery. My 34th week, I want to say, we found out that the baby was breeched, and that changed the whole plan. I was never offered the option of having a breech vaginal delivery. When we started timing my contractions, it was already 3 minutes apart. I got wheeled into the hospital. My water broke, and I started to get the urge to push.
Labor progressed so fast that the baby already started to emerge vaginally.
And that's when everything in the room started to get panicky. I just remember the nurse was closing my knees together and telling me not to push. I was getting really scared, and I told them I wanted my husband to be with me, and they said, no, because you're gonna be completely under. He's not allowed to come into the room. And before I could say anything, they just gassed me, and then I don't remember anything after that.
The infant was brought up to the level of the incision. The infant and both feet were delivered. The infant was handed off to the awaiting pediatricians.
It hurts. It hurts me because I don't have any memory of her birth.
She's standing more than sitting. Birth control is standing by if that's an option you need to go with, and the bed is prepared.
Sarah and Doug are severely limited in their choices solely because of this single study.
There are some risks, increased risks with breech deliveries. The risks are minimal if you follow certain tight protocols.
We'll have you do this a couple times with me examining you at the same time, which is not pleasant, but it'll be useful, okay?
I mean, we all know that planes fly safely most of the time, yet we only talk about planes that crash. It's the same thing here. When there's a tragedy in any birth, it's sad, but they can happen just as easily from cesarean section in the hospital as they can from a breech birth in the hospital or a breech birth at home for that matter.
My biggest beef right now in this country is that we are not, instead of teaching somebody the art of medicine, they're stopping it and say C-section. It's a no-brainer that this happens, but why are we turning a deaf ear and a blind eye to this important skill that needs to be engendered to give women choices?
Pregnancy has been great. No problems, no complications, other than apparently being breech. I really don't want to have a cesarean. If I have to do it, I'll do it. But I'm not going to just do it because that's what everyone does.
My position was always that if the patient wanted to do a vaginal breech, that we would consider it if everything was appropriate and if labor proceeded in a fairly simple fashion.
When I called him, I was like, great, there's somebody that does vaginal breech deliveries that has 40 years experience as an OB, that did 80 plus vaginal breech births, that supports women's right to choose. Wow, how exciting. And then I meet him and it's like, I'll do it, but I really don't want to because it's not of the norm and my community doesn't really support it.
Anxiety on the part of the practitioner as well as the patients, more than anything, is a driving force behind the idea that we don't do breeches very often anymore.
Are you anxious when you do them now?
Yes, I am. That's because I haven't done very many.
My confidence is lying within him as a practitioner, and knowing that he's had many successful vaginal breech deliveries and that I'm still of the mind and body to attempt it.
If there was a bad outcome, there would be a lot of scrutiny as to my care.
Yeah, insurance company, from hospitals, and make all these restrictions that make it difficult for good doctors who are capable of doing that, willing to do that, make it so difficult for them to want to do it.
So everyone is nervous and anxious, and I am aware of that, but I'm the one that's in this situation, so it's very challenging to just remain calm.
You have to have enough experience to do them to make yourself feel comfortable that they're not going to be dangerous. And I don't see how that's going to ever happen.
We need to have options in life, and the options need to be protected. In obstetrics, I think that should be something that we as a nation need to address, that we build a hospital or a center that more doctors can be trained and the skill can be passed on and done safely.
As many doctors as I asked, why is it unsafe? They couldn't really answer. You know, oh, it's this neck thing, it's the head coming out last, but why? And I wasn't getting a straight answer. I'm Marina Baccarin. I am 40 weeks today. This is my due date, actually, so I could pop at any second. It's been a stressful journey, and I feel like it didn't have to be, but because of the lack of options with my particular situation, which is a breech baby, it was a little harrowing. I asked my doctor if he would deliver a breech baby, and he immediately said, absolutely not, I'm not your person. I am not comfortable doing that. That's why the conversations were always about what can I do to change this situation versus what are my options to deliver a vaginal breech. The way he did it was close to an OR and with an epidural in, already ready to go, in case I went into labor or in case the baby was in distress and I needed to have a C-section.
In an ECV, a doctor attempts to externally rotate the fetus from a breech presentation to a cephalic or head-down position.
You're battling with, am I doing a medical intervention too soon where he'll be in trouble, and then if he needs to come out, it's too early. I was really stressed that I had to do something to him, to manipulate him, to make him turn. But it was my only option, I thought. I felt isolated, I felt crazy, I felt irresponsible, I felt really anxious. And when I stripped away why I was having that experience, it didn't come down to I was in trouble, my baby was in trouble, something was medically wrong with me. None of that was happening. The only reason why I was having a bad time was because I didn't have enough information or access to information or choices. Today is my due date. I met with Dr. Wu, I think a week ago. I was 39 weeks. For the first time I met with him. We came home that night and talked about our options. And what we kept coming back to was his success rate. He said that out of 10 women, only 1 ends up in a C-section. The rest have a vaginal breech delivery. I mean, I get goosebumps when I hear that because 1 in 3 women have a C-section in general. I want that C-section, but I don't. And I know now that I have an option. But when I show up and I'm in labor and I show up to the hospital, I know that I will have that option. And if everything is safe and everything goes well, I will have it. And if not, I will have a C-section. And I know I tried. When my water broke, I thought, okay, here we go. We're off to an adventure. The experience was a lot calmer than I expected. I mean, I remember walking into the hospital with my pants totally soaked from my water breaking and telling the nurses, My water broke, I'm breech, there was meconium, and having this sense of urgency, and they were like, okay, so I guess it's Dr. Wu that you're delivering with, we'll call him. And they brought me into a room and put him on a monitor, and he was fine, and everybody was very calm about the whole thing. It felt all so incredibly fast, from laboring to epidural to then going from there to pushing. We started pushing a little bit in the labor room, and that's when the foot came out first. I knew that he knew what he was doing. Obviously, I wouldn't have had him as my doctor, but he was so calm and so in control. As I was giving birth, and with every push, he was explaining, now I'm going to turn him, now this is happening, now the shoulder's coming out, it was really incredible. I still couldn't believe, as he was coming out and then as he was put on me, that I had done it, and it was safe, and he was fine, and it was better for him, and it was better for me, and it felt triumphant. It's important to me that people learn about breech options, because it doesn't have to be such a taboo. It doesn't have to be anxiety producing. It doesn't have to be a negative experience. It really truly is a miracle that little person came out of me, and especially the way he did. And
the skill level is being lost. Not too many people will do a vaginal birth any longer. So the experience of seeing one is not available. And if you're not available, how can you train anybody? So it's more like a dying art.
What I have a problem with sort of is the idea of skewed informed consent. And that's telling patients sort of information that's limited to get them to do what you want them to do.
My doctor gave me her whole story. How would she know any different? They don't teach breech birthing anymore. So I find out I have 3 weeks to churn my baby, and then I'm sitting in the doctor's office and I say, well, if I don't, I guess I'm giving birth to a breech baby. And my doctor looked at me and her face was like, no. I was just kind of stunned for a minute. It's like somebody takes a stun gun to you and you freeze, and you think 37 weeks is, beautiful, wonderful time, getting ready to have your baby. No, I had a lot of work to do. And if I wouldn't have figured it out in time and I did go into labor, I would have gone to the hospital and nobody would have helped me. I was kind of pushed into having the home experience, even though it was something I had always wanted. It was never something I planned on doing. When Joshua was born, that wasn't a triumphant moment for me. That was just magic and peace. I think it was a triumphant moment when I made the decision to do something I believed in.
When institutions do not think about women's choices, and they make it so much restrictions, and it makes it more difficult that no doctors want to learn and train, and the teachers who are still doing it are dying out. What will this nation become?
If you go against the community norm, you put yourself at great risk for liability. There's an enormous risk to you as the doctor, even if there's not much of a risk to your patient.
You can't expect people to come out in today's medical legal American world and be doing things that they don't really feel comfortable doing. One bad outcome, whether there's negligence or not, can end a career.
There's very little incentive for a doctor to offer vaginal breech delivery. If they schedule a C-section, they know exactly when it's going to be, exactly how long it'll take. The pay is a little bit higher, and the liability is a lot lower. The only reason I could think why a doctor would offer vaginal breech delivery is to meet the demands of their client.
You're okay. Deep, long breaths.
Your baby's right there, so you're not going to seem to take very long.
Find your body, push down. Good. Good, Sarah.
You want to touch your baby?
Oh my God.
Go ahead. That's her little butt.
Find your breath. Breathe down to your baby. Tell her it's safe. It's okay.
What I want you to do is feel the baby's head, which is right here. Just put a little pressure on the baby's head as it comes down. Okay, keep your legs back. Can someone grab your leg? There we go. And open your legs wide. Well done. Beautiful. Baby's peeing too. So
Good.
Okay, now stop for a second. Breathe. Breathe. Okay. Follow the way down.
Good, Sarah. Beautiful.
There we go. Open her up.
You're doing great, Aurora. You got it.
Forward. Okay, don't push anymore. Don't push right now.
You take your time. Hi, sweetie.
There you go. One shoulder.
Look at that little baby. There you go.
Other shoulder. Okay.
Good, Sarah. Here she comes.
Okay, sir, give me a little push now.
Nice and gentle.
Big push. Little push again. You got it. Okay, good. Ooh.
Oh, hey, sweetie. Hi, baby. Hi, baby.
Nicely done.
Beautiful. Baby. Oh, welcome, Aurora. This is so weird. Oh, you're so beautiful. Hi, Aurora. You came out your way.
This is a thing that is more common than my having red hair.
To know someone would have been trained and it would have been safe, you know, that I could have had a vaginal delivery would have been a great option for me.
As people who are in my vintage and perhaps 10 years younger get old and stop practice, there won't be anybody really willing to do vaginal breaches.
There are a lot of benefits and reasons why the birth process is the way it is. And when we bypass them, you lose a lot of the benefits, and the women know it.
Your baby's right there, so you're not going to seem to take very long.
Hi, sweetie.
He's kind of trying to grab her, kind of kicking her off.
I think for the healthy, normal woman with a healthy, normal pregnancy, that the natural process of birthing through the birth canal has got to make sense for both the mother and the baby.
I don't think a cesarean section is the demon or the devil. I'll be the first one to recommend it in certain circumstances. But that percentage is probably around 10%, maybe 15%.
Let's give the women more options, and we just need to train better doctors.
Can be a very safe practice if you know what you're doing. You just need the training.
I think that those of us that still have the ability to do these births should offer that to people.
As long as people are talking about it and researching it, I think that's the beginning of something really great.
Home births, breech births, may not be for everyone, but informed decision-making is.
Restore the choice. Visit www.informedpregnancy.com.
Okay. Well, I cried for the 111th time. I don't know, the music just moves me because I've seen it so many times, but thoughts, I know we had a thought back there early on in the film. Yeah. Yeah, well, I don't know if it was, I don't know if she said her midwife. Yeah, well, again, language has been abused and misused. You're talking, remember, this is 2011. Why they did a pelvic exam? Because they don't know how to do Leopold's, probably. Actually, this is a good question. I know her midwife was a CNM, which in our country is called a certified nurse midwife, so they go through nursing school first. So they're not the direct entry type of midwife. And I know her midwife. Her midwife's an excellent midwife, but because Sarah was breech, her midwife refused, once she was breeched, to continue care with her, even though I was on board. So I had to bring Beth in, who's the midwife that's in the video. So there's a fear factor and a licensing factor that goes on with them, and they're much more a medicalized form of midwife. I don't know if the midwife did the pelvic exam or referred it to a doctor who did a pelvic exam, but you're right. And you're going to see a lot of stuff. Why was she in lithotomy position? I'm sorry? No, yeah. You have to understand, they come from a world that's not yours. They come from a medicalized world. And why was she in lithotomy position? Because in 2011, that's how we did breeches. You know, every baby was born as I was training or in private practice in that position. The idea of a woman being upright was like, whoa, that's like not even was in the radar. So that's that. But that was about as smooth and as beautiful as a lithotomy position breech birth you can have with a woman who's just sort of like almost having an orgasmic birth, actually. I mean, she was smiling a lot through her birth, saying things like, this is awesome, and that sort of thing, yeah. Oh, yeah.
And then when the shoulders were out, even the head had to do the same thing. And it would make sense if, say, if she was in all fours.
Oh, of course it would.
It would make sense if she was in all fours that the baby, gravity-wise, the movement would be a lot
Right.
straightforward.
We're gonna talk a little bit about why people continue to do things when they know they're stupid. Right.
I'm not saying it's stupid.
Oh, it is stupid.
Like, there was an obstetrician at the Anglis that said, like, I feel so comfortable with that way, and I feel so strongly that I can safely help this breech baby come earthside if the woman's in lithotomy, that we had to respect that, because it was like we're then asking him to do something different. We have to respect it. And
Are you married? Are you married?
Pardon?
Are you married?
No.
Damn it. I mean, I love you. I love you. That's the nicest thing that anyone's ever said. We have to respect people who have differences, rather than. But
90% of babies were born breech with his way.
Yeah.
And women were so happy, and whilst I could see that it's kind of not really.
Yeah, Dr. Wu, who had a 90% success rate, every woman had an epidural, everyone was in a lithotomy position, everyone had an assisted breech, and every baby had Piper forceps. That's how he did his breeches. But that's how he did them, and there was no way he was going to change that. So it's very difficult for people who are doing something by habit in a certain way to get them to change it. I, quite frankly, am still more comfortable doing lithotomy breeches, even though I don't do them that way anymore. But if I ever have to do an intensive maneuver, like a breech extraction or anything, I'd rather turn the woman over so I have access to her belly. I have her bottom against the heart. Because again, remember, for 30 some years, that's how I did breeches. Yeah. And if you ride a bicycle a certain way and somebody says, oh, you're riding it the wrong way after you've been riding it 30 years, but it's been working for me for 30 years, why would I change the way I ride a bicycle? Yeah. So that's what that.
I mean, after Melanie's conference with what you showed me, I thought, if I have an undiagnosed breech birth in the next bit between then and now, I would actually ask the woman to be in all fours or kneeling, because I feel like, the gravity, blah, 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 blah. Then I thought, but I'm actually taking away her choice. She might actually want to stand or lie on her side or, whatever. But I thought, I feel confident doing it that way. And I think, how am I to turn around and bag somebody for doing something the way they feel confidently when they're offering women choice?
Yeah, and a woman may not be able to be on all fours. She may be tired. She theoretically could be an amputee. There's lots of things that you could have where she can't do that, which is why I bring two Sophies and why I teach both upright and lithotomy, because I think it's important to be able to do both. But thank you for that nice comment, though, about the other doctor, because he feels more comfortable doing that than again, it isn't necessarily always about his comfort, but it's a mutual relationship between that. And these things obviously should be discussed in the prenatal period of time. It shouldn't be the last minute. Did anyone have any thoughts about what can I just go through them real quickly and just give you like highlights? Okay, so Katie, she's laying on the table and the doctors are talking about Lakers scores. That really bothers me. The old saying that the baby is the candy and the mother's the wrapper. You ever heard that? I don't know if you've heard that, but it goes around, the midwives taught me that. Basically, once you eat the candy, what do you do with the wrapper? You just ignore it, throw it away. So, like in that scene where she's just laying on the table and they're talking about Lakers scores, she just feels sad. Should she be feeling sad at that moment? No, she just did the greatest thing of all time. The toughest one for me is Elizabeth's story, because had she been in a traffic jam for 10 minutes, she would have had a vaginal birth in the parking lot. Right? Instead, they have to push her baby back up inside and then pull it out by cesarean section. Of course, it still comes out breech. They still have to know how to do breech delivery, but they can do it through their hole instead of her natural hole. So it's one of the stupidest things. And again, I really shed a tear every time I hear her say, it hurts because I have no memory of his birth. Right. And then you have Aria, who my feeling is that Dr. Crane just got so cowed by the term breech trial and by what Cedars-Sinai was doing to him. They were picking on him mercilessly, because he had one of the busiest practices at Cedars, which was a private hospital. We're in the west side of Los Angeles. Most of the celebrities in Los Angeles go to Cedars-Sinai. Paul had most of the celebrities. Cedars-Sinai, I believe, my heart was jealous of him, and they made his life miserable many, many times, so they cowed him. And so I suspect that she had a complete breech. And he reached up inside, he felt a foot, and he just got really nervous because he taught me breech delivery. He's one of the guys that taught me breech prior to 2000. I had done breeches with him. And then when he says, I haven't done very many, and then you see the thing come, he's done more than 100. Well, what is very many? Right, and that would have been in like a 12-year period of time. He'd only done 2 breeches because Cedars made it. The ACOG first put out a policy, and then Cedars follows the policy. And then if you go outside the policy, then you put yourself at risk, as Elliot says. The only reason to do these things is to satisfy the need of your client, which of course is not a priority in the non-continuity of care system, because there's no relationship between, when doctors or nurses are working a shift, there's far less of a relationship than there is. Did you have another question?
I was just going to say, I had a breech baby, and...
You had a breech baby, did you say?
Yeah, I had a breech baby. My first was a breech, and Lisa was my midwife. But I had a... And Robbie. Lisa and Robbie were my midwives. But the obstetrician, so we had an obstetrician involved, and I was his first upright breech. We convinced him, and when I went into labour, he got his textbook out and turned it upside down. And he was really good about it, and we were so hopeful, right, that this would be the start of something amazing. And then, since then, he's had some bad outcomes, and he's just been like completely bullied into submission now. And
bought into the what? I'm sorry.
So he did my birth upright.
Yeah, and it went fine, right?
And completely fine. Okay. Yeah, my first baby was so much easier than my second head down baby, like worlds apart. Even though I had a hospital birth and a home birth. And then, and so since then he has basically just been, like, he had a couple of bad outcomes where like a baby ended up in special care and a second twin, I think it was, and then just a couple of other things have happened to him, and he's just been completely bullied into submission. Yeah. I heard that he even got called in and sat down, like, and said, you get back in the boys' club or you get out, sort of thing.
Yeah, I don't know any physician that practices like him or me or David Hayes or anybody else that hasn't been called in and bullied and stuff like that. And some people can stand up
to the point now where we sent a client to him, a home birth client of mine and Nikki, she's not here, who had a breech baby, for a consult, and he literally said to this woman, okay, so yeah, like if it gets stuck, don't worry, I'll just do a symphysectomy.
You'll just do what?
A symphysectomy. Like he's gone from that extreme of supporting me to have my baby upright to now saying shit like that to women. It's just like tragic. So anyway, she came back to us and we had a lovely breech home birth.
Right, but if the guy had a terrible outcome with a head down baby, they would not stop doing head down babies. They would not be, right. But we're gonna wait. When I break down the numbers for you, you're gonna see how common a bad outcome with a breech baby is compared to a head down baby, and you're gonna say, for that, we got rid of all breech babies. We're gonna go through all that sort of stuff. Marina Baccarin is obviously very eloquent when she speaks. She says some very great things in her talk. But one of the things that she said to me, which impressed me, was when you have a unit that's comfortable with breech, it makes all the difference. She came in, my water broke, I'm breached, there's meconium, and it was all very hectic. And she walks in and they go, oh, you're breech? Okay, you must be with Dr. Wu. All right, we'll call him. because they had a breech service there that Dr. Wu ran, and nurses were used to it. It was not a panic for them. But in another setting, I remember transferring a woman, she's like 39 years old, having her first baby. She was 10 centimeters for a really long time, and she never got past that. And after 8 or 10 or 9, 11 hours, we decided to go to the hospital. So I called and I spoke to the charge nurse and I said, I'm sending in so-and-so. She's 39 years old, gravida 1, para 0. She's at 39 weeks and 6 days. She's been ruptured for about 16 hours. Her GBS is negative. She's stuck at 10 centimeters. She's been that way for a while. Her baby is breech. All her labs are normal. Her vital signs are stable. The baby's heart rate is great. And we're just coming in because we know we need a C-section because exhausted and she's ready to have a C-section. And for breech, we didn't have another option. It wasn't like she was going to get an epidural and pit like you might with a head-down baby. And I gave a full report very calmly, and the nurse only heard one word out of my mouth, the word breech. And she panicked on the phone. And I said, the baby's not going to fall out. We've been here 11 hours. The baby's not coming out. Baby's not going to come out. You're just going to do a C-section on her. And she said, put me on hold, and then she got the doctor on the phone. And the doctor, obviously, before the doctor got on the phone, the nurse freaked the doctor out. This guy's got a breech in labor, and then the doctor was pissed off. And I said, calm down. Calm down. They're just going to come in. She's just coming in for a C-section. And they got so agitated because all they could hear was the word breech. And then Kimberly says, a couple things. First of all, she steals some of my lines, by the way, the red hair line and the breech birth, home birth may not be for everybody, but informed, that's my line too. But Kimberly has been a great client. She went on to have one baby in the hospital, and then she had Joshua, the breech, and then she ended up having 4 more home births, so she's got 6 kids. But she says, the doctor didn't give her any choices. The doctor looked stunned when she said, I'm going to have a breech baby. And then she says, if I hadn't done my homework, I would have gone to the hospital and no one would have helped me. And that's a common thing. And then, of course, Sarah and Doug, you saw. And the side-by-side, I think, is very powerful. I think it shows it's a normal C-section. Happened to be a head-down baby because we didn't have footage of a breech C-section. But that was a fairly normal C-section. And we showed that at Kaiser Permanente, which is a big hospital system down in Southern California. We did a talk to the residents about breech birth. And the residents thought the documentary, that side-by-side was great. You know who didn't like it? Was the attending physicians. The attending physicians at Kaiser thought it was gratuitous. They thought, well, that's not the way it really is. I go, yeah, that's exactly the way it is. There's a huge difference between how a baby's born to parents at home. We're listening to the baby's lungs on mom's chest. We're not over the warmer. The mom's not, is that my baby sounds? Is that my baby crying? That sort of thing. They don't get it. So I hope that sets the stage for what we're going to do in the next 2 days. Any other questions or comments about that? Yeah.
I just want to touch base when in the...
Do you want to use the mic? Or are we Hang on. Just for the people at home, yeah.
Just with the pressure on the baby's head, is that for flexion?
Well, the thing that I was having to do with her hand?
Yeah.
Oh, we don't do that anymore.
Right.
It was another stupid thing. We're going to try to keep the baby's head flexed as it comes down. Again, you have to realize that I had no other training than what I was trained at LA County USC Women's Hospital. So I was still doing breeches for a long time until I started to go to some of the breech conferences in Bethesda and Ottawa and Amsterdam, where finally Frank Lewin and Anka Ritter and stuff started presenting their upright breech papers and things like that. And then I began to realize that a lot of the stuff that I did was archaic. So there was no reason to do that. Yeah, there was no reason to do that. And the other thing too, when I made a comment because I can't stand that I said that, but all things being equal, breech babies should be born in a hospital. Right? Because they'll never be equal. The success rates of a hospital breech program will never be the same as a home breech program. Right? Did you have a question too?
I'm just wondering if when you were practicing, you recommended ECV as a first line option, and if you did that yourself.
I'm going to go, this afternoon when I talk about breech, I'm going to talk about ECV. So I'm going to save that question for then, and I'll look at you when we do that. We'll talk about what I think my indications for an ECV should be. Right.
So I had to look back. It was 2013 I came to the, it was called Into the Breech conference here, and Anka Reiter did present then from Frankfurt, and all her upright MRIs that she had showing just the increased capacity of the pelvis anyway.
Yeah.
They were pretty amazing.
Yeah, that was 2013. Yeah, see, I hadn't even exposed to it yet.
Yeah.
Right.
So at that time, I think it was Michelle Underwood was the Heads Up clinic at Westmead.
Oh, yeah.
And Andrew Bissett's. So they were talking at that stage that they were very hopeful in New South Wales that it would be a roll-on effect, and Andrew Bissett's and is it Andrew Pesce would upskill that generation of registrars for breech. And then I was talking to a midwife from Sydney at the conference, and she said he's almost done because he hasn't got the support to keep up training
the current.
Yeah, he's
registrars
trying.
and
I mean, he's trying.
consultants.
I've known Andrew for many years from the conferences, and I actually got to. We were supposed to have lunch, but he was stuck with a breech in labor, so he couldn't leave the hospital. So Joe Sutton from Birth Time film, she took me over there, and we ended up sitting in his office for about 45 minutes, just chatting. And he, it's very frustrating because I think I told about this last night. There was a hospital in LA that was totally willing to do a breech program. The head of the hospital was on board. The chairman of OB was on board. We had 3 OBs at the hospital were on board. I came and given in-service. The nurses were on board. And somebody from corporate back in Connecticut just said, no, we're not doing it. And the whole thing got squashed, right? Because they look at it from a financial liability point of view, not as a human right or what women want to have. And one more question. You're just holding the mic. Oh, okay. All right, so let's move on because, again, we're going to be here late. We might have to move the dinner reservation. Okay, let me see. Okay, are we good? Okay. So I call this Breech the Other Way Babies Come Out, and it was just to talk about why we are in the mess we're in, and I go off on tangents, but this is what I do, and I hope that you guys find this to be well received as well. I love memes. I love wise people. Everybody knows who Oppenheimer is now. Probably didn't before Christopher Nolan made a movie about him, but some of you might have. But he sort of was the architect of the atomic bomb, so sort of famous and infamous at the same time. But he talks about challenging in science. There is no science if you can't ask questions. So we've all gone through a period of time in the last 3-4 years where we've seen that asking questions can get you deregistered and kicked off staff and even jailed in some countries. There's no place for dogma in science. The scientist is free and must be free to ask any question, to doubt any assertion, to seek any evidence, to correct any errors. Our political life is also predicated on openness. We know that the only way to avoid error is to detect it, and the only way to detect it is to be free to inquire. So when you talk to colleagues at hospitals or doctors who are comfortable or confident in their position will be happy to talk to you. They won't shut you down. Doctors who are insecure will shut you down. So it's a tell. You know right away if someone's bullshitting you because they won't discuss it. All right, so what I'd like to, this whole thing, I don't know if it was in college or whatever, about giving a talk, you're supposed to tell people what you're going to tell them, and then tell them what you told them. Any of you guys know that, but I don't really do that, but I did have objectives because sometimes when I do a seminar and to get CEUs or to get CMEs for credit for the nurses or the doctors, we have to have an objectives thing. So I just want to say that I hope after this session you'll have an understanding of why many of our colleagues see breech so differently, better understand how facilitating physiologic birth improves outcomes, better counsel future clients about options using best practices data and not fear, understand some obstacles in changing the current medical model to a midwifery model, have a better respect for autonomy and decision making. I don't think I have to tell you, I know that I'm preaching to the choir here, and I said that to I don't remember if it was Mayette or somebody else who said, you're not preaching to the choir, you're reinforcing what the choir needs to hear, all right? Because we often are alone. When we gather together, there's strength in us. When we're alone, we're easily cowed, as poor Dr. Crane was cowed. Clarify the ethical implications of supporting breech and twin vaginal birthing, and we'll think out of the box. Okay, so obviously mammals and how we give birth. My very first lecture when I started on this path, I titled it, Home Birth is Not Just for Hippies, What Mammals Know and We've Forgotten. And that set me on a path to really dig deep and dive into not the physiology like Sarah Buckley knows how to, I don't care about that stuff. I'm not an academician, I'm a clinician, and I'm a very practical thing. So I don't like doing detailed research and stuff like that. But very simply, I've watched dogs give birth, I've seen cows give birth, I've watched lambs give birth. They generally, all mammals, I've seen animals in the wild, you know, sort of giving birth, even on National Geographic specials on television or whatever, and they go off by themselves to a place where they feel safe. That's how best it works. So, optimal mammalian birth is quiet, safe, and unobserved. We're able to move about, walk, lie down, and rest. Surprisingly, we have to remind our colleagues, many of our colleagues in the hospital, you guys are doing better at this than we are, but they're able to drink if they're thirsty. Oh my God, what a novel idea. You know, not NPO or not ice chips only. And then of course this one is amazing. They're hungry, they can eat. A mammal, if your dog was in labor, you would never take away its bowl of food. You wouldn't do that. If it wants to eat, you let the mammal eat. In my country, you guys aren't doing this anymore, but in my country, many hospitals still don't allow anything but clear liquids. And a woman could be in labor for 22 hours and she's getting a popsicle every now and then. You guys call them popsicles here, by the way? What? Icy poles? Okay, icy poles, right, great. Okay, undisturbed, so that's clearly quiet, safe, and unobserved. It's a primitive brain function, we'll talk about that in the next slide. But you have to stay in your primitive brain. It's not sterile, oh my God. It's not sterile. You don't need to wash off a woman's vulva with betadine. You don't need to put I mean, you guys don't do this anymore, but in many hospitals in my country, they're still putting blue drapes on her legs up in stirrups to cover, as if they're about to take out her gallbladder or something. This is how they look at birth. Mammals are never separated from their young. Not on purpose anyway. You know, that's not happening. You know, Bliss likes to say two things. She likes to say, you know, try taking a chimpanzee away from its mother and see what happens to you. And when was the last time a tiger got checked at 7 centimeters? Okay, yeah, that stuff. Uninterrupted bonding time. By the way, if you don't know who Bliss is, she's my co-host on the podcast. Okay. Oh, and today, well, today in the United States is her birthday. It was yesterday for us, but it was today now for her. Right? And I don't know how old she is, and I don't ask. Bonding time is not interrupted. We don't need an hour of golden hour and then the baby has to go to the nursery, that kind of stuff. You never would do that. So simply what's wrong in these pictures, some of the, I mean, again, I'm dating myself a little bit, but I still like for people to recognize this. This is why I would love to be talking to a room full of OB residents, because they would have a harder time with the answers to these questions. But obviously pre-COVID, it's a waiting room. But even if you're having a home birth and the woman knows there's 6 family members downstairs in the kitchen, it's not a good idea. She knows they're there. It's going to bring her out of her primitive brain into her cognitive brain. So these people should all go out for pizza, go to a movie, or go home. Obvious, strapping a woman down on her back with CTG, which is useless, except for, I guess, is it Hazel? No, Kirsten. Kirsten is the CTG. But she says that I think the only indication where it actually shows any evidence is if you're inducing a baby for growth restriction or something like that. Isn't that the one she said? Well, if the woman wants it. Yeah. All right. The only reason a woman would want it is because she's been convinced that it's going to do some good, because it doesn't do any good. But anyway, you're immobilizing her, and you're making the bed the center of attention. This one is summarizes just about everything in labor, in the hospital-based model. You've been doing it for too long, you're going too long, we need to do something, we need to interfere, we need to do that kind of stuff. And then of course this one has got everything that's wrong with it, which is a classic, this is a classic birth still in the United States in a vaginal delivery where the woman is in stirrups, she's covered in the blue drapes, everybody's wearing a hazmat suit as if this is an infectious disease, and the baby's cord is now severed, and the doctor is posing with the baby for a picture as opposed to giving the baby to its mother. Right. So what's wrong in these pictures? Pretty much everything. From the moment we leave our nest to drive to the hospital until the moment we put our baby in the car seat to drive home, pretty much everything that is done in the medical model is antithetical to nature's design in America, and probably here too, because you're taking people out of their natural habitat and doing that. You've all seen the Monty Python sketch. If you haven't, you need to really find it. I mean, there's so many good lines in that sketch, but one of my favorites is the woman at the end. She says, "Doctor, I think the baby's coming, what do I do?" And John Cleese says, "Nothing, dear, you're not qualified." Right, right. And by the way, they wrote that in the 1970s. I think some of those guys were medical students, from what I remember. You're nodding, so you know that that's a fact. Yeah, I think they were medical students. And they just were, because of even their political statements stuff, were fairly visionary for 1970, mid-1970s. It's not actually from the moment you put the baby in the car seat, it's actually from the moment of the first prenatal visit, actually. So what happens in the hospital medicalized model of obstetrics? You guys know this. US versus Australia, I've learned a lot from doing these seminars, that you guys do some things a bit differently. So let's go through them. But first of all, the medical model sees pregnancy as illness, not wellness. And they see it as something that needs to be managed and controlled. Doctors sort of don't like nature's chaos, so they'll intervene and create their own chaos, but they're happy with their own chaos because it's their chaos, it's their mess, and they're comfortable with it. They're just not comfortable with the uncertainties of nature, whereas midwives have taught me that it's a natural function of a woman's body that occasionally goes awry. They're willing to accept uncertainty for the sake of honoring the fact that nature has a design and there's importance to it. In the antepartum period of time, you're already grooming a woman to be nervous. You're planting seeds of doubt. You're stuffing her with cortisol and stress hormones, telling her at a very first visit that, you know, you're 35, so we've got this, your placenta is probably going to give out, you know, your husband is too tall, you're too small, your hips are too narrow. They just throw these things out there. And it gets to the whole idea, if you've seen the movie Inception, most of you probably, hopefully have seen it, it's another good movie. I refer to them a lot because these analogies make sense. But there's a scene in the early part of the movie where they're trying to convince the antagonist, which is played by Cillian Murphy, the guy that plays Oppenheimer, by the way, same guy. And they're trying to say, how can we get this idea into his head? And one of the guys says, well, why can't we just suggest it to him? And they say, well, he'll know where it comes from. Well, what do you mean? And then the guy says, well, don't think about elephants. Okay. How do you not think about elephants? So don't think about the fact that your hips are small and your husband's too tall and you're over 35, but I'm just going to tell you about them anyway. And then what happens in my country, when you go into labor, you have to, obviously your country too, you have to get in the car and drive to the hospital. In my country, you enter the emergency triage area. I know some of these things are different for you. You don't make people pee in a cup. You don't make people change into a hospital gown. But in my country, they still do. Why do they do that, by the way, in my country? Any idea why they have them pee in a cup and put them in a hospital gown? It's what? Yeah, well, I think the hospital gown is totally disempowerment. Pee in a cup, by the way, is my estimation is they're not preeclamptic. They can't. You know, do they want to drug test the mother without her knowledge? That sort of thing, maybe. But part of it is that they do these things because they can charge for them. And that's why they do them. And there's a fee for giving her a gown. You can charge a laundry fee. Jim Gaffigan, the comedian, if you've heard him, you know who Jim Gaffigan is, some of you maybe? He's a comedian. He's had 5 home births. His wife has had 5 home births. He's been there. Let's be accurate. He tells a story about the hospital gown, and he says, why would I want my wife to wear a hospital gown that someone died in yesterday? Right. So why can't they wear their own jammies? Well, it is sort of you put a hospital gown on, you now become a patient because you got a hospital gown on. And you're treated as a patient with an illness. So this is something about, do you have any other medical problems? This is something that I realized that I was been doing for 30-some years before one of my new consults called me on it. When you take a history, if you've learned how to take a history, there's a chief complaint and you ask questions about that. And then you ask about meds and allergies. Then you ask about past medical history, past surgical history, family history, review of systems. That's sort of how we all, I'm assuming we all learned to take history that way. So when a woman would come to see me for her pregnancy, I would ask her the questions about her pregnancy, and they were just normal. They were maybe a breech consult, maybe just a regular head down baby coming in to see if they want me to be involved in their care. And I would get to past medical history and I would say, do you have any other medical problems? Which would just roll off my tongue. Finally, after all these years, one woman looked at me and she goes, what's the first one? And then I realized that even me was thinking that, you know, the forms I used have a problem list category. So I began crossing off the word problem and put diagnosis list, but it's still a problem list. And I was trained, and all doctors are trained to believe that pregnancy is the first problem. And so when you see that, you can start to see the prism by which they're looking through. That's what they're seeing. In my country, you're not pre-admitted in a lot of hospitals. Sometimes they are, but even when they come in and they're pre-admitted, they still have to sign consent forms that talk about surgery and power of attorney and death and what would you do if you went into a coma, and they have to sign these papers while they're in labor. That's not going to bring you out of your primitive brain, right? And then they ask them a laundry list of questions about piercings and pacemakers and what did grandma die from or how many steps do you have in your house, all while you're contracting every 3 minutes. And then I realized when I was still working in the hospital that this questionnaire is the same questionnaire they'd ask that you fill out if you came in with a gunshot wound or a broken leg. It's the same questionnaire. And you can't get your wristband until you fill out the questionnaire. And without a wristband, we can't do anything else to you, so you have to fill out the questionnaire first. But you're contracting every 3 minutes and you're not sick. But they don't look at you that way. We already talked about this. But the key is that the bed becomes center stage in the hospital labor room. When you go to a woman's house and she's in labor, and it's time for you to show up, how often is she in her bed? Almost never. Almost never. But in the hospital, they're expected to be in a bed. We have routine, and you guys don't do this, but we have a routine blood draw when they come in. They check a CBC, and they often send off a blood clot to the blood bank for type and screening to have it just in case. And they put a blood pressure cuff on her arm, which is fine to take a blood pressure on admission. But if you have a normal blood pressure on admission and you don't get an epidural, which can drop it sometimes, how often does your blood pressure actually become pathologic in labor? Hardly ever. Yet hospitals will have a kind of a protocol that says in early labor, you need a blood pressure every 2 hours, and then in active labor more often. And if she has an epidural, you have to do it every 5 minutes for the first 15 minutes, and then, you know, and you have to do that. So the blood pressure cuff is sitting on her arm, and often they leave it on the arm. And the machine just goes in the middle of something and starts to blow up. Blood draws are interesting. They send blood to the lab, not because there's a reason to do it, but because of the long habit of just doing it and because they can bill for it. They're going to argue that it's for safety, that, well, we have a clot in the blood bank in case she needs a transfusion. But how many women need a transfusion? And also, what do you do with all the women that come in, or the people that come in with a car accident, or in my country, a gunshot wound or something? You just type and cross them right away, or you just give them O-negative blood. They don't have blood clots sitting there. But if you can charge for that blood clot, and it's a couple $100 to do a type and screen on these women, and it's done, and it's routinely done. That's a good question. I don't know. Yeah, well, wait till we talk about C-sections. But you're right. Why don't they do that? I don't know. I think it's because they negotiate a price with the hospital, and no matter what the hospital bills for, sometimes the insurance company is only going to pay this much anyway. But then often the patient gets balance billed in my country. So it's a weird thing for me, and everything's inflated. You know, you've heard the joke about the $85 aspirin. Maybe you haven't, but you know, if you ever look at a hospital bill from the United States, you look at what they charge for certain things, and I didn't know they could charge for the fact that they brought me my baby. Yeah, baby from nursery to, you can put a charge for that in. So, I don't know, I don't know. Obviously, disempowerment we already talked about. Often they're not allowed to walk freely, change positions. Water birth in most hospitals in my country is not accessible. They can get in the shower, but they discourage you from getting in the shower. So that's why you should be in the shower the entire labor. We've talked about that. They can, you're frequently interrupted for protocol dictated procedures like blood pressure. But one of the other things that happens in the shift model of medicine is that you come in there, you're a little nervous, you don't know the people, you've been there now 7 hours, you really get comfortable with the nurse that's taking care of you. 7 p.m. rolls around, 7 a.m. rolls around, the change of shift, now you've got a new face and a new name. And you have to get used to that. It's just, everything that they're doing is antithetical to nature's design. We already talked about that too. So, any of those things on the list, are they done for the benefit of the mother? Let's go back and look at that. Tell me any one of those things that's done for the benefit of the laboring woman. As a routine. Obviously, sometimes it's necessary. But this is a routine in my country when you go to the hospital. Not one of these things is done for them. So, ask yourself the question, if not, then why are they done? Anybody have a thought? I'll tell you why they're done. Okay, so they're done either to err on the side of caution, which is a phrase that this past year has become very meaningful to me. I sort of took it apart and realized that what it means is to make a mistake, to be cautious. That's what it means. And to generate revenue, or just habit. Like me having Beth put her hand on the head to try to flex the head in labor. I just did it. Didn't really think about it. Didn't really think about why is lithotomy the best position. Didn't really think for years about why a baby going to the warmer was not okay. Just did it because that's the habit. So Thomas Paine has a quote that said, Thomas Paine is one of our founding scribes. He wrote a pamphlet during the Revolutionary War time called Common Sense. He was the original writer of a pamphlet called Common Sense. And he said the long habit of not thinking a thing wrong gives it the superficial appearance of being right. And that's true in our own lives. Pretty much, if we've been doing something a certain way, we're very reluctant to necessarily change it. And what happens is when someone makes us want to change it, first we make a big tumult, but ultimately time makes more converts than reason, and things will eventually come around. And that's why I'm sort of certain that the system that exists now cannot stand forever because it's failing, and it will take a long time to change, but it will eventually collapse because it has to. Oops. So interrupted labor, the mechanism, you guys all know this. I'm not sure that many doctors know this, or certainly don't think about it on a day-to-day basis. But labor and growing and delivering a baby is all a primitive brain function. Women in a coma can get pregnant, believe it or not. They can grow a baby and they can go into labor. They'll often go prematurely, and they can't push actively because that's active, but they can go into labor and they can get to completely dilated. How do I know that? Because I was a resident, I took care of 2 women. One had HIV, like terminal HIV, and the other one had Guillain-Barré syndrome that was completely paralyzed. And they both went into preterm labor. One of the babies didn't make it, the HIV baby didn't make it. They were both delivered by vacuum. They got to complete on their own. So that's nature's design. It's a normal function. And when you interrupt that design, you can potentially cause it to malfunction or go awry. An example of that would be the fact that, fortunately, like labor, and breathing and digestion are 2 bodily functions that we don't have to think about. Can you imagine if we did? To tell your stomach to digest your food and to remind yourself to breathe every 3 seconds or so? Breathe in, breathe out. You wouldn't have to do that. But if you have to go to court, if you have to give a speech, you might start to hyperventilate. Or you might get diarrhea. That's your cortical brain screwing up your primitive brain's function. That's what happens when a mammal needs to feel safe, and when a predator approaches, when a forest fire is in the area, when little kids run into the bedroom and the cat is laboring in the closet. They're going to stop contracting. They're going to secrete adrenaline, which stops contractions. They're going to get up and they're going to run. That's what they're going to do. So we take women from the place that they feel safest, which is their bedroom and their bathroom at home, and then we make them get in a car and do all those things we just talked about. And we wonder why a woman who's contracting every 3 minutes when she calls her doctor gets to the hospital, and after all that, they put her on the monitor and her contractions are 7 minutes apart. And actually people can't figure that out. You guys can, but people can't. So only when it's once again safe does labor return. It would make no sense for a mother to give birth when danger is near. Nature in this way ensures optimal survival rates. We have been screwing with that for a way too long a period of time. So these next 3 little paragraphs are, I put them together after a lot of thought, and I just want to go through them with you. Childbirth is a complex physiologic process honed over hundreds of thousands of years. If you talk to Sarah Buckley, it's 64 million years, but it's honed over a long period of time. We still understand little about the mysteries that determine the course of pregnancy, labor, and birth. One of the interesting things I had with my conversation with Sarah was about whether oxytocin crosses the placenta, and she says it doesn't necessarily cross in significant amounts. But we talked about the fact that mothers and babies are communicating, and if they're not communicating hormonally, how are they communicating? And she says, and we both agreed that we have intuition. Sometimes you know when your kid, you feel it inside. There's a way of communicating that we just don't understand right now. And I think that goes on, and when that gets interrupted, we don't take that into consideration. And when we disrupt that, what are we actually doing? But nobody's thinking about it because we don't understand it. So then I said this: interfering with these processes without fully understanding the short and long-term consequences is, as a mild word, inadvisable. There's better words, there's stronger words than that. And then lastly, for any attempted intervention into the normal physiologic process, normal being what nature would have done if you wouldn't have done anything to her, the burden of proof rests upon the intervention. It's not for the people who want to intervene to say nature is dangerous and I'm going to fix it, like giving vitamin K to babies who are born vitamin K deficient. My colleagues don't ask the question, why are babies born vitamin K deficient? If vitamin K is so important, why didn't nature over hundreds of thousands of years figure out a way to get vitamin K to cross the placenta? And all of you now, vitamin K has become very much more in our awareness, and people are asking the question. If the incidence of vitamin K, it used to be called hemorrhagic disease of the newborn, and I think they changed the name to make it seem like we need to give vitamin K. They changed it to vitamin K deficiency bleeding. But the incidence of that is somewhere between 1 in 10 and 1 in 16,000. So why don't we try to figure out what's wrong with that 1 out of 16,000 babies instead of giving vitamin K to 15,999 babies who nature decided shouldn't have it. But we don't. But we really should. And we can extrapolate that to so many things we're doing in pregnancy, and we'll talk about them in a minute, of things over time that we've done to pregnant women where we really haven't thought about it. Come to that later. So what do women want? Wisdom. What wisdom can you find that is greater than kindness? I think we really want that. Our women want that. And then this was written by Thorpe Biesenbeck in 1998. I'll just let you read it because I think it sums things up fairly nicely. So ultimately, the decision needs to belong to the informed woman. And when you don't inform women, then you're violating our ethical obligation to give them autonomy and decision making. And that is where the medical community is now. Because I look at the things that you do in labor and delivery, and you do things that are much more normal than my country does, and yet your statistics are worse than my country, which is really hard for me to quite figure out. Because the populations are similar. You have a fairly heavy indigent population, you have some obesity issues. We do too. We have a lot of indigent population, we have a lot of Native Americans, we have a lot of Latinos that are overweight, and yet, so it's not that different. And yet our numbers suck. Yours just suck worse, right? Right. Okay. So where has the US medical model taken us? So I want to talk about this, and then I'm going to go through your Victoria stats, because Little Bundleborth put them on Instagram, and I was sort of blown away by some of them, and I think they're worth talking about. But let's look at the US model. This applies to Australia too. All right, 1920, there were 90% of babies were born at home. By 1950, more than 90% of babies were born in the hospital. And now in your country, I hear it's 0.5% of women are having babies at home. So 99.5% are having them in the hospital or on the highway on the way to the hospital, but they're having that at home. Yeah. What is it, 107? What?
107 is born before arrival.
Oh, that's like a code? Oh. Yeah. Yeah. Again, I'm sorry I don't understand some of the terminology, and part of the way I don't hear that well, so sometimes when I might have to just ask you to say something or stand up and repeat it. So don't get mad at me for doing that. It's just, you know, my heart and my mind want to work really good, and my body just says, slow down. Okay. So why is that happening? And you know, we could look at the history of that in my country, and the history basically is because in the 1920s, John D. Rockefeller, and I mean, there's more to it than this, but the main story is that John D. Rockefeller, who was an oil magnate, wanted to sort of take over the medical industry. He hired a guy named Flexner who put out a report that said anybody doing any sort of medical thing that wasn't licensed or wasn't going through a didactic medical school that was approved by such and such an organization could no longer, should be ostracized and ridiculed. And so they got rid of naturopaths. They got rid of homeopathy. They certainly vilified midwives. They went on a campaign to vilify midwives and to advertise to the American population that home birth was archaic and no civilized person would do a home birth, when you could go to the hospital and have this beautiful aluminum tiled room that you could have your baby in, instead of, you know, showing a farm with a midwife who's got a wart on her nose and wearing a scarf and doesn't shave her armpits, and she's the midwife. Why would you want to go to that? They actually did that sort of stuff. So we now have greater than 3 generations of my country and in your country who have no experience with natural birthing. They just don't. They don't see it in movies. They don't see it in television. They have been brainwashed to believe that birth is dramatic and scary. Doctors have been brainwashed horribly, and then they project their fear onwards. So I think that I know that to be true, because as I spoke last night, I said, you know, I have the good fortune of occasionally taking care of women in the Amish community in my country, and they have almost no fear of birth whatsoever, right? And they probably know people that have bled to death or died in childbirth, but they consider it a part of their natural life cycle and a rite of passage. Women have been indoctrinated to fear birth and abdicated its process to doctors, and we obviously project it forward. That's why the doctor at the first prenatal visit is pouring on the fear. I don't even think they know what they're doing. They think they're doing a good service by scaring women into that. Don't think about elephants model. C-section rate in 1970, as you saw in the film, was around 5 to 6%. I believe that it was the same in Australia. Now, our C-section rate is about 32% and rising. Your C-section rate, I know in Victoria, was 39%. And I know that C-section rates, I was speaking to a guy in South Africa who was his wife wanted a home birth. And his C-section, the C-section rate I told him was 70%. He said, no, it's closer to 80% now. And of course, she went into labor at home, and she ended up having some D cells and ended up with a C-section. The C-section rate in Armenia is 70%, where home birth is illegal. Brazil, it's over 70%. Who in their right mind can think that 7 out of 10 women can't give birth as nature designed? And who thinks this is a good idea? And yet, no one's saying, the thing about the insurance companies, it's like, no one is saying, like, we're paying for unnecessary surgeries. I'll have an example about that when we get to the cognitive dissonance argument. But so the C-section rate has gone up 500% with no statistical difference in cerebral palsy or HIE. So what have we done? More than 30% of women in my country have labor induced. It's higher here. The United States spends more per capita on healthcare than any other country. We're 45th in the world in neonatal mortality or morbidity. That's shameful. I'm sorry? Well, $300 for an aspirin, yeah, right. That's partly true. No, I mean, it's crazy that we consider ourselves a first world country, and there are many third world countries that have better outcomes than we do. So what happened to our ability to birth as nature intended in just over a generation? Now this guy, Thomas Sowell, is not a medical person whatsoever. Thomas Sowell is one of my heroes. He's an economist. He's in his late 80s or early 90s now, so he's really not in the limelight anymore. But he has some very wise things to say, and if you ever have any time and you're not doing anything, which I know none of you have, but if you go to YouTube and you watch some of the interviews that Tom Sowell gives, he's very, very wise economist, talks about the economy and common sense and socialism and other things like that. And he says it's usually futile to try to talk facts and analysis to people who are enjoying a sense of moral superiority in their ignorance. So trying to convince people that are arranging deck chairs on the Titanic, which is really what's happening in the medical community, that they maybe want to take a different course is really hard because they sense a moral superiority in them, and they will then sit with their lousy stats, and they'll sit in judgment of how you guys practice. How about Australia and Victoria? So Little Bundle Birth put this out, and I took it, and I just tried to highlight some things. But what's interesting about Victoria is you guys have changed the human species. Because the human species normally has a gestational time of 266 days. If you add 2 weeks in there, that makes it 40 weeks. You guys have now changed it to 38 and a half weeks. How have you done that? What's going on here in the state of Victoria? All right? So obviously we know that that's ridiculous, but that's because they're inducing people way beyond what's normal. But suddenly the average gestational age in your state was 38 weeks and 5 days. How the hell did that happen? What's that?
Stats anymore for most of the outcomes for the mother-baby report. So it's because they're inducing everyone.
Yeah.
But you don't even know what the real stats are for anything. I think C-section, they look at all women, but all the other stats where they're looking at episiotomy rates and all of that, it's only for selected women, which was 26% of the total population. So we don't even know what's happening with 75%.
And a lot of that population is epiduralized.
Yeah.
And augmented.
Right. Yeah, induction rate in that group was 40%. And that's of the 25%, which are the low-risk women. So
yeah.
God
I just find it like just incredible because people say, well, 40 weeks isn't right. Primaps actually go longer than 40 weeks and stuff. Mm-hmm. Actually, they don't. I've looked at my numbers over my entire career. And my breech babies, the average breech mom, because I don't induce hardly ever, especially now in the home birth setting, but my average breech mom went to 39 weeks and 6 days, and my average head mount mom went to 40 weeks in 1 day. Mm. And that's if you do nothing. And the range would be for me like 35 to 43 weeks because I have a huge range. But the mean was actually 40 weeks, which is kind of cool because that's what we're taught. So it's one of those things that seem to still apply. This one, I just highlighted a couple things here. One is the top reason for induction. Now usually other is there's this, and then there's other, which is a small percentage. Here you have not classified as 24%. So does that mean that we don't know why, or that means that they didn't have a box that they could fill out and it was really for no reason whatsoever other than the ARRIVE trial or something like that? I don't know. But if your state's gonna gather data, they should probably gather data and not leave it like unknown. And then less than 40% of women in Victoria started labor spontaneously. The rest either were induced or had scheduled Caesars. So again, going back to that paragraph where I said, if we're going to intervene in labor, we have to know that the intervention is safe before we meddle with Mother Nature. They completely ignore that stuff. This is crazy. By the way, that's the last little bundle birth. I met her at the Convergence. I think she was there. So only 45.9% of the women in Victoria had a vaginal birth that wasn't instrumented. So less than half. You had a 39% cesarean rate. That's not good. Okay. You had an episiotomy rate of 30.2 because I've now learned all about your perineal bundle, which you guys are calling perineal bungle, right? Which doesn't make any sense to me. We're going to cut all women to avoid a small percentage who might get a 4th degree. That's like, let's give hepatitis vaccine to all babies because one baby in a million might get hepatitis. Or the vitamin K example I give you. But this is a serious, well, so is giving vitamin K or hepatitis vaccine, but this is what I did in 1980 as a 3rd-year medical student. We cut episiotomies in all women. They had 30% episiotomy rate. I bet you that if I ask you guys, in the last 10 years, how many episiotomies have any of us in this room done cumulatively? There's probably less than 10. Right? How many of you have done an episiotomy ever? How many of you have done more than 10 episiotomies in your career? You have. I have, for sure. Yeah. Okay. 1 in 34 years. And why? Tell us why. No. Tell us why you did the one.
Oh, so the one that I did
Yeah.
was way back when I was a student working with a senior midwife, and just thought
Yeah.
had to be done at the time.
Right. You did it because it's what you were taught to do, and then you realize that there's really. But if I was still in the medical model, and I had never got exposed to midwives, then if I saw a perineum that was tight over a baby's head, my doctor colleagues are still cutting episiotomy. Not at that rate, but they're still cutting episiotomy. That's a crazy number. And then, let's see, then and then I asked about this VBAC rate, and I said, is that the percent that attempt a VBAC? Or is that, of those that attempt a VBAC, that's the success rate? And that's what people told me. Is that true? 13.1% of the people who attempt a VBAC here are successful? Or is only 13.1% of VBACs, of previous sections, being allowed a VBAC? Because I don't know what VBAC rate means.
But it's the opposite for home birth.
What's that?
It's the opposite for home birth. You have an 85% chance of success having a
Yes.
successful VBAC at home, and only a 13% chance.
No, I mean, my stats were 93% success rate with VBAC. But my question is, does that 13.1, does that mean that was their success rate, or does that mean that that's how many women were allowed to try for a VBAC? Success rate. I mean, if you know, a broken clock is right more often than that. What's that?
If they're brave enough to plan for that, that's their success rate.
That's just, I mean, that's horrible.
That's the stat of the total number of women that are having a VBAC. So there'll be more women that are trying for a VBAC. That's the actual number of women that have had a C-section that are having a VBAC.
Right, so 86.9% of women who try for a VBAC are not successful. Oh, okay. So it isn't necessarily the success rate. It's the number of women that are trying for a VBAC. Oh, okay. Do we know what the success rate is of those women that try for a VBAC, or we don't know that? Oh, it's nowhere close. Yeah, and I would tell you that there's no rate of vaginal delivery in the hospital that is better than outside of the hospital. By every measure, you're going to have more success. And that was another thing that was very impressive in the film, was when Miranda Baccarin realized that when Dr. Wu does breech delivery, that his success rate is 90%. And she had the wisdom to say, that blows me away because 1 in 3 women generally have a cesarean section. So again, they were wise women in that movie. And then lastly, this one just sort of blew me. Oh, did you find something?
Between 30 and 80% success rate, depending
On the hospital, on the system.
Isn't that 13.1%? Isn't that the success rate? No, that's the number of women that have had a C-section that will have a VBAC total.
Yeah, that makes more sense to me. I don't think you could possibly have a piss poor rate like that. So the rate varies between 30 to 80% depending on which hospital you're at, which makes no sense at all either, but I totally get that. And then and I know you define postpartum hemorrhage here as 500 cc's, which needs to change. We've changed it in my country, by the way. What's that? Okay, well then you're saying that 27.9% of women had over 1,000 cc blood loss in Victoria? That would still be 500 last year. When did they change it? Just this year? Okay, because yeah, a lot of I mean, every other place I've been, Brisbane, Gold Coast, Sydney, they said it's still 500. Okay, they need to change that because 500 is not a lot of, it's not a lot of blood loss. But if they label, because that's a ridiculous rate of postpartum hemorrhage. Okay. Yeah. You know, I don't know overall. I know mine, but I don't know overall what the postpartum hemorrhage rate is in the U.S. Oh, it's 1,000 now. Yeah, 1,000 cc's for vaginal delivery. I think it might be 1,500 for a cesarean. What's that? For even a. Yeah, I think we've gone up to 1,000 and 1,500, but don't quote me on that. I don't really know. I know that I think a vaginal delivery is 1,000. Maybe C-section's also 1,000. I don't know, but I don't know what the rate is. I just know that in things like twins, it's higher. We'll talk about that tomorrow. Okay. Got to keep moving. Oops. Okay. So what happened in our ability to birth as nature intended in just over 2 generations, and why is this supported? All right. One of the big reasons is we're stuck in stage 1 thinking. How many of you have heard about stage 1 thinking? I mean, do you know what, because I talk about it all the time, but if you haven't listened to me, I don't know that anybody else really talks about stage 1 thinking, but it's fairly obvious what it means. But this stage 1 thinking means sort of, well, first let me do this. I love this. It has nothing to really do with stage 1 thinking, but I had to stick this slide in someplace because I love the little kid. But it is sort of stage 1 thinking. If we're going to ban VBAC, and some of the hospitals I heard in your country still have a VBAC ban on them, which, by the way, is completely unethical. VBAC is just a vaginal delivery, and to tell a woman she can't have a vaginal delivery, that's insane. And the logic they give is that, well, we don't have 24-hour anesthesia. Well, if you don't have 24-hour anesthesia, then you need to ban birth at your hospital, or you need to accept all birth at your hospital. Because 99% of emergency crash C-sections have nothing to do with VBAC. They're abruptions, they're fetal bradycardias, those sorts of things. And you seem to handle those just fine. Okay. Another Tom Sowell thing, he says, much of the history of the Western world over the past 3, now 5 decades, this is an old slide, has been the history of replacing what worked with what sounded good. So think about this for a second. When instituting policy, stage 1 thinkers fail to ask this question. So if you already know the answer, don't shout it out. But what is the question that, and you can probably see my screen, so don't look at my screen. What is the question that people who are stage 1 thinkers fail to ask, excuse me? Anybody? Okay. Well, I'll tell you. And then what? So if we do A, then B, then what happens if we do A? So, stage 1 is the immediate result of an action that sounds or feels good without determining what happens after. After this slide, what time is it, guys? Who's got a watch? I left my watch in the... Okay, so after this slide, we'll take 10-15-minute break. Okay. Before acting on the anticipated first results of an event, stage 1, it's best to engage in stage 2 thinking, duh. Right? By first asking a very simple question, if we do this, then what will happen? So, in the 1950s, there was some genius who decided that if women are nauseous, they should take a medication for their nausea. Okay, it was called thalidomide. You probably still remember thalidomide, even though it's some of you have no reason to remember it. It's one of those things, it lives in infamy. Caused limb reduction defects. It was mostly used in England. And also diethylstilbestrol was used for threatened miscarriage or a history of miscarriage, caused Mullerian abnormalities in female fetuses, and who knows what it caused in male fetuses. But they caused them to have problems with their tubes, their uterus, misshapen uteruses, more likely to develop adenocarcinoma of their cervix because they were, as fetuses, their mother was given DES. Don't you think we should test these things before we give it to anybody, let alone pregnant women? There's something called the precautionary principle. You do not give unknown, untested, or experimental medication to a woman with a fetus inside of her, right? Okay. Birth control pills, statins, SSRIs. These things, billion dollar boondoggles. Because birth control pills, while had some use, no one bothered to think, well, if we screw up with a woman's menstrual cycle from the time she's 14 years old, and she takes it for 20 years, what have we been denying her? What process? Yeah, she has dysfunctional uterine bleeding, so we're going to put her on it so we can control her bleeding. Why don't we try to figure out why she has dysfunctional uterine bleeding first? And if she does, maybe to correct the underlying problem. No, we're going to just put them on birth control pills. Right. Secondly, statins. Anybody who had a cholesterol over 200 was encouraged to start taking a statin. Did anyone investigate the fact that maybe cholesterol isn't the cause of heart disease and stroke, and that maybe cholesterol is a very necessary precursor for a lot of things in the body, and we're just going to give it? And now we're seeing that people that have been on statins are more likely to develop dementia more quickly, and it doesn't really do anything, but it's a billion-dollar industry. My internist, when he saw me when I was in my 50s, my cholesterol was like 220, but my HDL was like 60. And he wanted to put me on a statin. And if I start taking a statin at age 54 or whatever I was, I'm supposed to stay on that the rest of my life. That's insane. Did he tell me about maybe losing weight, maybe stopping being on call and taking less stress? No, he didn't tell me any of that stuff. He wanted to put me on a statin. And then SSRIs, which are selective serotonin reuptake inhibitors, are used for depression because of the depression theory that serotonin deficiency was part of the cause of depression. But was it? And the research says probably not. Yet millions upon millions of people were put on Prozac and drugs like Prozac to treat depression when it actually didn't even work. And it wasn't the mechanism. They did it anyway. So again, a lot of stage one thinking is there because there's a money-making thing in it. Because there's no money in not giving SSRIs. Okay. Heavy metals as the ingredients of medication. I don't even have to talk about heavy metals in vaccines. The aluminum that's in vaccines, or mercury that used to be in a lot of vaccines and still in some flu. The batch flu vaccines still have mercury in them. But around the turn of the 20th century, the 1900s, they sprayed arsenic. They went around and they put mercury in babies' teething powder. You can still look it up. We looked it up the other day. You Google, teething powder with mercury, and there's something called, I forgot what it was called now, but there was a brand in about 1906 or something that came out. It had mercury, and you put that on babies' gums, and they'll be really good for them, right? Mercury in fillings, for that matter. When I was a kid, Minnesota has a lot of mosquitoes. When I was a kid, we would ride our bikes around the neighborhood, and every now and then, once a week or something, a truck would come by, spraying this smoke out of the back of the truck. And I don't know if it was DDT or if it was malathion, but either one of them can't be really good for you. So what did we do as kids? We followed along in our bikes, riding through the smoke, thinking, what a fun thing. And our parents thought it was fun, too. They didn't care. And so we're riding around through the smoke coming out of this thing in this toxic fumes as kids because we thought it was hilarious to chase after these trucks that were driving through the neighborhood, slowly spraying this stuff in the neighborhood. Stage one thinking. Did we ever think that maybe that's not a good idea? Maybe we should find out what happens if we spray DDT everywhere? This one I won't spend a lot of time on. We used to give women injections to dry up their breast milk. It was standing orders, postpartum, so that they could bottle feed and not get engorged. And that was a standard. Did anyone bother to think, or was it again money driven? And of course, this one was probably money driven. In my state of California, by 2035, right now, it won't last, but they're mandating all electric vehicles. Now, If you're a green energy person and you think that's a great idea, that's fine. But California doesn't have the electrical grid right now to manage its state as it is right now. We have rolling brownouts or rolling blackouts sometimes, especially last week when it was 100 degrees in Santa Barbara, they had power outages. They haven't built an electric power plant in California since I moved there 40 years ago, and the population went from 25 million to 40 million. And pretty soon all cars are going to be electric. Well, how are they going to power them? Screening mammograms and pap smears. I'll focus on mammograms. We were always taught that annual mammograms make good sense. Why were we told that? Did anyone ever look to see if it actually made a difference before they decided to give you screening mammograms? No, they didn't. Annual pap smears. Did anyone check to see that it actually decreases the rate of cancer or does anything really good? No, they didn't. We believe they did, but if you try to find evidence that they did, it's either absent or not very good. But finally, in Canada, they came out with this study, and this was probably 15 or 20 years ago, on mammograms. And they actually did look at 50,000 women over 25 years, and they had about 25,000 women in two groups. One group got screening mammograms every year, the other group got breast self-exam only. And if we were taught that picking up breast cancer early gives you a better chance of survival, which does make sense, and that mammograms pick up breast cancer earlier than obviously breast self-exam, because they can pick up these little things, then you'd expect that the rate of cancer deaths would be higher in the breast self-exam group than in the mammogram group. But they weren't. They were the same. All they found was that the mammogram group ended up with more biopsies, more lumpectomies, more mastectomies, more other concerns, worries, more exposure to radiation without any improvement in survival. Shouldn't they have done that before they started telling people to get screening mammograms? No. I mean, yes, they should have. The world is filled with stage one thinkers. Pretty much everything your political world does is generally stage one thinking. They'll do something because it feels good or sounds good, but they've never really asked the question, is it actually going to do good? Somebody is benefiting from it, and that's why they do it. Playing gods with genes and viruses, I won't even get into that. You guys know what that's about here in Melbourne, and just in other things too. And I'm not even, Elon Musk wants to put implants in our brains and stuff like that. I mean, I love Elon. I love the fact that he's an entrepreneur and created all these great things that make our lives easier. But that to me is a little bit too far, because don't they watch the movies? Don't they read history? Because anytime you play with something like that, it always comes back to haunt you. When I was a kid, I read Mary Shelley's Frankenstein. It was a frightening book back then. Now, compared to everything else that you've got, like Jurassic Park, Frankenstein's a nothing book. But it is about man destroying God, man thinking he's God, man creating something outside of God, and that thing coming back and destroying man. And if you look at Jurassic Park, if you look at Mary Shelley's Frankenstein, if you look at World War Z, if you look at Outbreak, any of these movies, or if you look at the real world in the last 4 years, you understand that when you start playing with these things, you have to ask yourself, why are we doing that? Why are we doing gain-of-function research? What's the real motive behind gain-of-function research? So Jeff Goldblum in Jurassic Park, and I'm sure every one of you has seen Jurassic Park. If you haven't, shame on you. The original one. And he says this: you were so preoccupied with whether or not you could that you never stopped to think if you should. That summarizes stage one thinking really, really well. Inducing all pregnancies by 39 weeks, I won't spend a lot of time on the ARRIVE trial. It's bad science. It doesn't apply to how your hospitals and my hospitals practice. It was ridiculous. Their primary outcome was to prove that inducing all people at 39 weeks would lower the stillbirth rate. They didn't prove their primary outcome. Their secondary outcome was lowered the C-section rate from 22% to 18.5%. But name me a hospital that has a 22% C-section rate. There isn't one. So how does this apply to a hospital that has a 40% C-section rate, or private doctors who now are going to induce women at 39 weeks, but they're not following the protocols and they don't have the same thing, and all you're going to do is cause problems. So they put out this thing because they felt like it was a good idea to do, but they never thought, and then what happens if we put this out there? Sectioning all breeches. Another question about if we section all breeches, are we actually saving mothers and babies? What are we doing? Now, that's going to be the whole theme as we go along today. And then in today's time, I think what is truly behind most stage 1 behavior is money. And then especially egregious stage 1 thinking, and I'm going to come to this next, but let's stop, let's take a break. So it is now 11:30. See how the time just goes by? Okay, so let's take, you want to take 15? Let's take 15 minutes. Everybody take a break. 11:45, we'll start up again. Arg.
suitcase the night before my flight. When your laugh gave you away, you cried for me to stay. I will comfort you no matter where you hide. Are you scared of falling down a well? It's not strange to have a fear you'd never tell. Just remember to be brave, and in the moments you're afraid, it's that fear that lets you know that you're alive. Before you close your eyes to sleep, you should know I plan to keep every little part of you gets the best of me. Please slow down. Time wait up for me. Tell me what it's like to be in love. Is he more or less the boy you thought he was? Well, let me tell you this before you lean in for the kiss. He'll be lucky if he gets to know your mind. Before you close your eyes to sleep, you should know I plan to keep every little part of you gets the best of me. Please slow down. Time wait up for me. When you're old like me, you'll be surprised at all the little things that make you cry. So be kind to your heart, and when we are apart, let our love for you go with you as you fly. It's a rude world we're meant to wander. Do you feel you're slipping under every night? Getting through, running us so ragged. Just when you think you had it, they twist the knife. Are you blue, baby, in the morning? The doctor gives his warning. It's terrifying. So spin a dream no one else is making. Nothing there for taking in the morning light. Let it down, let it down. You're carrying the weight of the world, put it all by you. Let it down, let it down. I want you to know that you're safe here. I want you to stay here by my side. On a road dusty and forgotten, it's not your heart that's rotten, you know that, right? Give me truth, nothing left for saying, no hands left for praying, we're flying by. Let it down, let it down. You're carrying the weight of the world, put it all by you. Let it down, let it down. I want you to know that you're safe here. tell you what I want. Bones that don't break, cars that last forever. Starlit fades, even in the dark. When you're all alone, with thoughts that take you down a one-way road to nowhere you can call your own. Like a bright flash, glows in the sky, burning imprints into your eyes, speaking words that shattered eye up in the sky, even in the dark, when you're all turned around and you're asking why. There's no way to know and there's nowhere to go, but the morning you'll be fine. Like a bright flash, glows in the sky, burning imprints into your eyes, speaking words that
I wish for the rain whenever you go, and I'm digging my grave after the show, only drifting away under street lamps, drowning out all of the stars that might have been guiding my way. Walk in the rain with nobody there but a simple refrain, a chill in the air and a moon hanging pale, casting shadows over the cobblestone street. That morning when the air
There's no consultation,
lingers on, tears upon the pillow where you lay. My coffee's getting colder while I wonder where you've gone. Better off alone than here, a fool in the rain, hoping you'll come by, but you won't tell me. With tears in my eyes, I'm a living cliche, and you're kissing her face. I'm alone with a wish for the rain. When I cry, the rain knows why she knows.
comes in. What's it? Pick her up to her hospital. She goes, oh, I just thought I'd come see you first, John. First port of call. Come into the medical clinic.
To that tunnel I went through. To that tunnel I went through. And my road, my road.
In the medical clinic.
The new birth center.
Yeah.
Springtime of my present tense. Springtime of my present tense. But I used to think that I was doomed to die young, to be consumed. Our love eyes were violent, those winters of my discontent. So long farewell, adieu, adieu. So long farewell, adieu, adieu. To that tunnel I went through. To that tunnel I went through. And my reward, my recompense. My reward, my recompense. Springtime of my present tense. Springtime of my present tense.
Sun. I met someone out on the west coast. I gotta get back, I can't let this go. Saturday sun. I met someone, don't care what it costs. No ray of sunlight's ever lost. So tired of sleeping alone, so tired of eating alone. I need to ask her, what's going on? Are we going strong? She felt like rest in her head. My shoulder was the perfect height. We fit so right. So what's going on? 'Cause I've been undone. a long drive to the coastline, looking at a first light. Am I still on her mind? I've been undone. Oh, Saturday sun, I met someone out on the west coast. I gotta get back, I can't let this go. Oh, Saturday sun, I met someone, don't care what it costs. No ray of sunlight's ever lost, ever lost.
Everybody, let's sit down. Please. Oh. Okay, how's the kitchen looking? Pretty empty in the kitchen, or there's still a lot of people in there? Okay. Maybe I should just talk on 1.5 speed.
I love that.
Yeah. I know. Right, exactly. I can't. Okay, so we left off with examples of stage 1 thinking, so I want people to understand that it's pervasive. It really is everywhere. But the most egregious stage 1 thinking that has affected our profession are these two things. And that is the persistent use of continuous fetal monitoring despite lack of evidence supporting its benefit, and continued adherence to the Friedman curve in spite of knowledge that it is flawed science, have not served women well, yet they remain standard in most hospital units. And I understand that you have your CTG rules and stuff like that, but two categories that still have to have CTG monitoring. Kristen Small addresses that whole idea that there's really no benefit to it at all. We know that. And then are doctors still applying the Friedman curve to labor? Yeah? So I want to talk about the Friedman curve for just a second first. Think about this for a second. You can see the graph of the Friedman curve there. So the red is the rate at which primips should dilate after you reach 4 centimeters. And the yellow is multips. So the question is, of course, do all women dilate at the same rate? And the answer is, of course, not. So how do they come up with this curve? Well, they had about 700 women in this study, and in order to come up with a curve, you basically have a scattergram of points. And then the curve is like the median or the mean through all the scatter points. So if this is the mean, and this is what you're supposed to use to gauge women's labor at 1 centimeter an hour for primips in the active phase, and it's made from a scattergram, then what percentage of the scattergram dots are below the curve? What? 50%, or 49%, whatever. Right. half the scattergram things are below the curve. So what these people have decided is that once they make this curve, that half the women who are in labor are abnormal. Is this normal thinking? You're thinking suddenly that this is an average, which means there's got to be people above it and below it. But now we've assigned the fact that this is the standard, so everyone that's below it needs to have their membranes ruptured or be augmented or whatever else, even though half the women, when they did this study, were below it, and that was their normal labor.
But this was Reagan created this curve on women that were going through induction.
They were anesthetized and they were being induced, right? Right, and yet, but yet it was immediately adopted. This is what I'm trying to say. It's the same thing with CTG. And no one ever did a randomized study on CTG to see, you can't do a randomized blinded study because people know if they're wearing a belt or not, but no one did a randomized study to see if CTG actually did any good. They just put them out there because they thought they might do good without ever asking the follow-up question, and then what happens when we do. And we know what the Friedman curve has done. It's contributed to a significant rise in the rate of inductions, cesarean section rates, augmentations, and obviously long-term health problems for mothers. And yet most hospitals still continue to use it despite the fact there's never been any evidence that it actually is accurate. And of course we all know just from common sense that it's not accurate. And when women are in a hospital in a bed strapped to a monitor with epidurals and on Pitocin, it's not the same as if they're free to walk around their living room. And yet this is still applied to they're not moving fast enough. It gets back to the picture with the guy with the watch. So it's stupid. Let's just say that it's stupid, and yet it's still used because once this becomes in place, it's very hard for anybody with any reasoned mind to get people to stop using it. Remember that thing, time makes more converts than reason? Eventually this will go the way of the dodo bird, but right now it is still there. And it's doing damage every single day. Do you want to say something?
There's not a single graduate midwife I've spoken to this year who is not petrified of not having CTG. Yeah. They're like, what do I do? There's no CTG. Enjoy it.
Right, right. And I mean, do they not know the data about CTGs?
They're not taught it. It's university, and then they go straight to the hospital, and that's all they stay in the bubble unless they're exposed to us working in Hobart.
Yeah. Well, one of the first things that I thought about when I was going to do my first home birth is that. I mean, it's a leap to go from that medical model to basically not monitoring. Now it seems like that's the norm, and to think otherwise would be crazy, but back then, that's the way I thought. But let's talk a little bit about CTGs. Steve Clark is an interesting guy. Steve Clark was a fellow at LA County USC Women's Hospital, and I was a resident there. So he's about 3 or 4 years older than me. And I sort of followed his work. I've always admired his work. He ended up, I think, at the University of Utah. It has nothing to do with why I'm in Utah. I don't even know if he's still there. But he has the gravitas in the maternal fetal medicine community to get an article published in the Green Journal that sort of is antithetical to what you'd think the Green Journal would want to see published in their journal. Because they cherry pick the articles they're going to put in there that sort of support their position, and they restrict publication of articles that don't. But he's got enough standing in the community to get this article published. And he wrote an article 2 years ago called Category 2 Interpartum Fetal Heart Rate Patterns Unassociated with Recognized Sentinel Events, Castles in the Air. Let me explain what Category 2 means, because you don't use that terminology. In America, we have Category 1, Category 2, and Category 3 fetal heart rate tracings. Category 1 fetal tracing, everyone knows exactly what that is. It's a nice, reactive, good-looking tracing, which is very reassuring. And a Category 3 tracing, everyone knows what that is. It's a tracing that looks like shit. And the baby's on a terminal event toward demise or brain damage. But Category 2 tracings are everything in between. So you could have a Category 2 tracing that is reactive at some times, but when the baby's asleep, it's very flat. Or there could be even little like subtle, even earlies or decels when the baby's asleep. And then wakes up and then it's perfectly fine again. Or it could be a baby that's having intermittent variables. Or it could be a baby that's having deep variables with slow return to baseline. or rising fetal baseline with a tachycardia. Any of those things are listed as category 2 tracings. The problem is nobody really knows what a category 2 tracing means. Yet, so many things are done because of a category 2 tracing, because it makes the nurses and the doctors uncomfortable. They will then act upon them. And they will do things to the mother, and eventually what will happen is the whole cascade of interventions will happen, and the woman will get a C-section, and the baby will come out with a category 2 tracing, will come out with APGARs of 9 and 9, normal cord gases, and everybody says, wow, thank God we were here because we got that baby out before we really had a problem. And the diagnosis for her C-section will not be unknown, or induction will not be unknown. It will be for fetal intolerance to labor, which you guys often call fetal distress. We've sort of gotten rid of that term. We now call it fetal intolerance to labor. It sounds better. Because how can you say a baby's in distress when it comes out with APGARs of 9 and 9 and normal cord gases? It obviously wasn't in distress, so they've changed it now fetal intolerance to labor, which means more likely obstetrician intolerance to labor is what it means. And so we have these rising C-section rates based on these monitors, which nobody knows what it means, the category 2 tracing. So he wrote an article. First, let's define what castles in the ear means, because you may not know, but it is what it sounds like. It's a visionary project or scheme, a daydream, an idle fancy, a pipe dream. Any plan, desire, or idea that is unlikely to be ever realized, a near impossibility. It's a really good description of what fetal monitoring really is, isn't it, when you think about it? Okay. So in summary, he said these two things. He said, and this was in the Green Journal, which was rather why I was impressed. He said, the evolution of continuous electronic fetal heart rate monitoring has presented the obstetrician with a critical clinical conundrum. Basic science observations suggest that such monitoring might be associated with improved long-term neurologic outcomes. That's what they presume in their stage 1 thinking. Yet after half a century of use and millions of cesarean deliveries based on monitoring, evidence for such improvement remains absent. Not diminished, not sketchy, remains absent. But then he even goes on and says this. Finally, obstetricians need to realize we are unique among medical specialties in our willingness to perform hundreds of thousands of major operative procedures each year, not only without evidence of benefit, but with strong evidence of non-benefit. Why do we do that? And we're going to get into why we do that in a second, but I just want to give an example that I use a lot in my country, but we can even do it with your country's numbers. So let's say that your country has about 300,000 births a year. It's obviously more dramatic when I talk about my country with 4 million births a year, but let's just use your country, 300,000 births a year. And say you have a C-section rate of 40%, 39, but 40 is easier math. That means you're doing about 120,000 C-sections a year in your country. Now, the World Health Organization, which is not an organization I will ever quote for anything accurate, does believe that the C-section rate in Western countries should be between 10 and 15%. But let's just say for the sake of this argument that it should be 20%. So you can see where I'm going with the math here. So your C-section rate is 40%, it should be 20%. You're doing 120,000 C-sections a year. That means based on even liberal parameters, you're probably doing at least 60,000 unnecessary cesarean sections every year in your country. In my country, it's more like 600,000 unnecessary C-sections every year, if you do the math in my country. But let's just say 60,000 unnecessary C-sections. That's an abomination. And as she discussed earlier, if in my country or your country, if they're doing 60,000 unnecessary mastectomies or gallbladder surgeries or knee surgeries, your government or your insurance companies or whoever's paying for that would probably get an inquiry going and probably question what's going on because we're spending money on things we shouldn't be spending money on. Yet for cesarean section, not a peep. Not a peep. 60,000 unnecessary C-sections every year. But here's the real question. Who's doing them? Because no doctor goes home at night. Right. No doctor goes home at night and says to their spouse, hey, honey, guess what? I did 2 unnecessary C-sections today. They don't say that. Every C-section they believe that they're doing is necessary, but half are unnecessary. Or more than half, but let's just say for the sake of my argument, half. So how do they handle that? Well, they're obviously going to say that guy over at that hospital is doing all the unnecessary ones. But then what's that guy saying over there? He's saying the guy at your hospital is doing it.
They sell it though, with the whole CTG, like we're going to act unnecessarily. We don't know which one's actually going to be bad and which one isn't. So we'll say that one and we'll do an unnecessary one just in case.
Do they actually admit that they're doing unnecessary ones though? Because I don't believe that they are. Well, they blame the women. I've heard that throughout Australia. Yeah. One at a time, guys, because I can't hear.
Of a trace, you could have a trace that looks bad, and some of those babies will actually be unwell, and some won't, but we don't know which is which, so we justify doing an unnecessary one to save the one that is actually false. Oh, is actually...
Right.
Yeah, and... Yeah. So
But they have to believe believe they're doing a good job. Yet half of the women that they're taking care of are having unnecessary major surgeries on them, without any concern about that woman, that baby, and that mother's future babies.
That's the standard thinking. Like, let's give the whole population a COVID vaccine. It's not going to be safe in order to save.
Right.
It's exactly the same.
Right. I'm telling you, the world is filled with stage one thinkers, and somehow they rise to levels of power and decision making, and it's baffling to me because you'd think the best and brightest and smartest would rise to those things, but the best and brightest smartest don't want to do this stuff. They want to clinically take care of women in their house or their hospital and do their work, and they don't want to do this. But these are the decisions that are being made. Did you want to say something over there?
I think if we look at like the World Health kind of thinking, if we're looking at 60,000 unnecessary C-sections, how many maternal deaths is that leading to? How many pregnancies is that leading to? How many fetal devices is that leading to in subsequent pregnancies? So it doesn't matter whether they think that it's necessary or not. You have to look at all the subsequent harm as well to get the full picture, and nobody's looking at that.
Right.
What comes next?
Yeah, we're gonna actually everything you just said. We're gonna look at the numbers and stuff like that.
But
So.
you also have a population of women that are going into it thinking birth is something to be feared, and the doctors and the systems are enforcing that rhetoric. So it's not being challenged by.
No. There's lots of reasons why it's not being challenged, but the bottom line is it's still completely unethical.
Oh, for sure.
Right. That we're operating on all these women
So there's
and
also
putting them and their babies at risk. Yeah.
There's also a growing group of women that are requesting a cesarean, choosing practitioners that they know will consent that even at a first visit. So then, or even at an emerge section, the consent will include, it's okay, you'll be able to have a vaginal birth next time, but try and get it.
Yeah.
So it's a throwaway line, you needed the cesarean, but you'll be able to have a vaginal birth next time. But all the doubt is put there, so the woman either chooses to have the section again, or they can't find the clinician to get the support, or have to go out of the system, which will be right out of the system soon.
Right. All of this. The reason I'm bringing all this up is that's because we're going to be talking how this relates to breech in twins and stuff. So you have to understand. But when you see Dr. Wu's stats, when you see my stats about success rates of vaginal breech birth, when you see the Royal College of OBGYN's recommendations about breech birth and about the risks of breech birth, it's going to make this even more outrageous and more upsetting to the fact that what's going on. But when you just see, and again, I've been giving you easy numbers. The C-section rate shouldn't be 20%. It should be less than that. And your C-section rate in some places, in some hospitals, is going to be 40, 50, 60%. And think about countries like Brazil or South Africa, where I told you it's 70, 80%. Probably 70% of C-sections being done are unnecessary, with no concern about those women, those babies, the microbiome of those babies, the effect it has on the breastfeeding and postpartum depression, and certainly the risk factors that you mentioned to all mothers' future babies. I will tell you that in my office, when I see a new consult for breech, they would always be sent to me generally by their doulas, because their doctors would never send them to me, because the doctors didn't believe, first of all, they didn't even know I existed, and if I existed, they certainly would think I'm that crazy guy that's doing home breech delivery, but they would never send them to me because they think breech is crazy and dangerous. But their doulas would send them, and I would see them as a consult, and one of the questions I would ask them, and it never altered, it was always the same answer, was I would ask them, the doctor who's told you you should have a C-section for your breech baby, who told you that was the safest and best choice for you and didn't offer you anything else, did that doctor ever ask you if you want more children? And the answer is 100% no, they never asked that question. We'll get to that. Okay, got to keep moving. This is just for fun. When you're dead, you don't know you're dead. The pain is felt by others. Same thing happens when you're stupid. Okay. So stage one thinking. This is an example of my country's thinking of stage one. So what are you looking at right there? You're looking at a labor and delivery room. Okay. So there was a push in the 90s and the early 2000s in my country about when home birth was trying to make a push. They said, home birth is dangerous, but we need to make hospital, we understand why women want it, so we need to make hospital birth more home-like. So to the administrators and people in a hospital, what that meant was we're going to put hardwood floors in and put curtains in the labor room, but we're going to keep the same policies that we've had all along. That is stage one. That's a stage one thinking. We're just going to make it look more like your bedroom, but you're still going to get flat on your back, CTG, inductions, AROMs, epidurals, and eventually interventions. So that's how they think about it. Again, they don't think about what the stage two thinking would be of what's going to happen if we do this, but we don't change any of our policies. It doesn't matter. We're trying to compete with those silly home birth people, so we'll make our rooms prettier. So you guys I've learned that you guys call this dressing up a turd. Yeah, in our country we call it putting lipstick on a pig, but it's basically the same thing. It's still a pig and it's still a turd, no matter how you dress it up. Yeah, everybody loves pigs, right? Do you put lipstick on your pigs? No, okay. So, pressing issues in the medical model surrounding consent and choice. Look, we could talk about any one of these slides and we could probably get stuck on it for 20 minutes, and I'm going to try to keep us moving. Breech birth occurs within a woman's lifetime. For some women, a forced cesarean is permanently devastating, and then you get women like this. So when you force a cesarean section on a woman, you don't ask the question, and then what? But this is kind of what might happen with a woman who has a C-section. She says, I had a forced cesarean because my baby was frank breech. I do not trust hospitals anymore. I hate my body now. I was loving it. I was loving my pregnancy until then. Now I feel like half a person. I have a baby, but I didn't give birth. And to me, that feels like Katie and Elizabeth in the movie, both of whom said, I wasn't really connected to the baby. I didn't really feel like connected to the baby. I mean, eventually they do, but there's a reason that nature designs things the way they do, and the hormonal cocktail. So stage one thinking is pervasive. You guys probably know what I'm going to say here, but in the medical model, all that matters is, anybody? Right, a live baby in the bassinet. That's sort of one of my go-to statements. It's a live baby in the bassinet. All that matters. They're going outside, okay. Because this is a very important point. If you look at any research paper, any book, anything that looks at outcomes, all you'll ever find in pretty much every academic research paper, the only outcomes that matter to them are neonatal death and neonatal morbidity, and occasionally C-section rate. They never ask, what's the breastfeeding rate? How's the baby's health at 5 years of age? How did the mom do? How did the mom's subsequent pregnancy go? Did mom have postpartum depression? How was bonding? These are not endpoints in any study. Only neonatal death, only neonatal morbidity. And once you start seeing this, and you start looking at studies, and you look at the method section, and they tell you what they're looking for, always going to be these numbers. And they also talk about something called composite morbidity. Do you know what composite morbidity is? Composite morbidity is a statistical manipulation. It's a statistical trick. It's like if you're looking at a paper and you want to look at, say, neonatal death, but there's not enough neonatal deaths to make your point statistically significant. So then you combine neonatal death with things like broken clavicles or shoulder dystocia, brachial plexus injury or bruised labia, and you put it all together. Oh, and now statistically it's significant. So yesterday at the ACM meeting, I went to one lecture, the diabetes guy lecture, and I don't know if were any of you at that meeting yesterday? Okay, so the diabetes guy lecture, he made a lecture, and he did this. He was pointing out something with diabetes, and he put up a slide that had composite risk on it. So let's see what you think about putting all these risks into one category. Birth, less than 37 weeks gestation. Birth weight over 4,500 grams. Birth trauma, something like IADPSG criteria, whatever that is, I don't know what that is. Neonatal respiratory distress. What is the respiratory distress? Is it a baby that needs 3 rescue breaths? Or is it a baby that's intubated and put on cooling blanket for 3 days? Need for phototherapy. Stillbirth neonatal death. Okay, so we're putting compositely together a baby that needs phototherapy with a stillbirth. Shoulder dystocia. All these things are put together so that they can reach statistical significance in the paper to say that screening for diabetes at such and such a date. And I don't know the rest of the paper. All I noticed was the use of composite morbidity. So here's another red flag for you. When you see a paper and you read in the material and methods section that they use composite morbidity, you should be suspicious about that paper. They should openly say what that means, but they don't. But no paper that has statistical morbidity in something that really matters has to use composite morbidity. It's a trick that I learned about this a long time ago. And when I read a paper and I see that the only endpoints that matter are neonatal death and neonatal morbidity, and they use composite morbidity in order to reach statistical significance, the paper's generally junk. But it will be often adopted because it's of what we're going to talk about in the coming slides. So all they care about is a live baby in the bassinet, and how that baby gets in the bassinet and what happens to that baby and the mother and the future babies does not matter to them. And that's not to say that the individual doctor or nurse are bad people or anything like that. It's not them, it's the system that they're in. It doesn't allow them to individualize their care and to actually do that because, one, there's no continuity anymore. You've all known stories of women who've had C-sections, not all of you, but who've gone on to have a problem with a subsequent pregnancy where they had an accreta, or they had a ruptured uterus, or their baby died, or even when we had one in Arizona recently where the mother and baby both died. And no one looks back and says, why did she have that first C-section? And in the case of the Arizona woman, she had a section because her baby was breached and she was never given an option. And had someone given her the option and had she had a vaginal delivery with that breech baby, she and both baby Mac, Jordan and baby Mac would be alive. But they're dead. And nobody looks back and says, geez, what did we do? We did a section for breech, and now we have a dead mom and a dead baby, or we have a woman who has a hysterectomy because she had a accreta. Right. That doesn't matter. All that matters is, well, we got a live baby in that first pregnancy, so we're good. Breech baby, some consider breech to be a variation of normal. Others suggest the possibility of innate abnormalities. We talked about this a little last night. I consider breech to be a variation of normal. I don't consider there to be any significant difference. And we know that by 2 years of age, there's no neurologic difference in them. So I don't really think that babies are sitting breech because there's a neurologic problem. Some people, and again, some women have said, like Robin Lim, we talked about last night, said that during the tsunami and when all that stress, there were more babies that were in breech position. So is that the mom and the baby not wanting to come out, the mom like tightening up because she's nervous and the baby staying in that position? I don't know. Obviously, some babies are in breech because moms have uterine abnormalities, like a septate uterus or bicornuate uterus. You see more of that. But it's not something that, without an anomaly of the baby, an obvious anomaly like hydrocephalus or goiter or something like that, babies are not going to generally be breached because there's something wrong with them. I just think that this is a normal variation. They say, and I've been re-quoting this number forever, that it's 3 to 4% of term babies. I'm wondering if I want to reevaluate that, maybe because I'm a lightning rod for breech stories and because I've been talking to all you in Australia, but it seems like more than 3 to 4% of your pregnancies are breech. I don't know if that's true for you. I don't know if you have 100 babies, how many of them were breech, but maybe it was only 3 or 4. But it seems like the stories are legion, so it's just I'm curious if that's true. There's very good data supporting vaginal breech birth for properly selected breeches, yet over 98% of breeches are born by cesarean section. And the question is, you know, it can't just be stage 1 thinking that does this. There's got to be more to that. So the question is why, and two of the main reasons that are why are something called confirmation bias and cognitive dissonance. So let's talk about these two in a way. We'll use the Turn Breech trial as an example of confirmation bias. So you guys all know the Turn Breech trial. Do I have to even go into it anymore? It was a study, came out of, it was 122 centers in 26 countries by a researcher named Mary Hanna was the lead author. She's from Vancouver, Canada. And there were 2,000 women in the study. And the selection criteria were listed there in the green. I won't read them to you. And what they found when they looked at that, and it was quoted in the documentary initially, that babies born by cesarean section did better than babies born vaginally. And so this was the crown on the death of vaginal breech birth. Vaginal breech birth had already been declining in the 80s and the 90s. And I think what happened is this is an example of confirmation bias. The medical community wanted a paper that could support what they wanted to do. Same thing happened with the ARRIVE trial, by the way. The ARRIVE trial, 2 years before the ARRIVE trial came out, there was a fake debate called a faux debate at the ACOG meeting where two guys, one was supposed to be pro-induction and one was supposed to be anti-induction at 39 weeks. Actually, they were both pro-induction. They convinced an audience of doctors that went from 24% believing it's a good idea before the faux debate to 70% thinking it was a good idea after to induce all women at 39 weeks. Then, lo and behold, 2 years later, the ARRIVE trial comes out. So it's almost as if this is what we wanted to see happen. We laid out the red carpet for it, and then we put the article out, and now it just proved what we already had been saying before. And so it gets lost. You just say it enough times. It's classic Nazi propaganda. If you say it enough times, you say it over and over again, it becomes truth, even if it's not truth. And that's what happened. So the Turn Breech trial was just a confirmation. Rixa likes to call it the one ring to rule them all, if you know what I'm talking about, right? So that's what happened. However, when you look at the Turn Breech trial, there were a lot of critiques of it. And within 2 years, the people themselves who put it together, Mary Hanna, people looked at it, they revisited it, and they found that there was no difference in neurologic outcome by 2 years of age between babies born vaginally or babies born by cesarean section, and that the Turn Breech trial recommendation should be withdrawn. That was in the documentary. Was it withdrawn? No, of course not, because it met the model by which they wanted to practice. That's called confirmation bias. But let's look at some of the critiques of the Turn Breech trial. First of all, there was high randomization in labor. Now, this trial was the only trial where there was really randomization in labor. Is that a good idea, to randomize a woman in labor? Because if a woman thinks breech is dangerous, because she's heard it all along through her pregnancy, and then she comes in labor and she pulls out the little piece of paper from the jar and says, you're going to have a vaginal birth. What's the chance of success for her? Not very good. 83% of the vaginal breech births, women didn't know they were going to have a vaginal breech birth till they were in labor. So that problem, from our perspective, they're not mentally in the right mindset for that. Secondly, you're supposed to have only vaginal breech, only breech babies in your breech study, right? Well, they had some twins and some cephalic babies in their data. Yeah. Okay, wait, just wait. So there was no consistency in the skill of the practitioner that was there. Having a flexed head was a requirement. Flexed heads are diagnosed by ultrasound in the medical world. You guys can probably do palpation and probably pretty good at it. Doctors are not. They use ultrasound. 30% of the centers, when the woman came in labor, did not have an ultrasound. So they violated one of their own parameters in 30% of the time. They didn't have the same labor protocol. So not only did they not necessarily have the skilled people doing it, they didn't have consistent protocols throughout all of them. How long do we let a lady labor? How long do we let her push? How long? They were all variable. Another thing that people don't think of is that C-sections in this study were done at 38 weeks. While the vaginal women were allowed to go up to as far as 41 weeks. Well, we all know that the longer you go in pregnancy, the more likely you are to have an adverse event that happens. Just we know that. So you're comparing apples to oranges when you do that. And in most cases of perinatal death, there were 16 perinatal deaths in the 2,088 women. Had nothing to do with the way they were born. They were usually due to anomalies. Right. So now when you see this, and you understand how hard, like for Rix and I, to get a paper published in a major journal, get it through peer review, right? Ask yourself this question. How did this get through peer review? With having head-down babies in a breech study? You think maybe we should correct that before we publish the study? No, this gets through peer review. Why does it get through peer review? Because of confirmation bias. They wanted it to get through peer review. They wanted it to get published. Right? 2-year follow-up, again, you look at the second author on that, that's Mary Hanna, same person that did the study, and they said that, and you saw this in the film, that planned cesarean delivery is not associated with a reduction or risk of death or neurodevelopmental delay in children at 2 years of age. So it really was no difference. Merritt Glazerman is also mentioned in the study. He's a researcher from Israel. I had the good fortune of meeting him. I'm not sure if he's still alive or not. But he basically wrote an article in 2006 revisiting the term breech trial, and then again in 2012, basically hearing crickets on his articles. Nobody was changing anything. But he said that this single piece of research profoundly and ubiquitously changed medical practice and effectively was a final nail in the coffin to remove vaginal breech birth from delivery wards. And interestingly enough, of the 122 centers in 26 countries that were in the study, about 96% of them, after the study came out, stopped doing breech delivery in their own centers. The term breech trial was a blatant example of how an inadequate randomized controlled trial can change medical practice and, via certain biases, be willing accepted. So, why did this one study, the term breech trial, have such a profound effect? And that's what we call confirmation bias. Confirmation bias is the tendency to search for, interpret, favor, and recall information in a way that affirms one's prior beliefs. Okay? Everyone in this room has confirmation bias. You know, we tend to navigate to coming to our conferences, and we couldn't stomach going to one of their conferences because it would make us nauseous by the time we were there. Those guys don't come to our conferences. In my country, if you're a conservative, you probably are okay watching Fox News. If you're a liberal, you're going to watch CNN or MSNBC. The two don't mix. We get our news from, so we all have bias. The difference is, I think that most of my midwife colleagues admit that they have a bias, and most of my OB colleagues don't admit they have a bias. They think they're right. These two guys will never agree because they will never leave their box. If all they did was they got out of their box, they walked around to the other side, they can maybe find some common ground with the other guy. But in here, this is the world we live in the obstetrical world, when the silos are sealed. We need to break the silos. We need to get OBs, residents, to spend 2 months following a home birth midwife around to get to understand how we do things. And then taking some home birth midwives and letting them hang around labor and delivery. And watching things, and maybe having meetings and luncheons and conferences where we all get together. And maybe this room would be great if it was half filled with residents or young doctors and half filled with midwives. And having me up here, and then having an academician up here who's sort of anti-home birth breech, that sort of thing. And then wouldn't that be great? Wouldn't it be great? Wouldn't it have been great in your country or my country if your politicians had taken the medical leaders who were so intent on locking us down and giving us vaccines and put them on the same stage and bought 2 hours of national television time and put on people like, in my country, Peter McCullough or Jay Bhattacharya or Robert Malone or Peter Corey, put them on the same stage with these guys and had a conversation so you, the average Australian, could then make up your own mind about who's telling the truth and who's not telling the truth. But they will never do that. People in power will never do that. And when they don't want to do that, it's because they're not confident in their position. Because people who are confident in their position don't have a problem debating it. The people that shut down debate are, when you can always tell who's got a winning argument. The winning argument person is the one who's willing to talk about it. There are tells out there. They'll call you names and stuff, and they'll say, well, I wouldn't belittle myself to talk to that Dr. Fischbein guy because he's a radical guy. That's a con. They're scared. They're chicken. You guys use that term here? Yeah. Okay. So, how about some evidence on the term breech trial, on breech since the term breech trial? Well, 6 years later, a Promoter study came out of France and Belgium. You may have heard of this one. It's 4 times larger. It had 8,000 women in it. And they corrected for the problems with the term breech trial. They didn't have any twins or head-down babies in their study. And they didn't randomize them in labor. And they had more standard protocols. And they found no difference in perinatal mortality or morbidity. So why was that ignored? 4 times larger. What's that? Yeah, confirmation bias and cognitive dissonance, right. They just wanted to ignore it because they liked the way things were. For whatever reason, the medical model wanted to do C-sections. I understand the business model is greater. You're in at 8:30 and you're out at 9:15, and you get paid, like Elliot says, you may not make more money as a surgeon. I don't think we get paid more for surgery in my country. We get paid a global fee, but time is value. And if you have somebody in labor, you might have to be there for 7 or 8 hours in the hospital, whereas here you're in and out in 45 minutes to an hour. The hospital definitely makes more money. And even in a country like yours, where the money comes from the government, the hospital still gets paid more money. More of your tax dollars go to pay for a C-section than for a vaginal delivery. That's how it works. Because hospitals they don't give a hospital a set amount of money and say, okay, now take care of everybody. Hospitals bill the government for what they do, and the government decides what they're going to pay them. And if they pay them less than the hospital needs to survive, the hospital will do one of 2 things. It will either go out of business, or it'll start doing more stuff unnecessarily so they can make up for the deficit that they need to make their hospital viable. What they won't do is fire administrators or fire people who don't do anything. They don't do that. So you brought this up before, that that with breech birth vaginally, there are some short-term morbidity issues. One of the things that every paper finds, including our own, is that 1-minute APGAR scores are statistically significantly lower than with C-section, but by 5 minutes that difference disappears. And then there's increased need for ventilation, but as I said earlier, what does ventilation mean? They don't define it. But they would say that taking a mask and giving the baby 3 breaths is assisted ventilation. By the way, we use mouth-to-mouth, Bliss and I, and some of our. Do you guys do mouth-to-mouth? Because I never find the seal with the bag doesn't work too well. You. So you do mouth-to-mouth. Right. Yeah, some of you carry the ambu bag, and some of you don't. But I just find that I get a better feel for the baby if I have to do it by putting mouth-to-mouth. So, yeah. Would I describe it? I have a big mouth. Yeah, you go over their nose and mouth, yeah. Or, I mean, their nose is too small to like put it over the mouth and pinch the nose. So no, yeah, you just get over, you put your mouth over, well, where's Sophie here? She's got powder on her, so I don't really want to put my mouth on her right now, but essentially, that's not a very big area. So you just seal your mouth on that, right?
How big a breath?
You know what, it's a feel. It's a feel. You mean you've got your hand on her, you can feel her chest expand. And you can tell when you have a seal and when you're doing it. So I don't know, because I don't have a meter on me that tells me how many foot-pounds of pressure I'm doing when I'm blowing into her. But I've always done it that way. When I take my NRP classes, we learn to use the bag. But when I go into real life, I always use mouth-to-mouth. And I learned mouth-to-mouth from the midwife. Obviously, in the hospital, the OB never does any of this stuff. They got the pediatric team in there, and they do all that stuff. But when I started doing home births, I had to take NRP every 2 years, and like you guys probably do, and I had to do certain things. But then the midwives I worked with, Beth and Bliss and Alex Evangelidi, they all use mouth-to-mouth. And so that's how I got it. Again, walking on the coattails of the midwives that came before me, I learned almost everything that I do right now, I learned from midwives, because I certainly didn't learn it in residency. And I've just modified it over the years. And I have a different, a different sort of skill level because of what I do. The obstetrical part of me has certain things that I can do that I still take with me, but I've left a lot of stuff behind. Anyway, so getting off track, but that's. And again, if you live in a world where if you're in a hospital and they don't want you doing mouth to mouth, you don't do mouth to mouth. But I just think you get a better seal and a better feel for that you're actually ventilating than when you use the bag. Okay, so that's that. This is a very important slide. Okay, this is RICSA. I stole this from RICSA with permission, by the way. But this is, you can see the size of the red dot is the size of the dots are based on the number of women in the study, and the size of the dot, and the red dots are for planned cesarean for breech, and the green dots are for planned vaginal breech. And you can see in pretty much every study that the red and green dots are fairly close together, right on top of each other, and some of them, even the green dots are to the left of the red dots. Right? But they're all relatively close together. The bottom part of the axis is deaths per thousand, and that stuff. And you look at the size of those, and you say, wow, those are all fairly common. But there's only one study that's way at the top that you can barely see. You need a telescope, and you're looking at Pluto out there. That's Pluto. That's the only one where there was a significant difference between two. That's the one they chose to follow. So when you see it put this way dramatically like this, you have to really ask yourself, why? Why would they follow that one? Well, it's the only randomized trial. But that's a really piss poor reason because it's a poorly randomized trial. So they followed it because they wanted to follow it. The question is, why did something that we loved doing as residents, that we considered normal, and we fought over who's going to take care of the breech in room 6, as residents, why did it become out of favor? Why did that happen? And I can't answer that. I can't speak for people because my mind doesn't go there. Was it fear? Was it money? Was it time? Was it ego? I don't know. All of them? Probably. But who decided that? Because when I was a resident, academia was supportive of breech delivery. When did it change? Why did it change? There were articles coming out through the 80s and 90s that supported vaginal breech birth. And there were articles coming out that supported cesarean section. Why did the cesarean section ones dominate? Who was it that decided we need one ring to rule them all? And why did they accept it? Okay. So cesarean for all breeches leads to these complications, which you mentioned before. Especially potentially uterine rupture or scar dehiscence, and then invasive placenta. And so if you look at the rate of invasive placenta over the last 50 years, you can see that more cesareans equal more accretas or incretas or procretas. The C-section rate was 32%. Repeat cesarean section rate was 88% when this slide was made, which I think was probably 3-4 years ago. Placenta accreta has tripled since the 1980s, from 1 in 1250 to 1 in, what?
Why do you think that is? Is that the number per C-section or is that per pregnancy? Like it's gone from 1 in 30,000 to 1 in 1,250.
Births.
Births, okay.
Births. In 1960s, placenta accreta was almost unheard of. Kind of like in the 1930s and 40s, autism was almost unheard of, right? And in low-resource countries and low-resource hospitals, like your not tertiary care centers, if a woman comes in with an undiagnosed accreta, the chance of a maternal death is about, well, again, these are just data points. I don't, but it's as high as 1 in 14. Now, if they walk into Royal Women's Hospital or something like that with an accreta, even if it's undiagnosed, they're probably not going to die. They might lose their uterus, but they're not going to die because you have blood banks and you have good surgeons there and you have that kind of stuff. But if you're some small community hospital, or you're in Mozambique or Malawi, and you walk in with a placenta accreta, and by the way, when we do section all breeches here in Australia, in the United States, and Europe, doctors in third world countries are following our lead. And so in third world countries, they're sectioning all breeches. And what's happening to those women in the future? We are seeing 1 out of every 14 deaths. And we'll talk about that in a second. But when you section babies, especially the pre-labor cesarean section, like Michelle O'Donnell likes to talk about, is that you do increase risk to the children. Now, these are small relative risk increases or odds ratios. A 21% increase in asthma, a 59% increase in childhood obesity is nothing to be scoffed at. Type 1 diabetes is elevated, autoimmune diseases are elevated. So a lot of these things are, but these, if you're going to give informed consent to a woman about sectioning her for breech, you should be telling her this stuff too. And they don't. This is another slide that shows a study that I think came out of the Netherlands. And they looked at 8,500 C-sections for breech over a 4-year period of time. Now, I'm curious how they had that many breaches in 4 years. So I don't really know if there was, or maybe it's all C-sections together. But whatever, if you do a C-section on 8,500 women, and I'm assuming it's breaches because this came from, and it says elective C-section for breech. So I don't know if maybe it was all from, I don't know if they have that many breaches in the Netherlands or if they took it from all over Europe. But they published this paper, and if you do a C-section for breech, and the Royal College of OBGYN says the risk of a neonatal death or an intrapartum death with, or stillbirth with a breech baby vaginally is 1 in 500. In this study, it was 1 in 477. So about the same. It's called the number needed, well, the number needed to treat. You need to do 477 C-sections on women to save 1 baby. But if you did 8,500 elective C-sections and a number needed to treat of 477, you're going to save 19 babies. But at what cost? If these women went on to have another baby, well, first of all, in the 8,500 women, 8,500 C-sections, 4 women are going to die. Because the rate of maternal death after C-section is about 1 in 2,100 in Western countries. It's as high as 1 in 100 in places like Tanzania. But it's about 1 in 2,000 plus. Okay, so you're going to kill 4 mothers. You're going to lose 9 babies if they have a subsequent pregnancy because of the risk of ruptured uterus. And you're going to have 140 extra morbidities in the mothers, including things like accreta, hysterectomy, bladder injury, scar tissue, bowel obstruction, other things like that that occur from the surgery. So ultimately, if you're going to, if a woman's having a C-section as a primate for breech, and you ask her the question, which they won't ask her, which is, do you want more children? You're really not doing anything. You're probably doing detriment. Because what if she wants a 3rd baby or a 4th baby? Are you going to, and what's the risk of a 2nd C-section, and a 3rd C-section, and a 4th C-section?
And the 4 women that die now have other babies that have no mother.
Baby without a mother, right.
Which is so
Yeah, and if you do the sections and you do a 2nd section on them, you're going to lose 4 more women. Now you're 8 women down, right? Again, this thought process is complex. This is beyond stage 1 thinking. You have to actually think, if I section all breaches, and then what? And this is where the inquisitive mind would want to go, is to find out, what am I actually doing? But the oblivious mind just wants to go about their business and do it because it's easier, and they think it's safer, or they've convinced themselves that it's safer. So cesarean section is essentially deferred risk. By removing the neonatal risk of the first baby by cesarean section, saving those 19 babies, really all you've done is move risk to future babies and put the mother at more risk. That's all you've done. And ultimately, as we'll say many times through the 2 days here, whose decision is it? Belongs to the mom. And how can the mom make an informed decision if you haven't told her this information? If all you told her is breech is dangerous and the baby's head will get stuck and nobody does breeches anymore. Okay, I'm going to skip these 3 slides. Just want you to know there's a new paper that just came out last month from a Swedish study. And there's a lot of flaws in the study. And I put this together because it confirms that C-section is better for breeches than vaginal delivery. And so confirmation bias is going to say if there's a program that doesn't want to do breech delivery, they'll start quoting this article. But this article has a lot of flaws. And the only message I want to say about this article is, how should we interpret a study? Should we read a headline in the newspaper, or should we, as most of us do, should we just read the abstract and then scroll down to the conclusion section and skip the results and material and method section? Because the material and method section is the meat of a paper, but it's the driest, boringest part. But ultimately, you got to know how good, you can't tell how good a study is until you read the material method section. Because the conclusion might say something, and then you find out there's only 12 women in the study. But if you read the abstract and you read the conclusions, you wouldn't know that. So don't make the mistake of looking at a headline in the New York Times or whatever. What's your big paper in Australia? Or whatever it is, right, okay. Don't.
Is this peer reviewed?
What's that?
Is this a peer reviewed article?
Oh, of course it's peer reviewed. God, you guys are not going to let me get through this without going through it right. Okay, all right. We got more time. I mean, I can go through this with you. So let me just, I'll let you read that one because it's just the introduction. And I'll just read the conclusions that it says planned vaginal breech delivery was associated with an increased risk of neonatal mortality. And God, I was trying to go faster, but and short-term morbidity compared to planned cesarean breech in accordance with the new guidelines. So we'll talk about that in a second. So but they also are very good about saying the potential risks of doing cesarean section should be discussed against the potential benefits and stuff like that. Their strength and limitations section in their paper is very good, whereas a lot of papers don't have a good strength and limitations section. So you have to read the material and methods section, and you have to read the results section to be able to scrutinize a paper like that. So ask questions, by the way, like the ARRIVE trial. Can the results of this trial be relatable to the way your hospital practices? And most of the time the answer is no. Yet, that will not be considered. What would be considered is that, oh, there's a study that shows that C-section's better. That confirms my belief. I'm going to believe this study. I'm not even going to look at it. So I have a group. I have a WhatsApp group with a bunch of breech practitioners, I hate to use the word providers, but breech doctors that we share a WhatsApp group. So when something comes out, so I saw this article. I sent a WhatsApp message to people and asked them for their thoughts on this article, and I got a bunch of messages back, and here's just 4 of them that I got back. So this is from Anina, who is a Brazilian OB, believe it or not, a Brazilian OB who does breech delivery. It's like, wow, okay. So she said, I have to read it again, but at first glance, I've noticed some disturbing things in table 3. 40% use of epidurals in the study. Now that's actually fairly normal. So that, I mean, Frank Lewin's papers and stuff like that had about a 40% epidural, but they used 80% use of augmentation with Pitocin in their breeches. Most of us in the breech world believe that breech labor should start spontaneously and progress normally, and if they stall out, unlike with a head-down baby where they might stall out at 7 centimeters and you put the woman to sleep, or you have her go for a walk, or you have her go make out with her husband, or whatever we do, with breech, if they stall out, that would be a sign that maybe they should go have a C-section. It's not an unreasonable thing to do. But they put 80% of these women on Pitocin, or synthetic oxytocin. And I don't know, the 25% episiotomy rate doesn't mean anything to me. I don't even know why that's relevant. How was labor assistance performed that they've had so much intervention happening? And here's something that is remarkable, because in the term breech trial, some of the worst injuries of breech babies were babies born by cesarean section. Here she says, I want to go there and learn how they performed 842 cesarean sections without any neonatal injuries or difficult extractions. So, I mean, she jokingly says they're probably very good at cesarean section, but still, you can be very good at cesarean section, but you're still pulling out a lot of breeches and you're not injuring a single one. That's surprising. David Hayes says, he says some of this. He says, this is a new program at one center in Sweden after they essentially had stopped practicing breech for many, many years. And then they brought in a protocol which is called the OptiBreech protocol, which is the algorithmic protocol of Sean Walker and Anka Ritter, which is very time-oriented, restricted. We'll go over the algorithms later this afternoon. And I'll show you that they're very rigid, time-based, and interventional. And then she says, but in reference to the epidurals, he said both Promoda and Frank Lewin's study had about a 40% epidural rate, but only about a 40% Pitocin augmentation rate. He said that much fewer, he says the 3.2 composite morbidity, of course they use composite morbidity, guys. What does that mean? All right, it's way too high. That's from David Hayes. You guys all know David. He's with Breech Without Borders if you don't know him. And then this is from a woman named Carolyn Reese, who's in our group, and I actually don't know who she is, but she's in our group. So she said, The study stopped after, they had one perinatal death in the breech thing after 225 births. They wanted to do 350 breech births. They only did 225. And so again, can you imagine them stopping a cephalic study because they had one intrapartum death or neonatal death? No, they would never do that. With breech, suddenly, they're so close to triggering to be, because they're scared. So what kind of care was provided? And then this is from Nathan Riley. Nathan Riley is a physician in the United States he's the one who put together the recent Kentucky Breech Conference that we had there. And he said some very wise things. He said there are very narrow windows of times for the second stage based on the OptiBreech protocols of Sean and Anka. Suggested probably a number of planned vaginal deliveries were converted to planned cesarean deliveries, partly because of bias of the staff. They were much more comfortable with doing a C-section for it, so they were very quick to trigger these women into having C-sections. We all know that patience in the second stage is sometimes required, and they were given 30 to 60 minutes in the second stage, and that's not always enough time to birth, especially when 40% had regional anesthesia and they were in a scary hospital setting. And then lastly, he says what I say, which is that the fatal repeated error of only being considered of neonatal morbidity and mortality with regards to deciding between vaginal delivery and cesarean delivery. So how useful is the hypothesis to begin with when we know there is more to this conversation than neonatal outcomes, which you talk about. So then the study also said, in the study, every woman had an ECV. So think about that for a second. You got a baby that's been sitting breech for 8 weeks or 10 weeks or maybe the entire pregnancy. And then you try to push that and pull that baby out of the pelvis. You've changed something. You've changed the position of the baby. You've maybe decreased station. You've done something. Every single woman had ECV. That skews your data. It's got to skew your data. And then infants born in the planned vaginal delivery group had a higher gestational age, which again, we already talked about. The longer you go in pregnancy, the more likely you are to have potential problems. And they had lower birth weight. So maybe there was something wrong with these babies to begin with. I don't know. And then primips made up 71% of the planned vaginal delivery group. And primip success rates and other things are going to be less than multips. We'll see that over the weekend. How did they get what?
100% of women consented to an ECV.
Good question.
This is not how they explain.
Yeah, they don't explain that. They just said.
The women that declined the ECV then got excluded from the study.
Yeah, they just said everyone had ECV. By the way, these are when I take stuff on this stuff. This is cut and pasted from the article, so it's not like I might have deleted some sentences, but I didn't edit this. This is all just cut and paste type stuff. So interesting, they did find something that I find really useful. They required pelvimetry on all the women, which is X-ray or MRI pelvimetry, but only 76.4% of it had pelvimetry and the other 23.6% did not. And they found that there was no difference in outcomes. So that makes me very happy because it shows, in this particular case, not that what they wanted to show, but that pelvimetry is useless. X-ray, imaging pelvimetry is useless. They said there's a higher risk associated with planned vaginal delivery in our sample as compared to that in, say, the Promoda study. May partly be explained by differences in the experience of the managing vaginal breech So they're admitting that their skill level was lower. This is the part that I really liked about them. They did say some really nice things here. It may be tempting to conclude that because planned cesarean delivery is safer than planned vaginal delivery, vaginal breech birth should be abandoned in favor of planned C-section. However, the increased risk of vaginal breech deliveries have to be weighed against the risks of performing more cesareans. Notably, augmented risks associated with repeat delivery after cesarean include abnormality of invasive placenta, uterine abruption, significant blood loss, abdominal adhesions, and organ injury. Now, how many breech papers ever said that before? So I admire them for that. Furthermore, by removing the option of vaginal breech birth, women's autonomy would be limited, since patient autonomy is broadly recognized as an ethical value in maternity care, not offering the option of somebody's laughing at that. It's not broadly recognized?
They had to write it.
What's that?
We're just laughing at the irony of the statement.
Say that again.
Sorry, just laughing at the irony of the statement.
Oh.
Not that it's absolutely factual yet.
Right. No, I actually think these people sincerely believe that, but I don't know Sweden's birth culture at all. I believe that they were actually trying to actually do this, but I don't think they understood breech very well, and they're doing it in a hospital setting with 80% of women having Pitocin. That's not how you should be doing breeches. Anyway, you can read the rest of that, because I can't, because my eyesight's too hard for me. And they said, being a single center observational study, the restricted sample size, the demographics, the time frame led to a lack of generalizability, as these may not reflect the diversity found or be representative of other settings. How fair is that to say that? That's a really nice thing to say. They said that our findings may not be generalizable to other settings. Will people who want to continue doing C-section for breech read that paragraph? And no, they won't. Oh, and they asked, it said, the guiding principle being that it is better to err on the side of caution. I love the fact that they put that in there, because that's one of my slogans, is ridiculing err on the side of caution, and strictly adhere to more narrow selection criteria. And my question is it what should be the guiding principle? What's the guiding principle, everybody? What? What does a woman want? What does a woman? That's the guiding principle. So why does one flawed study, the term breech trial, still have such a profound effect and lead to such heavy confirmation bias? Again, the reason I'm going through all this stuff in detail is because when you know this stuff and you have a client who comes to you with a breech birth, and you may not be able to take care of her, but you can certainly now give her insight and information as to how to seek information so she can make proper consent from the doctor or the team that's going to be taking care of her. And a lot of us, we're stuck in a world where I get asked, you should see my inbox every day. I'm asked advice all the time. And I obviously can't give specific advice to anybody. I haven't done their history. I don't know them. I haven't put my hands on them. I don't know. But I can certainly give them ideas of where to look and what to do. And so I feel like I'm helping them by that. And this is sort of why I'm doing this, because I want you to do the same thing. So in 1978, I finished my college, and I was going to start medical school that fall. And I wanted to take some time off. So I took my little Chevy Nova. It's a car, they don't make it anymore, but it was a Chevrolet Nova. And I drove it 8,000 miles from Minneapolis out to Seattle, and then all the way down to San Diego, and then back through all the national parks in Arizona and southern Utah, and had a great summer. It's probably the best summer I've ever had, because I was in my 20s, I was physically fit, and because otherwise for the rest of my 20s I was in school or residency. So I didn't really experience my 20s, and a lot of doctors and people who go through that training feel the same way. But in those days they didn't have Bluetooth, they didn't have CDs, they didn't have cassette players. Essentially I had like a Walkman, and I had 2 cassettes. And I listened to, one of them was Boz Scaggs. Probably don't even know who Boz Scaggs is. The old people are nodding, and right? And the other one was Simon and Garfunkel's Greatest Hits. Some of you don't know who Simon and Garfunkel is. Okay. But they were songwriter poets, the Simon and Garfunkel were, and their lyrics are pretty interesting if you pay attention to them. But I would sing along with their songs as I'm driving through Wyoming, and one of the songs I sang 1,000 times was a song called The Boxer. And you may know The Boxer. If you don't, you can listen to the lyrics. But in the first stanza, there's a lyric that I probably sang 1,000 times and never really paid attention to what it meant. But it goes like this, and it's a perfect definition of what cognitive dissonance is. They say, all lies and jest, still a man hears what he wants to hear and he disregards the rest. So that's cognitive dissonance in a nutshell from a poet. Cognitive dissonance is used to describe the feeling of discomfort that results from holding 2 conflicting beliefs. So cognitions are thoughts or beliefs. Dissonance is difference between them. What we really want in our lives are consonant cognitions. So by being here today and being surrounded by the loving people who we share things with, we feel really good. If we were sitting in an auditorium filled with doctors talking about how stupid home birth is and VBAC is terrible and all that stuff, we would be starting to get anxious and feel a set of cognitive dissonance. And there would be ways that we would try to cope with that. And so there's several ways to cope with that, but earlier I asked, knowing all the facts that we've reviewed so far, why do OBs still cling to this model and vehemently discredit other models? And that's because there are 3 key strategies to dealing with cognitive dissonance. Another simple example of cognitive dissonance is that, say you feel like you're on a diet, you feel like you feel sort of fat, all right? But you're sitting in a conference all day long and they bring out brownies for the coffee break. And it's like, God, you know, I really shouldn't have that brownie, but I think, well, okay, so tomorrow I'll start my diet, or tomorrow I'll do something. So you find a way to justify eating that delicious coconut brownie. I just went through that a minute ago. And I'm feeling very guilty about eating that coconut brownie, okay? So there are 3 ways to deal with that. One is an obvious one, and that's to focus on the more supportive beliefs that outweigh the dissonant belief or behavior. In other words, cherry pick your data. So that's a confirmation bias. It's a form of confirmation bias. And just convince yourself that C-section is safe. Listen, I've done hundreds of C-sections and I've never had a problem. You don't know that you weren't the doctor that did the C-section on the woman that ruptured her uterus 2 years later. But you've never had a problem. So you convince yourself that it's safe. Yeah. What?
The brownies are refined sugar-free.
Oh, God.
Calorie-free. That's what we want. Calorie-free brownies.
Calorie-free brownies, right. Right.
Enjoy them.
Right. They actually burn calories.
Yes.
There's actually fen-phen in them.
Yes.
Or Ozempic was in my brownie, right?
Yeah.
Okay.
But our oxytocin levels are
Yeah. Okay. See? Okay, good. Thank you. Okay. This is the common one, is to reduce the importance of the conflicting belief. So you can just convince yourself that breech birth is dangerous. You don't have to think about it. Or you can say that anyone who does breech delivery is crazy. That makes you feel fine, because then you've now rationalized in your mind why you not doing breech delivery is okay. And this is what goes on every single day in every doctor's office. And the last one is it's sort of a rationalization in another way. You say, yeah, I mean, breech birth is a reasonable option. However, I'd like to support it, but my partners won't let me, or my hospital won't let me, or my insurance company won't let me. And so rather than fighting for it and fighting for your client, you just acquiesce. And this is a way that we all deal with our cognitive dissonance all day long. You can take anything that's in your life that is conflicting for you, and you can feel like I do one of these things to try to make it tolerable. Okay. 2 other things I want to talk about why doctors are the way they are. And one of them was something I really didn't know much about. I'd always heard about mass formation psychosis when it came to what happened in Nazi Germany, and how it is that people that lived neighborly with Jews, Jews were always persecuted there, but people lived neighborly with them. Their kids played with them, lived on the same block and houses next door to each other. And with a matter of about 5 to 7 years, not only did they not live peacefully together, but they turned them in to the SS, and then they went in their houses and stole all their furniture. So it's like, how does that happen? How do good people who live neighborly, and then you saw it during COVID. You lived next door to a neighbor who was very fearful of COVID and you weren't, and got mad at you because you weren't wearing a mask in your backyard, or called the authorities because you had 4 people over for a barbecue, and that sort of thing. And then you're supposed to live next to that person for the rest of your life. Why do they do that? And it's something, Matthias Desmet wrote a book in 2022 about the COVID thing, but he related it back to all sorts of things in history, where masses came in, the witch trials, other things like that. How did they suddenly convince you that this woman that had been helping you in your community and giving and healing your children and stuff like that now needed to be burned at the stake because she's a witch? How do they do that? Something called mass formation. It's a totalitarianized population. Pressure, the Spanish Inquisition comes down. And, they're persecuting whoever, I don't remember the whole details of it, but so people, they don't want to piss off these people, so they become, slaves to them. They become turncoats. They want to join with them because they realize that if you can't beat them, I better join them, because otherwise I'm going to be the next person that's burned at the stake. And so they sacrifice their own personal beliefs and interests to be part of a collective. And we see that all the time. a profound intolerance of dissonant voices. So not only is it enough that you yourself are giving up your individuality, but if somebody else is keeping their individuality, that upsets you greatly, and you need to quash them and shut them up. And we saw that last 3 years. And pronounced susceptibility to pseudoscientific indoctrination propaganda. So that's one thing that doctors who feel helpless inside a system, who know that they're just a cog in the wheel and they could be fired, not if they didn't get their COVID shots, but fired if they advise a woman that she can have a breech vaginal delivery, or advise a woman that she can go past 41 weeks, or advise a woman that in a hospital that bans VBAC, that VBAC is really a reasonable choice, and you can show up at the hospital and decline. And when they get to the hospital and the nurses ask them, well, why are you here? Well, my Dr. Jones said I could decline it. And then Dr. Jones gets called in on Monday morning and says, you better not be telling women to do that anymore. So you eventually get beat up and you surrender your autonomy. And a good example of that was called Ash's conformity experiments. I love looking back at history. And I never heard of this, but I was doing some research on this and I came up with this, and I don't know if you've ever seen these drawings. But what they did was they did an experiment where they put 12 people in a room and they gave them a drawing that looked the one on the left, and they said to the 12 people, which one does it match? And the first few times around, everyone said it matches C, which you'd all agree with, right? But in reality, 11 of the 12 people were in on it. And after the third or fourth time around, they began saying something different. And they tried to see how long a person would hold out to their own beliefs versus realizing, am I missing something? What's going on? Everyone has said that it's B, but I know it's C. And they said by the 10th time around, 75% of people would say something that was knowingly wrong to be part of the group. That's frightening. What's that? Yeah. Right. Right. I mean, it's frightening. You know, there was an old Groucho Marx, I think, said at one time, who are you going to believe, me or your lying eyes? And ultimately, that's true. If you are told something over and over enough, and everyone around you is agreeing to it, what percentage of people can hold out? And it actually is about 25% of people that will hold out. In my country, about 30% of people did not succumb to the propaganda about COVID. Your country was less because you have more totalitarian nature in your country, and you don't have the history that I have with my country, which is the Revolutionary War and all that stuff, and you don't have a Bill of Rights and a Constitution like we have. So, but still, 70% of people went along with it. And if they redo it again next year, it won't be 70%, but it'll still be above 50% that will still go along with it. They won't learn from that. So these are the reasons that things happen. And so, I'm not sure I say his name right, but is it Nietzsche? 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 How do you say that name? What? Nietzsche? Okay. Friedrich. Let's say Friedrich. Okay.
Call him Fred.
Friedrich says, madness is something rare in individuals, but in groups, parties, peoples, and ages, it rules. And we've seen it if we look at history of mankind. Madness will spread. The individual person goes home to his family or her family and they're not mad. But madness can spread through that. And it really spreads to people who are beyond your line of sight. In other words, your close family, you may be able to keep together. But people that aren't your close family, you have very little loyalty to them. And you will turn them in a second. And then, of course, Solzhenitsyn said, the simple step of a courageous individual is not to take part in a lie. So all of us here need to follow what he's saying. We can no longer sit back and watch. And we're going to put ourselves in peril at sometimes. But if we're going to fight for what's right for our clients and give them the information and trust that we believe in the sense of autonomy and decision making belongs to the woman that we're caring for, then we have to not take part in the lie anymore. Has to stop.
Science and psychology shows that women are more likely in groups to follow each other as well, so because of the family system.
Yeah.
In friendship groups, if one says this, then they will follow it.
Yeah, what she's saying is that women are more susceptible to that, but that's because you're more of a community culture. Men are more solo, and you know, men don't do that. Men like to go and they like to play sports and stuff like that, but they don't just get together for tea with other men and to talk about their day. It's not something that men like to do, right? We just don't. All right, so then Melanie Jackson, before I came to Australia, I was looking to Melanie and I was just reading some of her stuff and listening to some of her podcasts because I was going to meet her and I wanted to know a little bit more about her. She started, and one of her podcasts or something she wrote talked about authoritative knowledge. Maybe you guys know this because she's one of your country persons. But authoritative knowledge is what, you know, the white coat, what we call the white coat. It's not called the white coat syndrome. That's where women fear doctors, and it's actually appropriate. But it's where the white coat has a position of authority. They're standing up, you're in a bed. They have this level of authority simply because they're the doctor and you're not. But it's subliminal and it's actually overt. It's subjective and not necessarily truthful. Many, many doctors know far less than you do. Yet we give them a position of power and we actually become submissive when we really shouldn't. So she says, awareness that the psychology of those indoctrinated to a cycle of fear and intolerance, like doctors, this is for doctors, does not allow the doctors to see the results of their work as the problem. And some of you mentioned that earlier. Why are the C-section rates so high? Oh, the women are fat. The women aren't following our instructions. Women's pelvises are narrower. They're what?
They won't push.
They won't push properly, right? Okay. So it's really not them. And these, again, the reason I'm bringing these things up is so that when we have interactions with our OB colleagues, our job is not to alienate them, our job is not to educate them, but our job is to sort of try to understand where they're coming from and try to work through that to get the best thing we can for our clients. And maybe some of it will rub off on them, like it did to me early on. Just talking to midwives, it made sense to me. If we have that opportunity. Right now, the silos are pretty thick, especially in my country, where there's very little commingling of the ideas. It is imperative we are to change the culture toward multiples and so much else in the birth world. Our focus needs to be on spreading awareness that these biases exist. And the last thing about this is something called the medical gaze. She also talks about that. You guys heard about this? Any of you haven't? Because I hadn't heard about it. Well, a guy named Michel Foucault developed the concept of medical gaze, describing how doctors, and again, a woman comes to your office, start telling you her history. What happens is the doctor's only hearing the word breech, like the story I told you before. The doctor is taking out the medical aspects of her story and missing the rest of her story. Because maybe it's because of limited time, maybe it's because how they're trained, communication skills, but whatever it is, they're not seeing the person as a whole. They're seeing the person's problems. And so what happens is that the real subject of the clinical gaze is not an afflicted person, but an affliction. So the real problem isn't a woman with breech, it's breech. Or twins. Or VBAC. Or diabetes, or whatever. They see the disease. They don't see an individual with the disease. And therefore the disease is algorithmic. Everyone with the disease gets put on this hamster wheel. Whereas not everyone with diabetes or breech they're the same. Yet the algorithms are the same for the medical model. And what's really sad for me is that nurses and doctors go through years of training. And they're trained to think and they're trained to know and diagnose things. And they come out of all that training, spending all those years, and then they can't practice as they want because they go into a system that has already pre-formed algorithms. So why the hell did they need to go through all that training? To just follow an algorithm? And I understand the technical stuff, like, you know, having to learn surgery and stuff, that's fine. But the thought process, they're taught to think, and then they're given a license to think, and then they're told you can't think. Not to think?
I don't think medical schools, they're not teaching people. Nursing school definitely is.
They're just they're memorizing things and then just following the algorithms.
I got a doctor yell out, a client was telling me, and the doctor was like, my client was having an anxiety attack. I was in bed. She was saying that, but then a doctor and a midwife was like, we know that we have to follow the machines. So they discontinued a different protocol for sepsis instead of just listening. Because the machines tell us otherwise. So they couldn't think out. They were like, we just have to follow the machines.
Right, right, and we see that every day with things like GBS. Now, in your country, do you still screen all your women for GBS at like 36 weeks or whatever, maybe early, doing an early GBS? You know, in Europe, they don't screen for GBS in many of the countries there, right? They treat based on symptoms. Premature rupture of membranes, fever, fetal tachycardia, those sorts of things, prolonged rupture. But in my country, the same thing. And they give antibiotics like it's candy, without any thought that there's a consequence to giving antibiotics to all these women and babies. And go ahead, were you going to say something?
Sorry, it starts in high school, yeah. It's not even university. Like, my daughter just finished.
That's not going to help me any, unfortunately.
No.
No, I mean, you can do it for the people at home, but I can't. I'm just having a hard time hearing you.
So I was saying it starts in high school, this rote learning, not questioning anymore. Like when I went to high school, you still were taught to question everything and to kind of weigh up both sides of it. This is just
yeah.
And my daughter's just finished year 12 and done biology, and for example, when COVID vaccines were introduced, they were no longer allowed to discuss natural immunity. They could only discuss immunity from COVID vaccine.
Yeah.
And that was in a star school.
It's almost critically big school.
That's right.
Wow.
Yeah.
Yeah. And it creates but that was so many parts of like when she was doing year 12 biology, she'd come home and say to me, I don't get it, I'm not allowed to ask questions, I'm not allowed to have an alternate perspective, it's just that this is what you're going to learn. If you don't answer those questions the way we've formed them in these
You're going to fail.
environments, you're going to fail.
Yeah.
That's it, and they were told.
Yeah, you're not going to get through college if you were a conservative. You write an essay saying you think Ronald Reagan was a great president or something like that. You're not going to be able to do that. It's understandable, and that's why they're already creating an alternative economy, an alternative. You know, that's why homeschooling is growing by leaps and bounds in my country, because half of my country, or more than half of my country, at least has common sense, but the people running the country and running the education system do not have common sense, and so they end up. If you send your kids to school, you can be sure that they're going to hate you. If you have conservative values and you send your kids to college in my country, they're going to come back after 4 years and hundreds of thousands of dollars out of your pocket. They're going to come back hating you, right? That's what happens, and that's an interesting thing when it comes to who gets into medical school now, because people. I think I talked about this last night, but my initial thought, and people would always say to me, "What happens to good people go to medical school? What happens to them in medical school?" And the thought was that medical school residents they just get pounded on, and it gets pounded out of them. And they become sheep. They go into shepherds and they become sheep. And that was probably true when I was a medical student. But then someone said to me last year or the year before, they said, no, that's not it. Medical schools are not allowing shepherds into them anymore. They're weeding them out before they even get there through the application process because they only want sheep coming in. The question is, how did people who weren't sheep, who are now leading these medical schools and these education and their education czars or whatever you call them here, they were not those kind of people. How did they suddenly just become that way? And again, it's part of it is the mass formation, it's conformity, they want to be part of something. They think that this is the way to achieve because somehow over 50 or 60 years, there was a guy named Yuri Bezmenov. He was a Russian defector. And if you watch him on YouTube, he comes out and he says, he's being interviewed in the 1970s or maybe it was the 60s, by a commentator on US television. And he says, the Soviet Union will never conquer the United States. What will happen over the next 50 years or so is exactly what's happened, is the United States will eat itself alive. and we'll affect the family, we'll affect the schools, we'll deny religion, we'll do all the things that we can do, and then slowly but surely it will eat itself alive. We'll divide people by race, gender, and class. We will destroy boundaries, we'll destroy identities, we'll do all these things, and that's what will happen, and it's exactly what happened. So, again, the only way really the United States to fall was the way it's falling now, which is from internally. And it's the same thing. If your kids can't ask a question, like the very first slide I showed today, science, you have to be able to ask the questions. If they can't ask about natural immunity, you get your kids out of those schools. We're going to have to make alternative schools. And the government will come down and say, well, you can't educate your kids in an alternative school. And then you're going to have to find a new government. There's going to have to be an uprising. And hopefully it's peaceful. And hopefully, you get another 40,000 women that storm Canberra with their babies in their pregnant bellies. And they say, listen, we're not leaving. We're going to give birth on the steps here. All right. We're going to come to your house and we're going to sit outside your house. And we're going to sit here until you get some common sense. So, that's what's going to require it. Problem is most women with pregnant bellies and babies don't have the time to go to Canberra and sit there and do that. Right. Okay. Let's keep going because how are we doing, guys? 20+1. It's already 1:20? Yeah. You can see how the day just goes, all right? I'm going to try to move along quickly. I'm going to skip all these because, all right, so this is good. So what is practical in real time? So this is important. This is the Royal College of OBGYN, and these are the best guidelines out there. And the reason they're the best guidelines out here is because I have confirmation bias, okay? Because I think they're the best guidelines out there. Because they tend to offer all things that you need to know, as opposed to the American College guidelines. RANSCOG's guidelines are not very good either. Okay, so in general, this came out in 2017. Women should be informed that planned vaginal breech birth increases the risk of low APGAR scores, absolutely true, and serious short-term complications like NICU admissions, things like that, but has not been shown to increase the risk of long-term morbidity. Important to know. Think about, again, as I say these things, think about what the OBs you've seen counsel women on breech birth have actually said to the women, and then think about these. Where a woman presents with an unplanned breech labor, management should depend on the stage of the labor, whether factors associated with increased complications are found, availability of appropriate clinical expertise, and informed consent. So in other words, if a woman comes in advanced labor like Elizabeth, we should give her all the options and we should be prepared to deal with her in the best way we can. Now, if there's nobody there that knows how to do breech delivery, then a C-section might be the best choice. The problem is there should never be a labor and delivery unit where no one knows how to do breech delivery. Because you're talking about 1 out of every 25 babies that come in, theoretically, if it's 4%, are going to be a breech baby. And how can you have a labor and delivery unit that can't take care of 1 out of every 25 women that walk in there? So they went on and said this, which no other guideline says this. They said this: all maternity units must be able to provide skilled supervision for a vaginal breech birth where a woman is admitted in advanced labor, and protocols for this eventuality should be developed. That was in 2017. That's Rick's term. And we'll talk about it again when we talk about breech birth this afternoon. Or maybe it's twin. It's in the twin birth paper. We'll talk about it tomorrow, what sugar effect means. But you can figure out what it means, basically. Okay. Women should be informed that planned cesarean section leads to a small reduction in perinatal mortality compared to planned vaginal breech birth. That's true. Any decision to perform a cesarean needs to be balanced against the adverse consequences from the cesarean. Should be able to tell women that. So what is the actual risk reduction for doing a cesarean section for breech? Because we keep hearing that it's better for babies, but we actually had to put a number on it. I don't think we put a number on it today, have we? Okay, so let's do that. So they actually go on and say this. The blue is my conversion of it, but they say this: women should be informed that when planning a delivery for a breech baby, the risk of perinatal mortality is rounded to, or approximately 1 in 2,000 or 0.5 per thousand with cesarean section at 39 weeks or beyond, and approximately 2 per thousand or 1 in 500 with a planned vaginal breech birth. So the risk of a neonatal mortality with a planned vaginal breech birth is actually 4 times higher than it is with a planned cesarean section at 39 weeks or so. And this compares to approximately 1 in 1,000 risk with planned vaginal cephalic birth. So a vaginal cephalic birth is twice as risky as a C-section for a planned vaginal breech birth. A C-section for breech. So what do those numbers actually mean? Because you're getting relative risks don't mean anything. Let's look at actual risk. So the risk of these things not happening, with a C-section for breech, you have a 99.95% chance you're not going to have a neonatal death. With a breech birth, you have a 99.8% chance of it not happening. With a cephalic birth, you have a 99.9% chance of it not happening. If you gave those numbers to most women, you'd say, do you think, what's the difference? They would say, not much. And you could say, well, it's actually a 4-fold increase. 99.8 to 99.95 is a 4-fold reduction in risk from those two numbers. But it's still not much if you actually look at the actual risk. But here's the real kicker with those numbers. What's the difference between a vaginal breech birth and a vaginal cephalic birth? And shouldn't we be comparing those two rather than cesarean? So for every 1,000 cephalic births that you have, you'll lose 1 baby according to this number, and every 1,000 breech births, you'll lose 2. So what doctors are actually saying when they say section all breeches is we're going to section 1,000 women to save 1 baby. 1 baby. Now, some people may think that sectioning 1,000 women to save 1 baby is a good thing because they don't understand the risk we talked about earlier of how many women we're going to kill and how many babies we're going to kill in the future and how many morbid things. But a lot of women who hear that you're going to section 1,000 women to save 1 baby, and they would think you're out of your freaking mind. But they don't know that. But we do. And we need to let our women know that that's what they're saying. So when they go to the doctor and the doctor says, oh, it's really risky to have a vaginal breech birth, the woman can say, can you tell me how risky it is? And they'll say, very risky. Because honest to God, they do not know. How do I know they didn't know? Because I didn't know. And I was a breech practitioner. I didn't know these numbers until I read this when it came out. So there's a very important piece of information there. Secondly, it says, so selection of appropriate pregnancies in skilled interpartum care may allow planned vaginal breech birth to be nearly as safe as vaginal cephalic birth. And in our experience, it is. There's a slightly greater risk of morbidity, but the mortality is only 1 extra per 1,000. Women should be informed that cesarean section increases the risk of complications in future pregnancies. ACOG's guidelines don't say this. I don't really think RANSCOG's guidelines do either. Including the option of opting for VBAC, the increased risk of complications of repeat cesarean, and the risk of abnormally invasive placenta. The Royal College guidelines say that. And then lastly, they say clinicians should counsel in an unbiased way. Can you actually counsel in an unbiased way? No, you can't. Everybody has a bias. But when you're counseling, you should admit what your bias is to your client to ensure proper understanding of the absolute as well as relative risk of the different options. And you have to go thinking beyond stage 1, asking if we do this, then what happens? All right. Oops, wrong button. So, in summary, properly selected vaginal breech birth is a reasonable option. Neonatal death, actual risk is quite small, as we just showed you. But it's not the only endpoint. And we all know that. Midwives know that. Sectioning all breeches ignores downstream consequences. Vaginal breech birth options honor the pregnant woman's rights. Mother Nature has a reason for her design, and messing it with will have ripple effects. From the very beginning, when you mess with Mother Nature, you need to prove that your interventions are safe before you do them, and we don't do that. And because of time, I won't get into these, but we already talked a little bit about the RIVE trial. We talked about how does epidurals interfere with the whole thing, and also, like in my country, clear liquids, just in case. These are things that we're messing with Mother Nature's design. And when you only give a woman clear liquids, what's the chance of her having success? And when you mobilize her in a bed and you put belts on her, and people are constantly coming in and checking on her and interrupting her, you're messing with Mother Nature's design. And then in my country, we have these protocols in the nursery and NICU where, like, if a woman is diabetic and she delivers a baby and the baby's perfect, they have a protocol that says the baby needs to spend 4 hours in the NICU to be observed, which is like the stupidest thing you could possibly do. So just to summarize it, this is poor Melissa from Maine. This is from my inbox a year or two ago. And I just want you to exact that, because pretty much every bit of gaslighting you can possibly think of happened to poor Melissa in Maine. So let's just go through her story a little bit. And she doesn't use punctuation much. My mother would be appalled. My mother was an English teacher. So I have a hard time when I read these things without punctuation. I actually try to, when I respond to people, I try to put commas where they're supposed to go, and I do, so because, again, I have this OCD from my mom. My printing on that old paper, you know that paper that used to have the lines with the little blue dotted line between them, and you'd write your H's, and the H would have to go right to the little blue dotted line? Yeah, mine were perfect, just perfect. Now my handwriting is horrible. So, by the way, they don't teach cursive much anymore, do they? Yeah. Hello, I'm 39 weeks pregnant, and I'm trying really hard to find someone who will deliver my breech baby. But my providers have been scaring me, although I don't know if what they are saying is true because their reasons keep changing, and they aren't actually reasoning with me. They're just telling me my worst case scenarios, but, comma. I wanted to know what you think because I know you support breech, and as someone who does, you aren't going to be biased. So the first thing I want you to know is what? I'm going to be biased for sure, but I'm going to be honest about my bias. They told me my baby's head specifically is too big to have her as a breech. So you've heard this before. So these were what the numbers showed. So the baby's BPD was in the 5th percentile, but the OFD was in the 99th percentile. So what does this baby have? Baby has a dolichocephalic head. It's an oval-shaped head. Why does a baby who's been breeched for a long time have an oval-shaped head? Because the head is shaped like the fundus of the uterus. That's what happens. Is the head going to stay like that? Do we see breech babies walking around at age 7 with dolichocephalic heads? No. The head is mobile, it moves, it molds, right? So those were the numbers that they had. And the baby's estimated fetal weight at 39 weeks was 2884. Is that growth restricted? No, it's small, but it's not growth restricted at all. Not even close. It's they say it's in the 14th percentile. So what did they do? They circled the one abnormal value, which was the OFD, and they said that they were telling her head was too big, but this woman is smart, and she says, but I know what matters is the head circumference. As someone who does breech births, would this be a baby you would consider delivering? Are they just, or are, they forgot the word. I mean, this is cut and pasted, so it's not my English. My mom can be happy about that. Are they just trying to scare me? They're saying it like she's definitely going to get stuck. And like the baby's body is definitely going to descend even if I'm not fully dilated. By the way, get this, she's a multip. Okay, first you're thinking that she's a primip and they don't know anything. She had a successful all-natural first birth, and they said I have a good pelvis for having babies. They told me what comes out first is what causes the cervix to dilate. So if the body comes out first, I won't be dilated enough. Is this true? Should I even attempt to find someone who will, or just give up and have a C-section? I really don't want one. So let's grab Sophie here for just a second and just reiterate something. Next time you're at a birth, whether it's a head-down baby or not, you take out your tape measure at the end and you measure the head circumference of the baby. Then take the same tape measure, could be a different one, I guess they're all the same, and go around this area. Or get rid of one leg and just say it's incomplete breech and go around this area. And you'll find that generally the circumference of this area is bigger than this area, even in a 6-pound, 6-ounce baby. They don't know this because they don't know anything. And so what they visualize is they visualize a preemie baby coming out with the head getting stuck, which it can happen. But a term pregnancy, you're not going to see that happen. And when a head does get stuck in the uterus, when the baby gets out to the shoulders and the head, they can't get the head out, they'll mistakenly call that head entrapment. But head entrapment, by definition, means the head's stuck in the uterus by an incompletely dilated cervix. So it's the wrong terminology. They'll also call anything where they see a foot-link breech, and we'll go through that this afternoon. But they call that an entrapped head. And so this gives them the vision that scares the crap out of people, is that the baby's head's going to get stuck and they're not going to know what to do. But that really doesn't happen with term pregnancies. However, if they don't know breech and they never bothered to learn it, they don't know this stuff. They only know the pictures and diagrams that they've seen of babies with their head stuck in a diagram, and therefore that's been embedded in their brain. So that's poor Melissa from Maine, but unfortunately there's more. So there has to be more to the story. So she says, this gets worse, by the way. They also told me she's still growth restricted, even though she's in the 14th percentile. When last time she was in the 7th percentile, they told me there could be something wrong with my placenta, and I could deliver a stillborn if I don't get a C-section early. They were saying that she wasn't going to grow. That was at 36 weeks. This scan was at Thursday at 38 weeks, and she gained more than a pound, which just tells you the inconsistency and the unreliability of ultrasound. Okay. So then I wrote in the blue, which is my definition of IUGR. I know that the definition changed in 2020, and they changed it to 10th percentile, less than the 10th percentile, or something with color Doppler studies. Maybe I'll get into that later. But to me, IUGR describes a baby that's not growing well on its own growth curve. But it has really nothing to do with the being under 10th percentile. When they changed it to being under the 10th percentile, the Maternal Fetal Medicine Society created much more work for maternal fetal medicine doctors. This is what they did. But you're trying to tell me that 10% of all babies are growth restricted? No. No. Do they look at the size of the mother and the father, and did they look at the size of the mother's previous babies? No. Every baby that's under the 10th percentile is listed as growth restricted now. And by the way, under your new categories next year, even if the baby's been 8th percentile all along, or maybe she had a 5.5-pound baby in her first pregnancy, was labeled growth restricted, but it really wasn't because she's only 5'2", and her partner's only 5'7", and that was a normal baby for them. She'll be labeled as a previous growth restricted baby, and then she'll be categorized out of risk for you guys. This is how it's going to work. Okay. They also wouldn't try an ECV. They said she was growth restricted and didn't have enough fluid. My fluid has ranged from 8 to 12.7. What's normal fluid? 5. If you look at 4 quadrants, it's above 5. If you look at a maximum vertical pocket, it's above 2. So by any measure, she doesn't have diminished fluid. I mean, you understand, I mean, what I said about gaslighting is pretty much everything you can possibly say to a woman to get her to succumb to coercion is being said in this letter. I feel like they just aren't being honest with me. Or they are exaggerating, yeah. There's someone in New Hampshire who might be able to do it, but considering these measurements, would you say it's honestly unsafe? They wanted me to schedule a C-section, but I have been saying no. I want to wait until I'm in labor, and if she's still breached, then I'll do one. I still don't want to, but it's my only option, they said. And they said it's super risky to wait for labor. What do you think? Okay. So I wrote back to her, and I hadn't heard back from her in a while. Finally, I wrote back to her months later, and I said, so what happened? And she finally wrote me back, and I put it in here. And she wrote back this: I ended up switching doctors at 40 weeks because my doctor wouldn't try an ECV. And for some reason, I think they just wanted me to shut up and schedule a C-section. Do you think? Okay. The new doctor tried an ECV. He did the head and the assistant pushing up on the baby's bottom. The head moved, but the bottom didn't. And I think it's probably because the assistant wasn't pushing hard enough. He did not seem comfortable with the procedure. That may be true, or it may be that once the baby's been breached for a really long time and the baby develops a dolichocephalic head, that's going to be really hard to get that baby to move. So I'm not blaming the assistant who wasn't pushing up hard enough. After the failed ECV, they prepped me for a C-section. I felt trapped and devastated, but we went through with it, and we were both okay and healthy. Afterwards, I waited 18 months and got pregnant again, this time a home birth. Everything went well, and he wasn't breech. After that baby, I got pregnant again and just had another home birth in September, uncomplicated, and also in the correct position. All right. So, boy, did they brainwash her. Breech is the incorrect position and everything about breech. But pretty much every, I think the only thing they missed was like the nuchal cord. I think that was about the only other scare tactic they missed. It's a real letter. I got it in the mail. It's like, this is what they do. So lastly, is there any consensus with breech birth? Yeah, there's one consensus with all breech papers. All of them. Term breech trial, Promota, my paper, all of them. And that is this only one. It's the only consensus. And that is planned vaginal breech birth leads to some APGAR suppression in the first 5 minutes. And I don't know why, it's simply the way they come out a little more stunned, and they take a little more time to come around. Oh, is it with Cedars? I mean, I don't know, I haven't done any of those.
I worked as the Caesar midwife, and did heaps of breaches, as you imagine, probably more than 4%. And I was always like, give it a minute, give it a minute, give it a minute. Yeah. And the babies always came.
Right. Well, part of the reason, our 5-minute APGAR scores in our breech study were on average lower than a lot of other studies that were all hospital-based. We were really much the only home birth study. And the reason that they were lower, we believe, is because we didn't have a NICU team coming in and trying to resuscitate that baby at the 1-minute APGAR score. We just let the babies sort of come around as they came around.
Because, Stu, the neonatal the guidelines, the resus guidelines are that if the baby's flat, you should start full resuscitation within 30 seconds. That's what our neoresus guidelines are.
If the baby's, what, you say flaccid, did you say?
If the baby's flat, after 30 seconds, you start regardless of your heart rates or anything.
Right.
But that, I personally feel, and I personally don't lie, that lie with that, with breech babies. Because we know that.
We know that they're, yeah. Right, and they do come, and they come around. And they give you signs, and we'll talk about this afternoon, they give you signs that whether they're doing okay or not. And even when they're doing okay, they might come out with a slightly lower APGAR score, but they're going to come around. And if you want to stimulate them, that's fine, but to cut the cord and take them over to the warmer and do a lot of that stuff, it's about the dumbest thing you can do.
But it's so important that you see the birth. So I've been in situations where the doctors have come in after the birth, they didn't see the birth. Like, we've got a baby that was a minute ago doing tummy crunches and had a trimester cord and was happy, and then it comes out a bit flat, and then the doctor in.
Well, they hit the buzzer on the wall, right? Or
they hit the buzzer on the wall because it's a breech baby being
born. They automatically come in because it's a breech baby, right?
But they come in after they don't see the birth, and then they come in and they're like, oh my God, this baby's flat.
Yeah. Yeah. Look, we're all confirming. I mean, again, this is affirming for all of us to understand that when you see these things, you're not the crazy one. They are the ones that don't know anything. I'll say that they really don't know anything. So the current obstetric model is clearly not working. It's way past time to hope it will. Trusting nature and mastering skills is a good beginning. Speaking out and advocating vociferously is no longer optional for us. Not optional. Don't want to hear that. When are we becoming aware that obstetricians are acting unethically? We need to wake up those obstetricians too. We need to wake them up. And I think we can do it. It's a slow process, but I think we can do it. We need to get to the younger ones first. The older ones are probably beyond hope, but we can get to the younger ones and we can get to the residencies. Yeah.
Have you had any obstetricians come to your?
Very few. Yeah, very few. Breech Without Borders has a little more success with that. They've been in about, maybe between 4 and 8 training programs. They've got about 4 training programs up in the United States where they've trained hospitals who are setting up a breech program. But that's because RICSA is very academically oriented, and I'm not. I'm a clinician. But I had the good fortune last year of joining Breech Without Borders at Northwestern University in Chicago. It's a big university, it's a Big Ten school. And we spent 2 days with the residents, and one of the greatest fun things that I had to do. They were so eager to learn, and yet the faculty were so resistant to letting them do these things. But they at least had the day where they could be that person that if Elizabeth had shown up in labor, they would have said, stop what you're doing. Turn her over, get her on all fours, and let's see what happens. And that baby would have just rotated and come out and probably fallen on the bed. Right. Okay. So I'm grateful that you're all chosen to be here. So thank you for being here. Let's have lunch. Sounding certain does not make your sound certain. It's important to understand that when people talk with authoritative knowledge, doesn't mean that they actually know what they're talking about.
Did Z-Dog ever come back to you?
No, and either did Babies After 35 or Paging Dr. Fran. First of all, I don't even think they even see them because they block me. Oh, okay. Right, but other people repost it, and maybe Lincoln. When I go after these people. Z-Dog he's a schmuck. All right, you guys know what a schmuck is, by the way? Yeah. Okay. It's a Yiddish word. Yiddish words are great, by the way. Yiddish words are great. But the other two, you know, I mean, they're annoying as hell to me, especially the babies after 35, the one that she's always wearing a surgical hat when she talks. It's like nails on a blackboard for me. I would love to have a conversation with them. I would do a live conversation. We talked about this earlier. I would be very happy to go on a live forum with them and discuss what they, because I don't think we would disagree on maybe 80% of stuff. We might agree, but we should discuss it, as opposed to this tit for tat stuff on Instagram. You make a comment, then I make a comment. I mean, I sometimes look at the comment section in a post by them or me or anybody, and suddenly it goes off the rails sometimes. People just badgering each other back and forth. It's like, there's no point. When you have a troll, the best thing to do with a troll is to not engage. There was a movie called War Games out with Matthew Broderick. I don't know if you saw it years ago. It's about a computer that controlled the nuclear missiles and everything like that. And at the end of the thing, they're trying to teach it not to play the war games to blow up the world. So they gave it a game. They told it to play tic-tac-toe. And they realized that it started playing itself in tic-tac-toe, and it realized it can't win. You can't win when you play yourself. And so finally it realized that the best thing to do is not to play. So don't engage these trolls. It doesn't do any good. You're never going to convince them that you're right. And all they want is they want to be affirmed and to get a rise out of you. So I hardly ever read the comments, people's stuff. I just know that I feel very comfortable putting out there what I say, and I'd be more than happy to defend it if someone wants to do it publicly. I'm not going to do it in the comment section, right? Okay. So let's eat. Now, what time is it? Oh, wow. Can we eat fast?
Yes.
Oh, we can't yet because we've got to get some stuff. You can eat the cold food and hot food.
Oh, you're going to heat the hot food? All right, so maybe I could just start the second lecture while we're waiting until the food's ready?
Well, there's loads of cold food ready.
Yeah, we'll get some.
You guys, all right, well then how long is it going to take to heat the hot food?
It's already cooked and it's here.
So how long does that take?
5, 10.
All right, so let's take 25 minutes or so for lunch, take a break. But we are going to be here till 6 o'clock. I want you to know that. Okay. Do I have cognitive dissonance when I eat my lunch today?
I've been in the
cursing out the season. You were searching for a reason to be mad. Babe, I got plenty of them. It's a bad night, keeping Texas on the down. Made it easy to be leaving you behind, but I got what I want and it's just enough. There was an east coast, there was a fire straighten your tie. We're not alone. I'll tell a lie just to bring you home. We dance together. You're not that good. I'll tell a lie, but it's understood. I guess it's all about timing. I guess it's all about the things you want but never get. I guess it's all about trying to love someone you've never met. We eat our dinner, then we undress, and now we're dating, more or less. Now I am sick. You're probably drunk. You're saying things and they sound like love. I guess it's all about timing. I guess it's all about the things you have but didn't want. I guess it's all about dying to love someone. Wish it was easy. I wish I knew what I was doing, but I never do. Nearly had me convinced you were someone who wouldn't desert me. Now I've gotta tell all my friends why I got home so early. Do you tell your friends about me, or do you tell them nothing? But I expect something from the king of disappointment, but nobody's calling you your majesty. I'm not your jester for enjoyment. The kingdom of letdowns, you'd be royalty. Waiting, it's hard from your throne to see all the mistakes that you're making. You say that I need to manage my own expectations, so I expect nothing, and anything you do is amazing. I'm crazy while avoiding me? Can somebody tell me what the point is? Chasing the king of disappointment. Get your men, get your horses, gather all your forces, while you hold up in your palace, we'll all raise a chalice to the king of disappointment. But nobody's calling you your majesty. I'm not your jester for enjoyment. A kingdom of land and GB royalty. Call me the queen of paranoia. Tell me I'm crazy while avoiding me. Can somebody tell me what the point is? Can somebody tell me what the point is? Chasing the king of disappointment. But nobody's calling you your majesty. I'm not your jester for enjoyment. A kingdom of land on GB royalty. You call me the queen of paranoia. Tell me I'm crazy while avoiding me. Can somebody tell me what the point is? Chasing the king of disappointment.
Wide-eyed like a blue sky, deep side, the horizon feels so far away. And would it come true? Mystery blows like the wind through my heart, and I can love again. Do you wonder? Do you go for somewhere in the hole? That it's the right time for a show of the bright lights.
jewelry in the catch-all bottom.
It's sitting down a lot. Where is it? In the kitchen? What are they doing? Kitchen people! Oh, we're on it. Come on, everybody.
Fresh air.
Yeah, he likes me. He's like, he's been paying attention. Yeah. Yeah. Smart man. Smart little man. Right. Yep. Hello, baby. Okay. How many people are still in the kitchen? Okay, come on, kitchen people.
Yeah.
Okay, so this is the meat and potatoes. This is really the important lecture. I want to basically say that tomorrow when we start practicing, you'll figure out what you're comfortable with. But what I'm going to do is go through a lot of different videos, and I'm going to show you normal, and then I'm going to show you some things that aren't normal, and how to intervene, and when to intervene, and what the cardinal movements are. But I will just tell you that when I learned breech delivery at County Hospital back in when was this? 85, 84, 85. I did not know anything about cardinal movements of a breech or these sorts of things. Every single woman was in lithotomy position, and every single woman got hands on the breech. And I will talk a little bit about hands on the breech versus hands off the breech and stuff like that. We'll go along. Now, when I show the maneuvers that I'm going to, it's a little bit difficult. I will show them with Sophie, but they're not the same as when we do them tomorrow. So just try to keep the images in your mind today of the specific births we go to, and then tomorrow I'll say, just like in Sarah's birth where we had to do the Pinard's maneuver, we're gonna practice that tomorrow and stuff like that. Because it doesn't really, I mean, I'll show a little bit, but it's not the same thing. But it all will come together. So even if it seems a little scattered, it will all come together. And then you'll be able to decide tomorrow, do you like this maneuver? Do you like this maneuver? Do you like this maneuver? Which maneuvers feel comfortable for you? I am a big fan of what's called the love set maneuver. David Hayes likes moving things from up high, and he also likes the Ritkin maneuver where you put your fingers in a woman's anus, and I'm not a big fan of that. I've never had to do it. Don't ever want to do it. There's other maneuvers that you can do instead. But all of us, David, I, Betty Ann Davis, Frank, we've all met at conferences and we all discuss how we all do breeches slightly differently, but we're never yelling at each other because we're doing it wrong, right? There are many different ways to do it. So I will teach you the ways that I did it. And if you learn stuff at Breech Without Borders and you want to do that differently, that's absolutely fine, as long as the baby comes out. Okay, that's what I want. I want the baby come out with as little trauma as possible. So we're going to go through some stuff now, and we'll start at the very beginning. And again, just as you guys acknowledge indigenous peoples here and the fact that we're on the land of them, and so they're starting to do that in my country as well. And I think it's a nice thing, but I want to acknowledge the fact that I have all these people that were my mentors over time. And obviously this isn't all of them, but this is just essentially, I know every single person on this thing except one. Somebody snuck into a picture and I don't know who she is. The one by the lake at the bottom, there's one woman in there that I don't know who it is. But nonetheless, the rest of these people are all people that I honor and respect because they've helped me to become who I am now. And it's just good to remember that because someday in the future you guys will be teaching and talking and you'll remember, and then one of you may have a picture of Sarah Buckley or me or somebody else up there. So we do walk in the footsteps of those that came before us, and I would not be here doing breech delivery if it weren't for the fact that I was lucky enough to be at a program where they allowed us to do it. And when I was learning breech delivery back in the 80s, some programs had already banned it, had already stopped teaching it. So I got lucky. Okay. So this is Shell and baby Reef. And I'm not going to say anything, not going to talk about it. I'm just going to show you a breech delivery on a birth stool. She's a primate. Baby's a complete breech. And we're going to talk about that. We're going to show this video again at the very end. and we'll see it probably in a different way. But let's just watch and let Shell do her thing.
Awesome. Beautiful. Yes, that's it. Your body's infinite expansion. Infinite expansion. That's it. That's it. That's it. That's it.
Oh, it's coming.
More and more. Beautiful. Beautiful. Yes. Yes. You got it. You got it.
You're doing
you got
it.
it. Here he comes. Sliding. Sliding through.
You're doing it.
Good work. Sliding through. Sliding through. You got it. Right here. Through.
You're doing it. You're
Beautiful.
doing it.
Okay. Body's out. Beautiful. Here, Teddy. You're gonna his little head go right into Good. Good work. That's it. There's one more.
God damn it. Get out.
There you go. There you go.
I love it.
You got it. You got it. Here he comes. Here he comes. You got it. You got it. Yes. There you go. Did it. You did it.
Good. Not going to say anything about that. That's unassisted, upright, primip, breech birth. Can't be done. Can't be done. Too dangerous. Can't be done. Okay. So the objectives here are to counsel clients with a better understanding of the normalcy and actual risks and benefits of term breech birthing options, properly identify good candidates for the vaginal delivery option, identify when a breech baby needs assistance and be aware of and positions, and perform those appropriate maneuvers when necessary. That's my whole goal for you from this lecture today. So the American College of OBGYN, as you saw in the video, also said this. They said, the decision regarding the mode of delivery should depend on the experience of the healthcare provider. Should it? No, it shouldn't. All right. The decision regarding the mode of delivery should depend on what the mother expects, the mother wants, and we should have people there that can provide for them. Cesarean delivery will be the preferred mode of delivery for most physicians because of diminishing expertise and convenience. And as somebody was telling me earlier, in the private sector here, they make more money doing it. Your public sector doctors don't, but your private sector doctors do, apparently. In a vaginal breech delivery, planned vaginal delivery of a term singleton breech fetus may be reasonable under hospital-specific protocol guidelines. Now they say that because they don't support home birth for anything. So they use hospital-specific protocol guidelines, but they do support breech delivery, but you wouldn't know it by the fact that 98% of breeches are delivered by cesarean section and there's diminishing expertise. They admit that there's diminishing expertise, but they do nothing to solve the diminishing expertise. They're not mandating that residency programs bring back breech birth. RANSCOG says a couple of things. They say planned vaginal breech delivery must take place in a facility where appropriate experience and infrastructure are available, including continuous electronic fetal monitoring, immediate availability of cesarean facilities, availability of a suitably experienced obstetrician and midwife to manage the birth, and arrangements in place to manage shift changes and fatigue. I have no idea why that's in RANSCOG's guidelines, but that's what's in. I found that shocking, actually. Why would they even care about that? Why is that relevant to that? I mean, maybe it is, and maybe I've just never seen it before, but it just seems kind of an odd place to put it. But also, again, they talk about that breech should be in a place that has immediately available cesarean facilities. Well, shouldn't head-down babies be that way too? Shouldn't all babies be in a place if you're talking about the hospital? So I just think they look at breech and they automatically think of it in a different category. They don't think just of it as a variation of normal. All maternity units should undertake regular training for all medical and midwifery staff using simulation to ensure that staff maintain adequate skills to be able to provide appropriate care when a woman is admitted in advanced labor with breech presentation. Did you know that RANSCOG said that? No. Are they doing it? No. Okay. So when breech is taught as an emergency skill, the rate of vaginal breech birth in maternity unit actually goes down. Why? Because it's taught as an emergency. Therefore, it's taught as...
Yes. Yeah. They teach it as part of prompt, and they teach you on your back how to breech. With
So what part isn't true?
With like 1 minute of hands-on. They are teaching it. The part that's not true is that they're not teaching. Everyone's right. They're not teaching, but they are teaching it.
And they aren't the school.
In all maternity units or just public hospitals?
In prompt. In all public.
Yeah, okay, well, right. Private hospitals aren't doing it, right. And the private hospitals are filled with Ranstock members, I think. The doctors are Ranstock members. Right. No, I hear what you're saying, but there's certainly not a push to teach it. Are they teaching it in all residency programs? Because we talked about Andrew at Royal Women's, and he's teaching residents there, but apparently there's not a lot of other interest outside of it. Andrew has said that he says when I'm to have a breech delivery, none of the other attendings who happen to be around want to come in and watch. Right. So, but when you teach it as an emergency skill, it's kind of like shoulder dystocia. It becomes in your mind something to be avoided. That's the whole point of this.
Yeah, they're teaching it in a very scared way.
Yeah, right. And so it becomes something to be avoided, not to be endorsed. So you guys have all seen Bug's Life? The movie Bug's Life, everybody's seen Bug's Life? Another movie reference here, all right? At the beginning of Bug's Life, there's the ants are bringing the offering to a big pile for the grasshoppers. And they're all in a line, like if you ever had the ants in your kitchen, you know what I'm talking about. So off of the tree comes this big leaf, and it comes floating down, and it gets right in front of the line. And the ants behind the leaf begin to panic. They get in total panic. They don't know what to do because they can't see the people in front of them. So they're in complete panic. What do we do? What do we do? And then this older ant comes over and he says, calm down. We'll go around the leaf. And they go around the leaf and it's like, oh my God, yeah, we went around the leaf, we figured it out. It's sort of the same thing. Like I told you the story about when I gave a whole report about this woman who's very stable and all they heard was the word breech. It's the same thing here. What we need to do is change that culture. We're going to change that culture and you guys are going to start to do that. So at the Royal College, again, at the meeting, they said that term breech arguments should be set in the context of vaginal cephalic birth, not comparing it to cesarean section. And if we did that, as a Royal College number sees, you can see there's basically 1 extra neonatal death per 1,000 women doing that. But we compare it to cesarean for breech, where it's 4 times or a slightly higher risk of neonatal death, and therefore that seems awful. So Frank Lewin actually says, what is normal and what is pathology? And you end up, when you compare vaginal breech birth to cesarean for breech birth, you're comparing apples to oranges. They're 2 separate things. So the disparity between well-defined cesarean techniques and poorly defined vaginal breech births is one reason why studies comparing the 2 are open to criticism. So for cesarean sections, the techniques are described, codified, and clear. So in other words, if you do a cesarean section here in Melbourne, and someone does one in South Africa, another one does one in Vancouver, Canada, they're pretty much all done the same. C-sections are pretty much done the same across the world. But with vaginal breech birth, we have many unanswered questions. What limitations were in place? Could the woman move about? Was she allowed nourishment? Did she have anesthesia, Pitocin, or synthetic oxytocin? What position was the mother in? What support was available? What criteria were used? We don't know. Right? So one of the problems is everything is well described in the planned cesarean group. Well, you know almost nothing about the planned vaginal group. That's just one of the big problems with the Hannah term breech trial. And why, again, it's a trial that is a rotten trial, and yet it's accepted because of the things we talked about in the first lecture of confirmation bias, that sort of thing. So reteaching breech. So before we reteach breech, and the reason I have this slide is I love it because it's actually, they're sitting around telling stories. And that's how the best way to learn something, I believe, truly, as I said this morning, is to hear stories. Because the stories we can remember, and the little numbers and facts, sometimes they go in one ear and come out the other. So we'll tell some stories, but first Before we do that, I wanted to talk a little bit about, somebody mentioned earlier, I think it was you that talked about cephalic version. Yeah. External cephalic version, because every time a breech happens, it comes up as a possibility or an option to be discussed. So let's find out a little bit more about it. ECV is a procedure offered to turn the baby from a breech position to a head down position. It's typically done around 37 weeks. The reason it's done about 37 weeks is because there is a small chance that the baby could get in distress, and if you have to deliver a baby, you don't want to deliver a 34-weeker. But 37 weeks, the ratio of baby to fluid is better than at 38 or 39 weeks, as the baby gets bigger and the fluid gets less. So there might be a slightly greater success rate. The problem with 37 weeks is also, if it's successful, there's also a greater chance the baby might turn around and go back to where it was before. And I've seen that many times. And so we often give a woman a binder after a successful ECV, a Velcro binder to wear just to kind of keep her belly like that for a day or two, so the baby hopefully will put its head down in the pelvis and settle down. But that's essentially about how it's offered. But the question is, what are the indications for it? And that was your question, I think. And in the modern world, the indications are, well, if your only option is a cesarean section, then external cephalic version makes sense, because you only have the option of cesarean section. ECV success rates vary widely. We'll talk about why they vary widely in a second. But in my world, if you have an option of a vaginal breech birth and the baby meets the criteria, which I will go through for safe vaginal breech birth, then ultimately there's really no reason to offer an ECV unless there's limited resources, or unless, in my case, a woman came to me with a breech, and if she was planning to hire me to come to her house, that was going to cost her a lot of extra money. But if I could turn the baby around, then she could go back and just be with her midwife. So one other reason to do ECV is because if it's successful, it saves the woman a lot of money. So to think about that. But ultimately, if you trust breech birth, then you should give the woman the option to say, listen, if you deliver vaginally, the risk to your baby of having a really bad outcome is about 1 in 1,000 more than if you'd had a head-down baby. And it's about 4 times greater than if you have a cesarean for breech. But if you want a second or third baby, these are the risks. So an ECV, that's one of the reasons to do an ECV or not do an ECV. But you should just give them the information, and then based on their clinical situation, you should let them decide. And every woman's situation needs to be individualized, and fortunately in your model of care, you can do that. In the medical model, they really are more on an assembly line. You don't have the time to do all that stuff. But I don't think the indications of ECV are as strong as they should be. I mean, I think they're over-strong. They offer it too often because there's no other option. That's why they do it. So success is dependent on many factors. Parity, obviously more successful in multips. Fetal position, complete breeches are much easier to turn than frank breeches. They're just easier to tuck and do a somersault with than a frank breech. Anterior placenta makes it harder. Lower amniotic fluid volume makes it harder. Uterine anomalies certainly make it harder. If I knew a woman has a septate uterus or bicornuate uterus and that baby's breech and that head is wedged up in one of those horns up there, it's not even worth trying. It's really hard to be successful in that scenario. It can happen, but again, the kind of force and things you might have to do. Did you have a question? I'm sorry?
Do you also consider nuchal cord?
Oh, nuchal cord would not affect me at all.
For an ECV?
Yeah, it wouldn't affect, no. If it either goes or it doesn't go. Right.
It's an ongoing reason why we have women decline for ECV.
I'm sorry, I'm having a really hard time hearing. The microphone isn't going to help. Let me come over there.
No.
A lot of women that we refer for ECVs
have been declined because they had a nuchal cord. They won't do it.
Right. Based on any evidence whatsoever? No. There's no evidence that that's the reason not to do it. Fact is, when you turn them, the nuchal cord might unwind itself, for all you know. And if it doesn't go, it doesn't go. And if you're doing it and the baby has a variable decel, then you stop. And if you put the baby back to where it was, it's not going to lead to a crash C-section. So it's not a reason not to do it. It's a reason, again, for people that really don't want to do anything but a C-section for breech. Why would they want to turn the baby to a vertex and now they have to deal with her having a vaginal delivery. Again, if you really like C-sections and they're convenient for your office or your system of care, then why do you want to change somebody from that, right? So maybe I should move closer, but sorry, I think it's my ears and I think it's the acoustics. Fibroids also, fibroids can be a problem. And then of course the skill and the willingness of the practitioner. How good are they that want to do it? How motivated they are. And then techniques and success rates can vary widely. So this is Katya. Katya is a lovely woman. She and her husband I met when I was in Portugal a few years ago. They live in Porto. I don't know if you've ever been to Porto. It's a really pretty place. It's where port was invented, I guess, or where it comes from. And they called me and they said, Stu, our baby's breech, can you come to Portugal? And I said, well, yeah, I think I have a free month. I could come to Portugal. What's happening? Well, we'll put you up in a condo or a Airbnb here, and you know, you can just hang out and wait. And so it's like a free trip to Portugal, free condo, stuff like that. So I said, sure, yeah, I'd be thrilled to come to Portugal and spend more time there, because when I was in Portugal the time before, I was teaching, so it was like here, I didn't get a lot of free time to see. My daughter came with me on that trip too, and she got to see all of Lisbon and all of Porto, and I ended up working 2 days. But I said, sure. And she said, well, we're gonna try a version next week, and we'll let you know. So much to my chagrin, guess what happened? The version worked, right. So I didn't get to go to Portugal, which is, right. So the version worked, and again, I think that I told you earlier, one of the things that happens is when a successful version means they can save some money. So I think at the end here, Katya, you see here the joy on her face, and I lovingly joke that the joy on her face is that they don't have to pay Dr. Stu to come to Portugal anymore. But this is a good example of a two-person approach. Now, many of you have seen versions done, and you've seen them successfully done. This is a very nice one that's done. I don't think they need the ultrasonographer the whole time, but that's the way they do them in this hospital. She has a saline lock, but she got no meds. She does not have an epidural. She's in mild Trendelenburg positioning, which is just where her head's slightly tipped downward. And that's all they did for her, and that's what they did. So let's watch the two-person approach of an ECV that works. Oh, and they're speaking Portuguese, so you probably won't understand unless you know Portuguese.
Tá bem? Só estou filmando da barriga para baixo. Sim, sim. A outra eu estava filmando daí, só que o cabelo da Sidonie toda hora fazia assim o rabo de cavalo dela, toda hora brigando.
I'd like to know what she's saying.
Olha a pontuação, vai ser
I think it must be the ultrasonographer talking, saying like, the back is over here, the head goes So the baby is what we call right sacrum transverse. So the baby's sitting inside mom like this, with the head sort of over here. So you make a decision at the time, am I going to do a forward roll or a backward roll? If the head is over here, the easiest thing to start with to try is a forward roll. But if the head was over here like this, you might try a backward roll. So they're going to try a forward roll. So the first thing you do is the person with the white gloves is going to try to elevate the butt out of the pelvis. That's why she's tipped upside down a little bit. And they're going to push on the butt and get it out of the pelvis. Once they're comfortable with it out of the pelvis, the person with the blue gloves is going to take the head and try to force it toward the left.
Quando eu puder, vamos começar, tá bem? Olha, eu vou começar então.
Dia eu vou conseguir uma filmagem.
Okay, so loosening the thing baby out of the pelvis, and now the person with the blue gloves is going to start to apply some pressure.
Ok. Está.
And you can sort of just see the go.
Desculpa, Angela, mostra-me só aquilo que eu
back up transverse lie now.
Mostra. Ok, está aqui, já está transverso. Vamos. Isso, acho que está. Vamos.
Steady pressure, they're not killing her. It's hurting her, but it's not killing her. And the baby
Ok,
now.
acho que foi. Tá, ok. Sucesso! Parabéns! Parabéns! Ele gostou assim tanto.
But what's interesting about this is that there was no choice for them to have a vaginal breech birth. And so they either had to have this ECV or they were going to have to deal with either me coming or they were going to have a C-section. And I'm thrilled that she's ecstatic and that she's so happy that this happened. And they went on to have a vaginal delivery. It was great. But nonetheless, the women shouldn't be forced into these choices. This is the issue. Okay. So common breech presentations. You guys know these, but I just want to go over them really quickly, because some of you probably have more advanced knowledge than others. But a frank breech baby is a baby where the hips are flexed and the knees are extended. So the baby's basically sitting in what we call the diving pike position, right? Just like that. Complete breech is where the hips are flexed and the knees are flexed. So the baby's sitting like that. It could be like this. It could be, down here. But the feet and the butt are presenting. Sometimes the feet are presenting lower than that. Incomplete breech is where you have one foot up and 1 foot in the complete breech position. So you have one where the hip is flexed and the knee is extended, and one where the hip is flexed and the knee is flexed. Any of these three are perfectly fine for vaginal delivery at term. We were always taught that you could only do complete and frank breeches. Incomplete breeches should have a C-section. That's what I was taught. So back when I was training, we didn't do incomplete breeches, but now we know that that's not true because, again, you have a very wide dilating wedge when you have a baby in this position. It's really a non-issue. So that's incomplete breech. And of course, then there's the thing, what is truly a footling breech? So if you went back to Shell's video, you started out with a foot sticking out of her vagina. Now, because unfortunately a lot of people don't know anything, and because a little foot sticking out of the vagina is so cute, they often call it footling. But a true footling breech is when the hips are extended and the knees are extended. So the baby has to sort of be standing up. That's almost impossible at term. So the only time you really see a true footling breech is going to be a preemie or potentially a second twin. It's almost impossible for a first twin or a term breech baby to be footling breech, yet it will often be mislabeled by people who really don't know. The reason that's somewhat important is because there are certain jurisdictions, like in Oregon, where midwives are approved to do complete breeches and frank breeches, but they're not approved to do footling breeches. And so sometimes when they'll post a picture or do something on the internet and somebody sees that in Oregon and they see a foot sticking out, they'll get reported to the nursing board, and they'll then have to defend themselves against, because the expert for the nursing board agrees that that's a footling breech, doesn't know squat, and then the woman has to hire Hermine Hayes Klein or somebody else as a lawyer. I don't know if you know who Hermine Hayes Klein is. She's a human rights attorney. She defended a woman in the European Court of Human Rights about Agnes Zagreb, was a doctor who became a midwife, who was doing a home birth, who ended up putting on house arrest for 2 years. The woman that she took care of sued in the European Court of Human Rights for her right to give birth where she wanted to. She won, and Hermine was her lawyer. There was also a trial in Nebraska last year of what's called the Nebraska birth creeper. She had a bad outcome with a breech delivery, and Hermine, it was on court TV in my country. You may or may not have gotten to hear, but she defended. She's really a fighter for human rights in childbirth. And anyway, she had to defend this midwife against the testimony of a CNM who really probably doesn't do breech delivery, and just the medical board sent it to an expert They're not really experts. They're essentially rubber stampers. You guys know what I mean by that? They rubber stamp things. I don't want to use slang that you guys don't use. And essentially, because the reviewers for medical boards know that if they tell the medical board that there's really no case here, the likelihood is that they'll never get another case to review. Because the medical board isn't there to actually adjudicate things properly. They want to prosecute people. That's how they make their money. In California, the medical board gets no tax dollars. They get money from fines and licensing fees. That's how they get their money. It's another issue. So this baby, that is not a footling breech. How do I know? Because if you put your finger in, the butt's sitting right there. It's a complete breech with a dropped foot. Very normal, not a problem. This is what I think in the movie, when they said Dr. Crane didn't feel the baby was in the right position anymore, I just think it was a complete breech with a dropped foot, and he got nervous. And that's what happened. That's what I think. Because the true footling breech, even though it's the worst picture I could find, it's the only picture I could find, where the legs and hips are both extended. Now, if you go to Google and you put in footling breech, almost every picture that comes up is wrong. It'll be a baby like this, with the baby's complete with a dropped foot. And that's what they'll show. That is not a footling breech. And we cannot let people just arbitrarily change definitions. So we don't have to worry about footling breech much at term at all, except maybe a second twin. Okay? Okay. Something you rarely see, by the way, is a knee presenting. It's a knee. The baby's knee is presenting. And is that okay? Yeah, yeah. As long as because it's essentially a form of complete or incomplete breech. It's just the knee's coming out, so the baby, instead of being this way, is actually this way, and that knee is coming out. And sometimes, again, that may be a little bit of a problem. And if there's lack of progress, as we'll learn today, then one of the things you can do is you can easily ease that foot out and get it out of the way. Yeah.
And then are they more likely to end up needing assistance with the head because the knee naturally causes the back to arch head?
That's a really good question. I don't know enough. I've only seen a kneeing breech like twice in my career. So I don't know enough to answer that question.
I think there's a lecture in Breech Without Borders that they talk about knees presenting, and just the theory.
Well, if anybody's dug a deep dive into that sort of that RICSA has,
yeah,
I would not doubt it for a second, but I don't know there's a lot of data in the world on kneeing breeches.
She said there's no data,
right.
I think, but says theoretically that's the case, and you should just. It's not a reason to not do it. It's just a reason to be prepared to potentially flex the head if you need to.
Well, I'll tell you, the only two kneeing breeches that I've had, both of them ended up, I needed to help the leg out, and then I ended up having to do more maneuvers on.
Yeah.
So you're probably right, but two doesn't make up a data sample. Right. And by the way, she's a previous planned cesarean. She was a home VBAC, and she had a previous planned cesarean section for breech, right? Of course. Okay. So these are the criteria that I used when I started doing home deliveries in 2010. When I started doing breech deliveries, I had to have criteria because I wrote a paper with RICSA, and when you write a paper, you sort of have to put something down in print. You can't just say, well, I wing it when they come in labor. That doesn't go well with it for academia. So we came up with these guidelines, but like Pirates of the Caribbean, if you saw that, where they talk about the code, and they said, no, it's more like guidelines, actually. So guidelines are something that are just guidelines. The problem is in the medical world, when ACOG puts out guidelines, they end up becoming benchmarks for quality, and then they become hospital policies, and that's a mistake, and that's a problem. So these are the criteria that I use. There are 9.5 of them. So let's go through. Term. So if I'm going to do breeches at home, I'd like them to be term. So for me, that's like 36 weeks. Again, some provinces, states have laws that say you can't do a home birth until they're 37 weeks. You have to decide what you're going to do about that. I mean, if you have a woman comes in at 36 weeks and 6 days, are you going to transfer them? And American midwives have this issue. They have this problem because technically they're violating the law by doing that. If I had somebody come in at 35 weeks with a breech in labor, would I send her to the hospital? No. I just don't want to put that in the paper. But no, because if I sent her to the hospital, she'd have to have a C-section. And even at 35 weeks or 34 and 6, 7 weeks, whatever, that baby comes out, most of the time that baby's, because it went through labor and stuff, is not going to have a respiratory issue. And if it did, it's not going to be the kind of respiratory issue where they need to be acutely intubated and ventilated. So if an hour after birth, a baby born at 35 weeks is tachypnic or that its O2 sats aren't great, yeah, okay, so the baby can go to the hospital. But the mom got a home vaginal birth, the baby got an hour of delayed cord clamping and skin to skin, and that baby got a better start than if they went to the hospital and they would have had a C-section from the start. 2 obvious things, frank complete and incomplete breech are fine. Ability to flex its head is important. The reason is because the last cardinal movement of breech, as we'll learn, is head flexion. So the last movement a baby makes when it comes out breech is the baby just flexes its head, and that's how it comes out. As opposed to head down babies, where the second to last cardinal movement of a head down baby is what? Extension and then external rotation. So it's opposite. Now, do babies actually know what they're doing, or is it the shape of the pelvis that does it or something? I don't know. I don't care. But flexion is the last cardinal movement. So when a baby needs help or you're helping a baby out, you just have to remember that the last movement is not pulling the baby's head out or expulsion the head. It's to do a maneuver that's going to cause the head to flex. So.
What do you mean by ability to flex the head? Like, what would prevent a baby from being able to?
Good question. And I was going to move on to the next one. I completely forgot about that. So thank you. There are congenital anomalies of fetuses that will keep their head extended. I don't care if the baby extends its head. I just want to know the baby has the ability to flex its head so that it can do that last cardinal movement. But things that can prevent a baby's head from doing that, congenital goiter, hydrocephalus, torticollis are the 3 that come to mind. Torticollis is like they have a spasm in the sternocleidomastoid muscle when they're born. Maybe they've been malpositioned for a long time and their head is stuck like that. And an ultrasound, it's an ultrasound diagnosis for me, and they have to watch it and we want to see the baby's able to flex its head. If a baby is constantly sitting like this, and I have them come back next week and they're constantly sitting like this, that baby's not a candidate for vaginal delivery. Not a good choice. It's not a wise choice.
Do you just do routine ultrasound and just observe?
Yeah, I just watch for the, in any given ultrasound, a baby that's got an extended head may very well just, you wiggle the baby a little bit, the baby wakes up and puts its head down. So you have ways of making a baby move. We even had like what you'd call a vibrator for when we did NSTs to try to get them to wake up. I don't know if you guys still do that sometimes. Acoustic, we called it an acoustic stimulator. Yeah. Yeah, it's an acoustic stimulator. It just it wakes them up if they're in a sleep pattern to see if they'll move so you can see their heart rate go up and you can send them home. Same thing, we do that. So we would just want to see them. Now, could a nuchal cord prevent them from flexing their head? No, not really. I mean, maybe times 5 or something like that. And if I saw a nuchal cord times 5, I might hesitate myself, but not 1 or 2. Right. That's what, go ahead.
So I'm thinking, like, from my perspective, I want to go into the ultrasound with the woman and just observe baby's movements during the ultrasound.
What's that? That's what I do.
That's what you do.
Is that what you're asking?
Yeah.
Yeah. Yeah. When I do a consult for breech, as I see, because a lot of these breech women are not my clients. I end up meeting them for the first time at 37, 38, 39 weeks. And as part of the consult, I need to do an ultrasound because of the criteria that are coming up. The rest of the next 3 criteria are all sort of ultrasound based. And again, if I'm going to take them on, I'm already bucking my system in Southern California when I was there. I'm already like under the radar. I mean, not under the radar. I'm like on the radar. So I follow things by the book, at least on paper. But then I fudge things in real life. If her labor isn't if it's not following all these guidelines, again, I will fudge it because I want to give the woman a chance. Because to me, breech births succeed or not for the same reason head down babies succeed or not. Fetal distress happens for the same incidents, the same reasons that head down babies. And and so head down babies, we don't have these strict criteria. We shouldn't, because ultrasound, the prognostic uncertainty of ultrasound is pretty great. There isn't a great certainty with ultrasound. But as far as just wanting to see this, this is what we're looking for. baby's able to do that. Okay, next.
Will you continue to do breech births if the woman doesn't want an ultrasound?
It's a good question. Has that ever happened to me? Yeah, it has a few times, especially when I've been called to a surprise breech. And that's one of the things they'll get to when that's the half. I said there were 9.5 things. It's the half thing. It's like, what happens when I get called to a breech birth and I don't know all my other criteria? Do I still go? And the answer is yes. I would still go. But I always feel better if I'm going to take somebody on, especially because I haven't had the chance to spend 6 or 7 months with them and get to know them. They're new into my practice, and even though they're there because there's a trust there, and but I'm the only option also. So sometimes it's a little bit under duress. And some of these women have actually planned to have a hospital birth. And now they find out not only is their baby breech, but they're going to have to do it at home. And for some of them, that's a leap too far. Because as you know, and you taught me, and I think one of the last criteria is the right parental mindset. They have to be, they have to trust that this is going to work and that they trust you and stuff. So it's part of establishing a relationship. And if I ask them to do that and they say no, it's their right to say no, but it's a little red flag for me, yeah. Because I want to feel comfortable too. Estimated fetal weight, I made this up. This is between, America, it's between about 5 and 9.5 pounds, but would I tell a 10-pound, an estimated fetal weight of 10 pounds that she couldn't have a vaginal? Of course not. I'd let her labor and see what happens. Because again, the prognostic uncertainty of ultrasound isn't very good at predicting estimated fetal weight. How many times have you seen a woman get a C-section for macrosomia and the baby weighs, well, baby weighs 3,800 grams, and you're told, wow, that, we made a, no one says, oh, I'm sorry, I really made a mistake. They just don't. The biggest baby I ever delivered when I was a resident was about 13 pounds, 5 or 6 ounces. No, not breech. And it was a disaster. The mother was 400 pounds, and I was a resident. It wasn't my client. I got called I was a chief resident. I got called by the attending because the attending was a little woman, and they had a shoulder dystocia. It took about 11 minutes to get that baby out. Baby was toast. What? Biggest breech baby is actually, I have that in my paper, 10 pounds something, I think. I don't remember off the top of my head. But it wasn't huge. I mean, it wasn't massive. Well, 10 pounds is what, 4,500 grams, give or take? Yeah. Maybe 4,700 grams, I think. Obviously a good one, no gross anomalies. Now I'm not talking about things like 6 fingers or cleft lip. I'm talking about gastroschisis, spina bifida, some major anomaly. You're not going to do that. This is a good one, clinically adequate maternal pelvis. So I did not use, obviously, MRI or anything like that. And what's a clinically adequate pelvis? In my practice, the clinically adequate pelvis, the definition is a woman with a pelvis. Okay? As long as she hasn't had a crushing history of a car accident or some congenital anomaly. Any woman's pelvis is clinically adequate because the pelvis is a dynamic organ. But I will tell you, and we'll get to it later, we used to take breeches in labor up to labor and delivery. I mean, up to X-ray in labor. We'd send the least skilled person on our team up with them, basically just to push them up there. They'd take a flat plate and a cross-table lateral X-ray, and then the job of the medical student that went up with her is to bring us the films. And we'd look at the films, and we would measure the intraspinous diameter, the AP diameter, and the transverse diameter. They had to be 10, 11, and 12 centimeters. If they were anything less than that, they got a C-section. Because that was what was in the protocol that we were using at the time. So that's what we did. But as you'll see, we were taking these pictures in what position? Flat on their back. Right. Again, a form of stage 1 thinking. Like, we're going to put people flat on their back when we know that being upright, well, they probably didn't, I don't think they know that because no baby was delivered in any position but lithotomy in those days. So that's all it is, because mom's pelvis will accommodate most babies that she grows inside of her, and babies are dynamic as well. Appropriate parental mindset, we said that. Then 2 sort of simple, then the known client one. So this is the thing I mentioned. I mean, if I get called by a midwife for a surprise breech, I'm not going to say no, but if I go, I don't know half of these other parameters. I just have to trust that the midwife knows some of them. But I would go no matter what, because what's the option? To make the midwife, the option would be to make the midwife do something illegal, or make the woman go to a hospital and get a C-section, and couldn't do that. Yeah?
What do you do when you have a situation where you have a mum that, like a woman that's keen, and the partner's not on board? Would you go ahead in that situation?
Yeah, I would. I would go ahead in that situation. But generally, we want them to resolve that beforehand.
Does that worry you?
Ultimately, that's something that that's not something that I tried to get into in a situation where I had no real connection to the family. Earlier on, if I knew that, we would have weeks or months to work on that. But yeah, I can't abandon it. I could not abandon a woman who wanted me there to do that. I would do the best I could to reassure the husband. And like I said last night, because I'm a guy, I think, and I'm a guy's guy, I sort of connected with the fathers really well. And they trusted me. They did trust me. But that's a really interesting question that you ask, because we have that problem. And Bliss and I recognize that problem. We have a webinar every other month we do called Bringing the Home Birth Hesitant on Board, so that women in our country can, if they have their mother-in-law or their husband or somebody who's not game for home birth, we do an hour-and-a-half webinar where we give a little spiel about home birth, and then we take questions. And the questions are the usual questions about safety and cost and, why don't other doctors do it and that sort of thing, and we answer the questions. It's not hard to answer the questions because we're confident in our knowledge and belief of what we're doing.
Can you get sued?
Can you get what?
Can you get sued?
Oh yeah, we can get sued.
Yeah, by the family.
Yeah, we can. But the truth is that most home birth women are the kind of women who accept responsibility for what they're choosing. They understand that. Have we been threatened to be sued? Yeah, I was never sued for a home birth outcome, and they weren't all great, but I was never sued for that. I mean, we have consent forms, but my consent forms are really short, because I don't have this long 3-page consent form that says, oh, your baby can break its neck, your baby can do this, your baby can do that. No, I essentially say, I had a long conversation with Dr. Fischbein about the risks and benefits of this, and then what I do is I do a verbal consent form, and I have a witness with me, like my student or somebody else, and I just write a note in the chart that my usual consent form was done today, and parents understood and asked any questions they needed to, and agreeing to proceed. Because I just think giving them a consent form that tells them every thinking thing that can go wrong is just telling them not to think about elephants. I'll talk about it, but then when we talk about it, it's different than them just reading it on a piece of paper, because I can see the reaction in their face when I say it. And that's why I really like doing these. I don't like doing Zoom lectures, because most people in Zoom lectures, they got their camera off and you have no idea what they're doing anyway, and you can't see their faces, and you really want to see. I can look at you and I can see, does she look puzzled? Is she nodding? What's going on? And I can tell whether I'm actually answering the question that they're asking. So it's about relationships. And again, something they didn't teach us this in residency. This is something you come out and you have to learn. You either have your own people skills from when you were growing up and you have the people skills, or you don't. And if you don't have them, it's going to be very hard to develop them in the modern medical world anymore.
We've been finding a lot that the demographic of women having home birth has changed quite a bit, and they're not I think that women used to be much more in that self-responsibility category.
Now they're not?
But increasingly women are coming to us and still wanting to hand responsibility over to us as private midwives, which is like, I don't do that.
Yeah, well, again, all of us here have a sixth sense, a gut, and we should trust it. When we sit down with a couple and our little alertometer's going off inside that this is not a couple that's either getting along really well or whatever else, yeah, they may deserve the kind of care, but maybe that's not something that you necessarily want to take on. And you have the right to do that as a practitioner. We have to feel comfortable too. I just didn't have that happen very often. And I'm not a psychologist, and I don't want to really start trying to be a marriage counselor or anything like that too. But I may say something to them that and a lot of times if the woman goes to the bathroom, then I can ask the husband something. Or if the husband isn't there, I can ask the woman something that they may not want to answer. And there's always a red flag sometimes when you ask the woman a question and the husband answers the question. You guys all know this stuff. You guys are smart. You get good people skills. Let's keep going, and we're going to never get through this. Okay, and then these are the no-brainers. Labor needs to start spontaneously. We don't induce, and we really don't augment in the home birthing world, obviously. Did I ever use castor oil to get them into labor? Yeah, we did do that. What's that? Castor oil? Yeah. And again, that's not something I learned in residency either. That's a midwife thing. And I've never learned how, I've never seen so many different cocktails that you guys come up with as far as giving castor oil. And then obviously mom and baby need to tolerate labor. That's a no-brainer. Okay. So this is a stock footage thing. This is on YouTube. This is the arrival of Thaela. What's nice about this is it's an upright, multip, all fours, breech delivery where they'll show the delivery and then they'll show it again in slow motion with a little bit of narration on it. And let's watch it and then we can talk about it during and after, okay? So this is classically your classic upright frank breech vaginal delivery. Probably you're going to see this at least 60% of the time. You're going to see breeches that go just like this. Maybe not quite as fast as this, but just like this. Because we're going to spend most of the time today on pathology. So you're going to think, is it always pathology? Oh, no, this is what's more normal than not. Again, interesting that it's from Brazil. See all the tension in the labor. Positioning at almost 2/3 degree like that. Now, frank breech is the most common because you make the breech by 80% of breech. So babies will always rump sacrum transverse, almost always. Nothing is always or never, but they'll rump sacrum transverse, right or left, doesn't really matter. Left is slightly more common than right, but it really makes no difference. Then as they come out, they will rotate. And by the time they reach the umbilicus with frank breeches, they should be tum to bum. With incomplete or complete breeches, it might take a little longer to rotate, but you should start to see the rotation. When they're tum to bum, that tells you the baby's arms are here and not up here. Baby's arms are going to be in front of the baby. What you're going to see when the legs release is you're going to see cleavage running right up the middle. That's because the two shoulder blades are squished together. The cord doesn't necessarily need to have to run up the middle, but it often does. The baby will do some scrunches to try to get its shoulders out. And then what happens is one shoulder will come out, it'll rotate slightly the other way, the other shoulder will come out. And then before you can see it, the perineum fills up quickly, but you can't see it here because it's so fast. And the baby's head comes out by flexion. And then when that happens, you don't have to do anything. When you see a baby rotating tum to bum, or what we call sacrum anterior, baby's sacrum goes toward mom's pubic bone, and the baby's tummy goes toward mom's bum. That's going to tell you that this baby's going to come out, whether it needs simple maneuvers or no maneuvers. If the upright positioning, everything is perfect with that baby. And babies in utero, I can tell you when you do an ultrasound on a breech baby at 37 weeks, baby's arms are always here. Baby doesn't sit in utero with its arm behind its head like that. You don't see that. So what happens? Well, as they're coming down, theoretically, potentially, maybe it gets stuck on a bony prominence or something, gets dragged behind. Or possibly the baby gets startled and does a moral reflex. And so the arms go up, and then as it comes down, it gets stuck. So if that happens, the baby will not rotate tum to bum. The baby will stay sacrum transverse. It isn't complicated. You're going to find that by tomorrow when you start doing these, you're going to say, I keep doing the same maneuvers over and over again. Yeah, that's it. There's about three maneuvers that you need to know, depending on if they're upright or if they're in lithotomy. And once you know those maneuvers, you can do pretty much every breech baby. And then there's some extra maneuvers. But that's it. It really isn't that complicated, yet we've made it so scary and so complicated. So let's review what we just saw. So we saw the baby's buttocks and or legs emerge sacrum transverse. Right, so the baby comes out with the sacrum sideways. As the baby gets further and further down, closer toward the belly button, the baby will rotate from sacrum transverse. It'll begin to rotate as it comes down like that. And it will face you if she's upright. If she's on her back, you'll see the back. And if you remember Aurora's breech from the documentary, baby came out and the baby's back was sticking straight up like that. And when you saw Shell's birth just now, it almost looks like a lithotomy birth because you're watching it on the birth stool from the front. So the baby rotated with its back to you. Right? Everybody remember that? And it rotated a little bit later too, because you remember it didn't quite rotate. And when we watch the Shell's birth at the end, you'll see that it rotates a little bit later. And that's because complete breeches will often rotate a little bit later than frank breeches. But it should rotate tum to bum.
And if it doesn't, would you just try and correct that as you see it happening?
No, if a baby comes out and it's about this far out, okay, and the baby's still sideways, doesn't matter if the baby's good or bad or doing well, if it's bad, obviously, but if it's still really good, if it's gotten this far out, this baby will not deliver itself without your help. So, as we're going to learn, you're getting ahead of me, but as we're going to learn, the thing is, am I going to sit here and wait until the baby starts to lose tone and it looks like shit? Or am I going to tell the mom, listen, just like we talked about in the office, your baby's stuck with the sacrum sideways. That means baby's arm is up here. Usually it's the arm that's on the pubic bone side. Will be stuck on the pubic bone. You say to mom, listen, I'm going to help the baby out now. You don't have to sit there and wait. And this is where we get into the dilemma of the hands off the breech thing. And I'm going to show you some things where you're going to be chomping at the bit because you're wondering why they're sitting there doing nothing and doing nothing and doing nothing. So, yeah. Again, good question. But
I'll show you. I want to show you a birth video later. I want to see what you think about it.
Oh, you have one on your phone?
Yeah. Baby rotated.
Offering another video to watch.
Yeah.
And then stayed there for ages.
Yeah.
And then kind of just as it was coming out, rotated back to transverse, and then rotated anterior just as the head was coming out.
Okay. I have a sacrum posterior delivery that I'm going to show you. And it's a very rare thing that happens where the baby rotates the wrong way. And generally, that's not how they're going to resolve. They're going to be stuck there. And if you don't know what to do, this is the kind of births that end up in a disaster. It's the same thing when a baby's hanging sideways. If you don't know what to do, you might find somebody trying to pull on the baby to pull it out. It's the last thing you should do. You need to unwind them. Classically, the example is the kitchen drawer with the spoon that's stuck in the kitchen drawer. You can pull all you want. The drawer is never going to open. What do you do in that case? You push the drawer in a little bit, you flick the spoon out of the way, and you pull the drawer open. That's what we do. It's called reducing station and moving it. And that's what you do with a baby that comes out sacrum posterior. But you're getting way ahead. I got a reason why I'm doing what I'm doing. Okay. All right. So then we saw with frank breech, the legs will release spontaneously. With a complete breech, they'd already be out. Everybody gets that, right? They're the first things out if it's complete breech. You see the cleavage, which indicates the arms are across the chest and the shoulders are getting squeezed until you see this little cleavage running right up the middle. The baby will do tummy scrunches, which is the cutest term ever, I think, tummy scrunch. You'll see it, and that's a time that, first of all, the baby's well oxygenated because it's trying to get itself out. And it does tummy scrunches, and sometimes a scrunch will cause the arm to release out. So the baby's just trying to shake itself loose. The arms will eventually release spontaneously. Now, if you have time to see it, as the head begins to flex, you'll begin to see the perineum fill up, and the distance between the vagina and the anus will sort of get bigger. there'll be a stretch there because the forehead is coming as the baby's coming around the corner. But in most of these multips, it happens so quick that you don't even get a chance to see it. And then the full perineum indicates the head is flexed. If the perineum is hollow after the arms come out, that just tells you the baby's head is deflexed. And you know that you might have to help the head out. So these are all signs, just obvious things that you know. Once you know what's normal, then you can easily recognize abnormal. And by the way, you taught me that because you guys are experts in normal birthing. Experts in normal birthing are very quick to recognize something that's abnormal. Whereas doctors are experts in abnormal birthing, so to them everything looks abnormal. If you live in the same apartment for 20 years and you go out for dinner and you come home at night and the chair that's in the front hall is moved 3 inches from where it normally is, you would know that something's wrong. Did the dog hit it? Was there an earthquake? By the way, there's an earthquake in Los Angeles this morning, 5 point something. And, or, you know, was there somebody in my house that shouldn't be in my house? But you know immediately something's wrong. I, as a visitor to your house, would have no idea that that chair is not in the right place. But you know it because you guys are the experts in normal birthing. Right. What's next? Oh, the head will come out spontaneously. And then 2 no-brainers. The baby's passed to the mother. When she's ready, sometimes there's a pause and they're not quite ready to sit back and pull their baby through or sit back and get their baby. And then the cord is left intact even if you have to do any resuscitation on the baby. And when these things are present, there's rarely a need to do anything other than try to catch the baby or maybe not quite catch the baby because it falls on the bed or falls on the whatever. Okay, so we have positioning. There are more than 5 positions. There's actually side lying, and I'll show you a breech birth on the side. But there are 5 main positions. One is lithotomy, and for centuries, all women gave birth flat on their back. So that's the way, unfortunately, that I was trained and that I did birth for a really long time. So I'm really comfortable delivering a breech baby on her back. I've become more comfortable upright, but it was certainly not comfortable for me initially, sort of spatially disorienting for me. Now for you that have only done breeches upright, when we do lithotomy, you might be spatially disoriented, and we'll see. Okay. So lithotomy is like that. And then we have birth stool, as you saw with Shell, or this lovely picture is one of my favorite pictures. Because, by the way, is this a footling breech? No. How do we know that? Because it's term, right? And the butt is sitting right, you know, at the perineum there. So, upright breech is when they're on their knees or all fours, but they're leaning more upright, like against the bed or against the birth tub or against their partner, whatever else. So their back is more like upright like this. All fours is when they're on knees, hands and elbows or something like that. And that's more like this one. Oops, hang on. That mom, she's sort of laying flat. And then of course we have the dreaded water birth. Okay. And we'll talk about, I've got 3 videos of water births to show you too, and we'll go through that too. Okay. And I'll tell you why. The whole purpose of being upright in all fours is to use gravity. And when a woman is in the water, you have no gravity. So it just makes it a little more difficult, that's all.
I don't know if it's Rixa or Christine, but one of them was saying that sometimes having that buoyancy actually helps the babies to make the maneuvers. So they're like unsure about the gravity versus buoyancy argument.
You know, I'll tell you, Rixa is an academician, and what do academicians do for their spare time? They think too much. They really do. I mean, I adore Rixa and David and those sort of things, but they're constantly trying to come up with new theories and new ideas. And I'll tell you, I learned breech in 1982 and 83, and other than changing to upright, I don't need to actually try to overanalyze why things are happening. Some of you have brains like that, and I don't know that I'll be able to help you think differently, but I think sometimes it's too much thinking. But if the baby is floating up, and I do have a video where a midwife says, well, the baby's floating up this way, I'll just turn the mother over, and the baby will float up into what's called a Brock maneuver and come right out, and it works. But it would have worked anyway. All she would have had to do is reach under and do a shoulder press under the water too. So you can do, when it comes out that easy, it probably would have come out no matter what you did. Okay, So this is Erica and baby Aaliyah on her side. And Erica writes, baby is an incomplete breech with 1 foot down. So, in other words, Erica is like this. I mean, Aaliyah is like this inside of her, with one leg crossed and one leg down. And I called another hospital that has a provider that does breech deliveries, but he said he can't do it if it's incomplete breech. I'm feeling discouraged that the baby rotating is out of my control. Well, yeah, it is out of your control. You can't tell the baby what to do. But this physician is very old school. I honor the fact that he's doing breech delivery, but he doesn't understand. He was taught, like I was, that only complete and frank breeches are okay and incomplete are not, but he really hasn't kept up. So, because incomplete is perfectly fine to do in a term pregnancy. So let's watch Aaliyah's birth, and then on her side, and then we will finish what she has to say.
Good job.
Don't you like the way that the photographer brought it in from the floor and then sort of zoomed in? Yeah. So this is Robin. Robin is a midwife in Florida. She took a course that I taught in Tampa, Florida.
No, yeah, there you go. We got 2 toes.
Ouch!
Now, she doesn't need to be touching the baby right now. And so you'll see that a lot of us just can't keep our hands off the baby, I'm included. Well, you can see the baby when it comes out of the perineum. You see the white ring there
She's not
on the
stuck.
skin.
She's coming.
Eventually turns
There we
purple. That's called
go.
capillary
There we
filling,
go.
and that's something that's very reassuring.
Yes. Yeah.
So baby's perfectly tum to bum. Mom is providing incredible force because there's no gravity working there. So you've got the arm out. Now sometimes when, even in lithotomy position, when the mom gets the baby out that far, you need to do a little elevation of the head. So all Robin's going to do is a shoulder press here. She's going to push the baby forward. Forward, Robin. There we go. And then out comes the head. So even in this position, when you don't have gravity working for you, if the baby is doing its cardinal movements, that's delivery. That's what we would call a simple maneuver. You'll see that when we talk about my twins and I break down the breech deliveries, you'll see a third deliver with nothing, a third deliver with simple maneuvers basically related to not being upright, and a third required more intensive maneuvers. So about 66% of breech babies will either deliver with no maneuvers or very simple maneuvers. So she goes on to say, thank you so much for referring Robin. She delivered my breech baby at home safely. Robin took the training course. Ultimately, it made me feel so good about going with her as my midwife. Then she says, I delivered my first baby on my side too. For some reason, it's the most comfortable position for me. Then she gets to be on her side. I tried my hands and knees, but wasn't comfortable. I do think frank breech was easier to push out than the feet first breech. So her first babe was frank breech. So she had 2 vaginal breech deliveries. Good for her. Baby's happy and healthy, 6 pounds 14. By the way, I had an ultrasound and they predicted 7 pounds, so they were right on with their prediction. However, they said, I was looking for a midwife, looking for a provider that delivers breech. They told me that 7 pounds was way too big for a breech birth. This is why I call it dumb doctor dogma on the podcast, because it's just, why do they say stuff like that? Why would they say stuff like that? They don't know. Why don't they just say, I don't know? Okay. So this is a bunch of papers came out in the 2010s, or just before that, and innovations in breech birth when upright became popular. And you said Anka was here in 2013. Let's see, where was her paper? Let's see, where's her paper? Oh, right, or 2014 she had a paper, so she was probably gathering her data at that time. Anyway, shorter second stage with upright, less perineal trauma, fewer maneuvers are required because you have gravity, and definitely a higher vaginal birth rate. So there's absolutely no reason a woman shouldn't be upright unless she doesn't want to be upright. And then some women don't want to be upright. And that's why I want to teach lithotomy. But when you have to do maneuvers, as I said earlier today, when a woman's in lithotomy, you have better access to suprapubic pressure, to fundal pressure. Fundal pressure for breech, by the way, is a very useful tool when you're trying to get a baby out in a hurry because there's a problem. you know, you're always taught that fundal pressure with a head down baby is like, ooh, maybe not do that. You might impact the shoulder. Is that what you're taught? I haven't done head down babies for a while, but fundal pressure is something you...
Anka talked about Frank's nudge.
No, I'm talking about, oh, no, I'm talking about,
sorry.
if a baby's head down,
Yeah.
are you taught not to give fundal pressure because you might impact the shoulder? That's sort of what you're taught? Right. Yeah, with breech babies, it's actually a useful tool because you're actually propulsing the baby down and the baby is coming out the right way. By the way, with a head down baby, if you see a hand right here, what do you do usually? Oh, you do nothing? Well, sometimes you push it back in again because the shoulder could get impacted. But if you have a compound presentation, you just let it come out? Okay, great. Great. But in a breech baby, if the arm is coming down the side of a baby, that's perfectly fine. So I guess it's perfectly fine in both then. I was always taught if the hand was coming down here, you try to reduce the hand. Nice. Great. Okay. So being upright during labor and birth can increase the available space within your pelvis by 28 to 30%. Who knew that? But again, remember I told you what they did. I told you what they did when we had to send them up for X-ray pelvimetry. All right. Because again, it was performed flat on their back. So we didn't know what we didn't know back then, but we should have known. We should have known. Did you have a question? Oh, I thought you did this. Oh, okay. Okay. So this is a very important slide coming up, this one. And I want to give thanks to baby Gianni for helping me out with my friend's baby. We used it to pose to show the positions of the arms. A normal baby will turn tum to bum, and that baby will do fine. A baby that stays sacrum transverse, even if one arm or both arms are out, well, first of all, both arms won't be out. The baby's left arm is going to be caught up on the pubic bone in this picture, which is in front, and that baby will die or come out severely damaged if somebody doesn't know what to do and they just start tugging on that baby. But that's a very simple maneuver to unwrap that baby, and that's just to rotate the baby, to bring the baby around the other way. And do one of the rotational maneuvers and just help, and then slip the arm out and then do a shoulder press to get the head out. But just so you know, it's a very visual image to see that a baby that's staying sacrum transverse needs help. And you don't have to wait until they're floppy and in trouble to do it. Oh, and by the way, when the baby's out that far in either one of those pictures, the baby's no longer in the uterus. And if you go back and watch when we watch Shell's video, you see, we weren't telling her to wait for the next contraction. We weren't telling her anything, actually. She just felt the urge to push, and she needed to push. At this point, if you need to get a baby out, you don't sit there and wait for the next contraction. There's nothing inside the uterus. And what happens to the uterus when there's nothing inside of it? It contracts down. And of course, then the placenta separates. And on rare occasions, when you have a baby that's sitting there for a long time like that, the baby will come out and it will be wearing this placenta like a hat, which means that it really hasn't had any perfusion for quite some time. Okay. So at this point, the one on the left, you have mom push. The one on the right, you need to rotate so you can free that arm up. And then whether or not she pushes or not is up to mom. She'll do what her body tells her to do, but it's irrelevant because once you start to maneuver like that, you finish the delivery. We have what's called the once you start rule. And if you do a maneuver on a baby, even to get the baby's butt out, or do a Pinard's maneuver, or to get the legs out, once you've started a maneuver on a baby, you've changed everything. And even if you restore the mechanism, so now the baby, you've rotated the baby from here, and now the baby's in this position, and you got one arm out, you don't just leave the baby here now, because, oh, the baby's back in its normal cardinal movement position, we'll just leave it. No, no. If you've had to do something to get it here, you finish the delivery and you get the baby out. That's the rule. All of us agree with that. You'll see what I mean when we go along. Okay. So with upright breech birth, normal is, again, the baby's abdomen is to the mother's anus. When the torso and arms are being born, that's tum to bum. The baby's shoulders then shift slightly to the oblique to release each arm. Not normal is when the shoulders stop in the AP diameter, and you can have either unilateral or bilateral nuchal arms. The baby's spine stays facing the mother's thigh, otherwise sacrum transverse. and progress stops. Sometimes an arm or shoulder gets stuck inside the symphysis pubis. That's the most common place for it to get stuck. So let's watch. This is Sage and baby Vale. Sage is a marathon runner and a CrossFit trainer. So, I mean, we always talk about how tight their pelvises are, and doctors will say things like, oh, your pelvis is really tight, I don't know if this baby's gonna come out of you. And by the way, if you look at Sage, she also has very narrow hips. Can't really tell, but you can sort of tell from that picture. She's got very narrow hips. She's very lean, strong, muscular. Baby Vale is in the incomplete position, and this is funny because we laid baby Vale on the bed getting ready to put her on the scale, in the weigh thing, and we did not pose her like that. This is how she sat. And you can even see that baby Vale has a varus deformity of her left foot. That's because it's been sitting underneath her for a really long time. So she needed a little bit of orthopedic work afterwards on her foot to get it to be, back and rotated back the right way. It's a very common thing. It's a non-issue. And also about this video, which I love, you guys will laugh, I'm sure, but is the father, Anthony. Fathers that participate in these sorts of births, fathers that help catch their baby or are very involved in their own birth, tend to, they just by nature tend to be more attentive, and maybe it's a selection issue, but they tend to be better fathers. I just think when they're involved in their birth and they're not just an appendage in the corner of the room feeling helpless and emasculated, it's better for them, it's better for the mom, it's better for the relationship, and it's better for the child to have a father involved. And you'll see how moved Anthony is by this whole thing. Maybe rotating anteriorly.
Yes. Yes. Yes.
Also,
here she comes, honey.
We'll bring the camera down lower, so we'll get a good check right now. Let me just watch for the legs to pop out.
You're doing so good, honey. So good. Yes, honey.
She's in perfect position.
Here she comes, honey. Here she comes, honey. So
good job, Sage.
Can you want me to film from down here? Watch the flashlight. It's creating a shadow. Sometimes
her butt and one leg is out. Almost all the way out.
The butt and one leg is out. The butt and one leg is out, honey. Yes.
So it's going to get lighter in just a second. There we go.
Yeah, look it.
So now you can see that one leg is almost out. Now you really couldn't be sure that the baby's rotated or not yet. Here comes one leg. But you can see that's the first leg out. Now you can see the cord is running right up the cord running right up the middle.
You do what you need to do, honey. You do what you need to do.
There's a tummy scrunch.
Listen to your body.
It's not going to fall because the arms are... In every one of these videos, you're not going to see any tears. And I can't remember from any of the ones that I'm involved with that we had to do stitches on any of them. The poor little foot is...
You know what I mean? Of course you're gonna have tone. You know where she's coming from?
Sometimes you can put your fingers there just to protect the perineum where the foot's going to pop out. Because occasionally, sometimes you could see a little tear or something when the foot pops out.
All right, here comes.
Yes, honey. There's leg number 2.
Yeah, just that or a warm water. Tummy scrunch. Or whatever.
Good.
Now, there's another tummy scrunch. The cord's running right up the middle. The cord doesn't have to run
yes,
up the
honey, yes,
What you want to see is the baby's tongue is
Umbilic is
the mom's bum.
147, 43.
Now you see a robust cord there. It's full, it's turbid, it looks great. Later on, we're going to see some cords that look like that, and then they start not looking like that anymore. Another tummy scrunch.
Can you turn the fan off?
Oh, shut up. No, don't go away. You stay here, Anthony, because the baby's going to come out.
Jenny, turn the
Everybody watch.
Oh,
remember, she's a prime.
Yes, honey, yes.
Good.
Prime with narrow hips and a very powerful. Take a breath. Take a breath, Sage. And maybe just take a breath.
Breathe.
That was beautiful, Sage.
Oh my God.
Mom's taking a moment.
She looks good too.
She's
got so much hair.
So when you're ready, Sage, you can either sit back or reach down and pull your baby up through your legs.
There she is.
Isn't that great?
There she is. There she is. There she is.
You want to sit back, Sage?
There she is. Yes. Oh my God. Oh my God. Oh.
You think he wanted to have a baby?
It's a new baby. It's okay. It's okay. It's okay. You just hold her.
You open it, Anthony?
Okay, I'm going to stop it here because there's more of that going on. But I've got to keep you moving. All right. Some of you may have seen this on the internet. This is Emily. She's a midwife in Ohio. And she said this is like her 5th or 6th pregnancy. She's done surrogacy work. This baby is hers. This is a home unassisted Frank Breech birth. And it's just, again, watching a normal, I'm showing this to show you what's normal. I'm not for or against free birthing. This is not a statement on that at all. She's a skilled midwife and she would know what to do. But the interesting thing about her is comparing Anthony to her husband, and and ultimately she's asking questions about what's happening, and it's her teenage son that's filming that answers the questions, because her husband's pretty much useless. But I met him; he's a very nice guy. But I just think. So let's watch this one. Right now, I'm just showing you all normal breech births, so you get in your mind what's normal, so that you don't think that pathology is normal.
I need to hold on to somebody. It's coming. Do you see anything?
Yes, it's coming. It's coming. It's almost out.
Yes, the baby is coming. She's, it's coming.
Did we get it?
No. Is it rotating? What's it doing?
Looks like a blob.
I need to hold on to somebody.
Maybe like a butt cheek or something.
Is it
Listen to the
sideways or-
sun. Listen to the sun.
It looks like it's butt cheek or something. I can't tell.
It burns so
Okay, it looks like his back.
Okay.
Okay, okay.
It's coming.
Just let him come. Just let him come. Move your hand. Just let him come.
The baby rotate.
It's almost out. It's just its head, pretty much.
Listen to her.
His arms are not.
Is his belly button? Do you see his back?
Yeah, I see
Is
his
he
back.
sideways?
Yeah, I see his back.
Is he sideways?
Sideways.
No, he's coming straight back.
You might want to get its head in case it falls.
It's okay.
It's definitely moving.
She's going to release the arms.
Anthony, up higher. Okay.
Yeah, she releases both arms and then she does a backward shoulder press and she pulls the baby out. Is that great or what?
Looks like a doll.
I am in awe.
Okay. Guys, I need a. It's okay.
Away.
Get the
Look at
ball
that
suction
beautiful
that's on
baby.
the
Okay.
case I wanted.
Moving
Hi,
on.
baby. You did so.
One more. This is midwife Minden shared this with me. This is she said this was her first breech that she ever did. And she wrote me and she said, this is my first home breech catch that she had. And so I put catch with a question mark because you have to decide whether this qualifies as a catch or not. So let's watch. And again, watch for the cardinal movements. Watch the baby come out. Watch it's Frank Breech. Watch the baby rotate. Get this image in your mind.
Beautiful, beautiful. Good job. Good job.
And also, I mean, the fact that the
Nice structure.
children, even the teenage son, the son, the husbands, they're all involved, they're at home, nobody's running around, and there's no peds team waiting for the baby. Very peaceful. So the baby rotates beautifully.
There's her feet. Oh, and there's her hands, and there's her head. Oh, and there she is, Mama.
Okay, so qualify as a catch or not a catch? I don't know.
I don't know.
Okay. All right. So now we've seen normal several times. So let's talk about when things aren't normal. What kind of criteria are we going to use to determine if and when we think we need to intervene? So one of the things that's never really mentioned that often, but I think is important, is how has the heart rate been in the pushing stage? Has it been steady in 130, 140, whatever it's been, or are you starting to hear variables? And do the variables getting deeper? We all know what that's like. We've all had babies where, the variables are getting deeper and deeper as the baby comes out. And if you have a baby that's got a perfectly normal heart rate in the second stage, then you have a baby that's probably far less likely to be compromised as it comes out through those maneuvers or those movements. But if you have a baby that's having variables, even deep variables, that's a baby you might want to expedite the delivery simply because that baby doesn't have much reserve left. All right? That's one thing. Second thing, capillary filling. We'll see more examples of it. But capillary filling is what you do if you get sunburn and you touch yourself and it blanches and you take your finger off and it fills back up again. That tells you your heart is beating, basically what it tells you, and you're perfusing. And when you see capillary filling, the best place to see it is, what? Did you say something? Oh, okay. Is as the baby comes through the perineum with the tight perineum, you'll see it looks like a white ring, and the baby will move farther down, and that white area will then blanch into purple, or whatever color the baby is. But usually it's purple or moderate purple. So that means the third one, this one, is not such a good indicator, but a change in color. If a baby is fairly purple or fairly red, and now it's starting to look mottled or pale, that would be another sign. But it's a weaker sign. So capillary filling is a good sign that the baby's being perfused. And certainly this is probably the best sign of baby being perfused, is its tone. Is it doing tummy crunches? Do its legs have tone? Or are they laying there like a wet noodle? Fetal position, what do I mean by that? Well, is the baby staying sacrum transverse or is the baby rotating to normal? So if the baby's staying sacrum transverse, that's a sign that says you're going to probably have to, well, not probably, you're going to have to intervene. It's just a matter of making a decision when you want to do it. And we're going to work on making that very clear today. Protection of the perineum, that's a silly one where you can touch the mom, or you can, maybe the baby's frank breech and the legs are just sitting there at the ankles and they're right up essentially by the anus, just to ease them out so they don't snap out, so they don't get a little labial tear. You can do that. That's not considered a maneuver. That's just sort of helping them out. But again, it's something that you can do, and the mom may ask for help, and that's the last one. But arrest of progress is important. Arrest of time, not so important. I don't want any, I don't teach by algorithms and time methods. I don't want to get you stuck on the idea that you have 3 minutes from here and 5 minutes from here and 7 minutes from here and stuff like that, like the Sean Walker, Anka Ritter algorithms. And Rixa does some teaching about, once they reach the umbilicus, baby rumps, you'd have 5 minutes to get the baby out. From the umbilicus, it's 3 minutes. You don't necessarily have that much time. And if you think you have that much time, you might be making a mistake. So don't use time. Let the baby tell you what's happening. Take advantage of the fact that breech babies are visible, and they're telling you how they're doing. Right? Really good one too is how's the umbilical cord looking? Because you can see it. You don't need to be checking a heartbeat. You'll see in most of these, there's some where they check a heartbeat, but most of these, once you can see the baby, the heartbeat's irrelevant. If the heartbeat's 80 and the baby's got good tone and doing tummy scrunches, that's okay. If the heartbeat's 120 and the baby looks like, yesterday's spaghetti, then you don't care that the heart rate's 20, you want that baby out. So what does the cord look like? Initially, a cord will look generally robust, sometimes more coiled. As the baby stops perfusing, the cord will become flaccid. The cord may uncoil a little bit, and it looks rather pale and bleh. And then the mom can ask you to help too. That's another reason why you can help. So the first maneuver that I like to teach is something called the love set maneuver. This is my rotational maneuver. Other people, well, the love set maneuver is where you move the baby from the hips if they're in lithotomy position, which is what's described here, or if they're upright, you're going to move the baby from the hips but in front. And you're always going to keep tum to bum. So if mom's bum is here, her pubic bone is here, because she's upright, then the baby's going to start coming out like this, sideways. If a baby comes out sideways and by this point has not rotated, it's not going to rotate. So you're going to put your thumbs on bony prominences here and here, or if it's lithotomy, here and here. But you don't want to ever squeeze soft tissue. So careful not to grab the thigh, careful not to squeeze a kidney or anything like that. Try to stay on the bone. And I'll remind you tomorrow when you're doing them, because I'll watch and your thumbs will move off, and you'll forget because you're thinking about this and you've just grabbed the baby by the leg or the thigh and you don't really want to do that. But then you're going to do, what you do is the baby's hanging out this way. Let me turn it this way so you guys can see. So the baby's hanging out this way, and the mom's tum is up here. Pay no attention to that one because these diagrams are from the old textbooks where they're in lithotomy position. But the baby's hanging out here. What you do is you lift the baby to neutral. In other words, the baby's going to be hanging down a little bit toward gravity. You want to lift the baby back up so it's parallel with the earth. And then all you're going to do is you're going to then rotate the baby 180 degrees to the other side. And you're going to know which way to rotate it because you're always going to rotate it where you're keeping tum to bum. Then when it gets to this side, if you can start to see an armpit, oops, so if you get your arm up there, stay there. Nope. She's not sticky enough right now. She's got too much powder on her. But if you can see an armpit, then what you do, generally what I like to do is take the hand up the baby's backside and just sweep the arm down across the abdomen. Some people like to reach up with the other dominant and pull the arm down. That's okay, but you're putting more force on the arm when you pull it down. And try never to pull an arm or push an arm down with one finger. Try to use 2 or 3 fingers. The reason is because when you put pressure on the humerus bone with one finger, there's a slightly greater chance you can break the humerus bone. It's easier to break it over one finger than 2 or 3. I've broken 2 humerus bones in 42 years. And you never want to do it because it's a horrible sound when it breaks, like a chicken bone breaking. All right, so again, you sweep it down. So now you swept this arm out. This arm's still inside. Sophie's arms lock. It's really interesting to see how they're made. Skeletons are really weird looking inside. So this arm's up here now, and the baby's, that arm's out. So then what you do is you put your thumbs here again, you rotate 180 degrees this way, and then you take your left hand in and you sweep this arm out. So now you got both arms out. With both arms out, the baby will generally restitute back to where the baby's completely sacrum anterior and the face is facing you with the perineum right here like that. That's generally what will happen. If not, you may need to correct the baby. At this point, if you try to correct the baby from down here and the baby doesn't have a lot of tone, you might be putting a little too much torque on the baby. So you can move your thumbs up here. This is called the Lewin maneuver, named after Frank, and this is the one that David likes to use. He likes to move the baby from up here. But if the baby's down here and you want to move the baby with the shoulders, you're going to have to put your thumbs and fingers into the mom's vagina to do it. And I think if you can stay out of the mom's vagina, it's probably a good thing to stay out of the mom's vagina. Right? So then you've got the baby, and you've got the baby where the chin is now right in front of you. So you might even want to just look and make sure you check the chin so the baby's not looking this way. You don't want to do a shoulder press with the baby looking sideways. So you want to make sure the head is in the AP plane. And then you just do a shoulder press. You just push baby backwards. By pushing the baby backwards, you cause the head to flex, and out it comes. So the rotational maneuver is to free the arms. Now at any time, if you're trying your rotational maneuver, and you're trying to turn that baby and it's not turning, right? That means something's stuck on something. So what you can do at that point is you can either do it from down here, or you can move up here, and you can just reduce station a little bit, like the spoon in the drawer, and then do your rotation. And you'll find that if you push the baby up a little bit, you'll almost always be able to rotate the baby because now you've moved the baby up to where the pelvis is a little bit wider, and whatever's been stuck, you've freed it off of the shelf. Whether it's stuck on the sacral promontory or stuck on the pubic bone, it doesn't matter, something's stuck. And you can free it up and then continue your maneuvers to bring the baby down. All right, so it's described here, but again, this is described in lithotomy position. So I just want to review this with you. So The maneuver should start when descent and rotation of the baby have stalled and the baby remains sacrum transverse. So we already talked about that. So the baby's stalled right about here, and it's not coming down anymore. And even if it hasn't stalled, and it stays like this at this point, maybe the mom can push it down a little farther, it's still not going to rotate because that arm is up here, or one of the arms is caught. The baby is grasped using both hands by the femoral pelvic grip, keeping the thumbs parallel to the vertebral column. So in lithotomy position, I'm putting my thumbs here. In upright position, I'm just putting my thumbs, same place, other side. Okay? The baby's lifted up slightly. Okay, I call that the neutral position, so that again, because it's hanging down, you want to rotate the baby sort of parallel with the earth. The trunk is rotated through 180 degrees, keeping the back anterior in lithotomy position, or the tum anterior, our anterior. But we use anterior and posterior, by the way, by mother's anterior and posterior. So it's a little confusing when your anterior is looking at the mom's bum, and that arm that's in front of you is actually the posterior arm. Just have to kind of remember that. Mom's anterior is what we call anterior. But again, lithotomy position, while maintaining outward traction. So when you're rotating a baby with lithotomy or the Lewin maneuver, you're not pulling at all. You're rotating 180 degrees, and then you're gently pulling down. Not out. You just gently pull down to see you can slip something under the skin to see if you can see that armpit. So this is a rotational maneuver without pulling. Well, there's only one maneuver that you rotate and pull at the same time. That's Pinard's maneuver, and I'll be describing that in a minute. But there's no pulling until you get to the 180 degrees, then you gently pull down. Can I see that armpit? Nope, I can't see it yet. Go back up to neutral, rotate 180 degrees, gently pull down. Oh, now I can see that armpit, and slip that arm out. Now, when you get really good at this sort of thing and you feel comfortable with it, once you slip one arm out, you don't necessarily have to rotate the baby back the other way. You can just go in posteriorly and slip the other arm out. But when we're learning, I want you to rotate back and forth. You'll see in some bursts where I just get one arm out and I just go get the other arm because it's posterior or anterior, and I just go get it. The trunk is then rotated in reverse direction, keeping the back anterior. Again, lithotomy position, back anterior. Upright position, tummy anterior, my anterior. Until the remaining axilla is in view, the arm is then gently released under the symphysis. It's more difficult with poor tone. So once the hips are visible, when urgency is necessary. So the minute you can get your fingers on these two hips right here, if the baby's in trouble and it's only this much out, you can do this maneuver. If the baby's, and when the baby's only this much out, all you're seeing at 2 feet, you can pull the baby out to that point, as long as mom's completely dilated. All this is contingent on her being completely dilated. If she's frank breech, what are you going to pull on? You don't have anything to pull on. So this is where we'll get to Pinard's maneuver in a minute. But what you do if they're frank breech and all you can see is this much, you should reach your fingers in and you get them into this little hip joint here and hip joint here. And you're going to pull the baby out and rotate the baby till the legs are about out, and then you just slip the two legs out. And now the baby's out like this. And now you know exactly what to do because you've brought the baby out to where you can then do your love set or your Lewin maneuver. And we'll also talk about when the baby gets a little further up, a really nice maneuver is Betty Ann's prayer hands maneuver, where you turn the baby like this. And some people really like this maneuver because you sort of have control of the whole baby this way. You're turning the baby as a unit as opposed to putting torque here. But this is the maneuver that I learned when I was, a youngster, and it's really worked for me all these years. So it's the maneuver that I teach. But we're also going to practice the one with the shoulders and the prayer hands maneuver. We'll practice them all, and you'll feel very comfortable with them by the time we're done.
Can I ask?
Yeah.
With a complete or incomplete breech, that rotation can be a bit later?
Slightly later.
So are you going to give a little more time?
Yeah, I'm going to wait till both legs are out, as long as the baby's showing me that it's got good tone. And once both legs are out, if the baby's still completely sideways, it's not going to rotate all the way.
Oh, really? So you wouldn't give it a little bit longer for a complete?
Well, if mom gives a push and it comes down a little bit more, yeah, you can do that.
Yeah.
Again, I'm not talking about a sense of urgency unless the baby's telling you it's urgent.
Yeah, like the last complete breech that I was at, she was probably sideways, but the umbilicus there. But then with the next push, the next contraction, we saw the rotation start.
Yeah, if you watch Shell's delivery at the beginning, the baby didn't rotate until it was much higher up.
Yeah.
Right, and you're watching it from the back. So yes, you can give it more time if the baby's telling you it's fine. If the baby's not telling you it's fine, then you would go get it anyway. But if it gets up to about this point, to the nipples, and it hasn't rotated, it's not going to rotate. Right. Good question. And that's just showing how you sweeping the arm. And I like the idea of pushing the arm across the chest as opposed to pulling it down. I like going this way rather than pulling it this way. But if I watch you do it and you start reaching up and pulling the arm down and it comes out fine, that's fine. Because again, there is no absolutely one right way to do it, and you'll get whatever you feel comfortable doing. All right, so this is Cecilia and baby B. This is an incomplete breech, just like Sage and baby Vale, who we saw. But this baby stays persistent left sacrum transverse. Why does it stay that way? Right. She did it. Right. So this is an upright one, just like Sage and baby Vale. It's very much the same. So the baby comes out with same thing where this leg is up and this leg is like this. This leg comes out. Baby eventually comes down. And because this leg is sort of in the way, you can't really tell if the baby is rotated or not until this leg comes out. And once that leg comes out, you'll see that the baby's stuck. And that means that this baby's bottom arm is going to be stuck on the pubic bone someplace. So the interesting thing with this one is that the baby, I tried to rotate the baby in different positions, and it really was difficult to rotate. So eventually you'll see that I put a lot of torque on the baby, and you'll think, oh, he's putting a lot of torque on that baby. And it's kind of, again, because I know what I can get away with. To get the point, I try to even reduce station a little bit, just to rotate enough to get my hand up there and get that arm out. Once that arm comes out, the baby comes out really easily. So let's watch, and then you can ask questions after. That's the last one. There you go. So this is at a birth center in Thousand Oaks, California.
Push down. Well done.
The baby's rotating.
Well done.
Your one leg is out.
One leg is out, baby.
Don't you say it? The dads always repeat what you say. You can wait.
Oh, baby.
Okay, the baby's staying right there now. The baby's kicking, maybe a little crunch there, trying to help himself out.
Do you want to know the sex of the baby? Do you want to go and see? Or do you want to wait?
I want you to stay there. It's just for
Stay there. Okay. Now, I don't think you need to wait for a contraction at this point. If you wanted to push, you're welcome to try to push. Okay.
Get your energy back.
Again, there's no reason when the baby's already out partly this far that you need to wait for another contraction. Sometimes you could be waiting 6 or 7 minutes and you don't really want to do that. So just have the mom instinctually push, and if she's not pushing at all, you might ask her to push. But we don't do, like you guys, you taught me, we don't do coach pushing. None of this,
Can you warm the room up a little
hold
bit?
your breath, count 1, 2, 3. I mean, oh God, we did that for years. So right now, you can't tell whether this baby's going to be sacrum transverse or upright.
Beautiful.
You can't really tell. You know it's going to be sacrum transverse because it says it on the slide. Yeah. So your whole positive, looks very similar to the baby Vale. Sort of exactly
second
the
leg's
same
out to
thing,
the
except
knee.
it's not.
Sorry.
With Vale, you could actually see the cord running. You could see the baby's belly was right in front of you. With this baby, now you're getting the idea that the baby is left sacrum transverse. So you can still say the baby has some tone, even though it's not really doing anything. If it didn't have tone, that left leg would just sort of. Well, there's no reason to do anything different right now, but certainly, yeah, if you think that you want to try to change positions on a mom because things aren't progressing, yeah, try all those things before you put your hands on it and do it.
Got really good
I
tone.
am like, sort of, like, at some point, I still have obstetrician in me.
Can you feel?
And I can't get it all out of me, and so when I reach a point where there's an impasse, I would just as soon not be monkeying around with positioning, and I just go get the baby.
See a real lot of progress.
This is a scrunch, okay? Baby's telling you what? Yeah, it's fine. I'm happy. I'm good. It's a little weird. Think about how for the first time the baby's actually had freedom, like to move its legs, and it's got to be a really interesting thing to think about. Like I said, out comes the right leg. I'm just sort of protecting the perineum. But there's steady progress. So as long as now,
the baby's rotating.
that's mom doing that, by the way.
So one of the arms is not.
But there's steady progress. But now at this point, baby's at the umbilicus. The cord looks
When
good.
the baby's arms
Baby's
is not
got
in the
tone,
right
but
place,
she's
the baby's
basically
trying
stuck
to help
sacrum
itself out,
sacrum
but
transverse.
can't. Okay, so I'm going to help the baby out a little bit. All right.
So we always talk about these things in the antenatal, the prenatal visits about what can go on. I offer to show them films, by the way. Some women want to see it. Other women don't really want to see it. So bring the baby up, and I'm trying to get the baby to rotate around. Seeing if I can get the baby's left arm, and I can't. So I try to reduce station a little bit. That's not working. The baby doesn't like that. So not the mom doesn't like it actually. So I'm putting a lot of torque on the baby to the point where I can go up and get that other arm that was way up over the. I'm gonna reach in and get it up.
Now you can push your baby out.
The baby's left arm is still up high over the head. So I'm going back over the top of the head, and I'm sweeping that arm out. Obviously, it's uncomfortable for mom, no question. So this arm comes out, and you can see the other arm will follow. It's stuck in the cord, but it just falls out.
Okay.
And then just a simple shoulder press, and the baby's out. Okay? So, it starts to look a little brutal, but you get an idea of what you have to do and what you can get away with. And so I'm very comfortable putting my hands up inside and resolving problems inside. And some people are more timid than that. This is just, it comes from experience and doing it for years. I often will reach up and figure out, well, I can't reach this arm, let's see if I can get the other arm. And rather than sitting there rotating back and forth, I'll do that. But I want to teach the basic stuff how I learned. All right, Brock maneuver, again, only for lithotomy position. Oh yeah, sorry.
Fundal pressure have been helpful in that scenario?
No, I don't think so, because the arm was the arm that was stuck. But again, also fundal pressure in the upright positioning is very hard to do. You have to either get behind her and give her a bear hug, or you have to turn her over, because you can't sit there and push on her fundus because she'll just lift off the bed. So that's why, again, I know that upright breech birth is great for unassisted breeches, but when I have to do complicated maneuvers, I'd rather have them on their back. You guys will only probably be doing upright breech birth for the most part, so you'll get better at doing them that. But fundal pressure is something that you could have used to do that, but it wasn't that it wasn't coming down, it was because the arm was sort of still stuck on the pubic bone. That left arm was stuck on the pubic bone. So fundal pressure is helpful for me when I can't get my hands on the baby. Once I can get my hands on the baby, I can get the baby out just by rotational maneuvering stuff. Yeah. I'm sorry?
Smelly beat where you flex.
That's for lithotomy position, yes.
Okay, yeah.
You don't really need that much for upright breech. But you can, if you're doing a shoulder press and it's not coming, you can then take one hand and keep it there and one hand go inside and get your hand in there. But there's so many other maneuvers you can do besides that, which again, we'll practice tomorrow. And I'll show you them. It's better, when we're talking about those intricate little maneuvers, it's going to be better when I show you on the models about how to do them. But Brock maneuver, was there another question before we, yeah, go ahead.
I had someone say that doing the love set kind of helped you figure out which was the problematic arm. That if the love set isn't working, you just go and grab whatever arm you can get.
Yeah, and sometimes I would just go, like a shoulder dystocia, I would just go in and get whatever arm I can get. Now I knew which was the problematic arm, because I knew that was the arm that was on the pubic bone, which had to be the baby's left arm, because that's the side that was down. So what I was going to try to do is I'm going to try to rotate that baby so that the left arm would come off of the pubic bone. But I was having trouble doing that. So I gave it enough torque where I could got the baby to where I could get my hand up inside and just come up behind the head, sort of essentially this arm, the baby's left arm was up here behind the head. So I rotated it was like this. I tried to go this way, I couldn't get the baby to go. So I put enough torque to get the baby here, and then I went way up here, and I brought the arm down. And as I brought this arm down, this arm was already was just in front, but it was tangled up in the cord. And as this arm came out, then this arm just fell out. And the baby corrected itself, so I didn't have to do any rotations to get the chin to be in the AP diameter. It was just sitting there, and then I just went ahead and did that.
Can we watch that one more time?
Oh, it takes so long.
Just the bit that where you intervened.
Ah, God. All right. Yes. Okay, hang on.
Asking for a reply from Emma.
Yeah. I'm not telling you should do that. I'm telling you that when you get comfortable, you know what you can get away with. So, when you?
Oh, you're doing great.
Oh, hang on. All right, let's back up a little bit. Okay.
And as well today, she needs.
Yeah, in the other mode, I can't use the timer. I have to go out of.
So could you try Leuven maneuver in that position or not?
Oh yeah, I could have tried to get my thumbs up higher. I just don't do that maneuver. So now I'm actually just trying to reduce station a little bit. Yeah, and then probably 6 different ways from Sunday to get this baby out. Right. But again, you can feel, if you can feel how much you can get away with, and you can feel that the baby's going to give or not going to give. You'll see when I show you the one that comes out sacred posterior. I tell you the story how much I try to get it. It will not budge, and you know it's not going to budge.
Hold your breath. Hold your breath.
Okay. No push now.
And see, when that baby was sacrum transverse like that, so let's go back to this mode here. When the baby was sacrum transverse like that, oh wait, I wasn't going to wait till the baby got floppy.
Yeah.
There's no reason to wait. A lot of people, a lot of midwives and doctors, well, midwives mainly because doctors aren't doing breech anymore, but midwives, they took Mary Cronk's statement about hands off the breech a little too far, and we'll talk about that when we get there. So this is the Brock maneuver. Brock maneuver is for lithotomy only. And the reason it's for lithotomy only is because if this woman, when you've turned this picture over, then what would that baby be doing? It would just be hanging there. So this is essentially, Brock maneuver is mimicking gravity that you have if the mom were on all fours. And nobody really thought about it. The supposed story is that Frank Lewin saw this Brock maneuver picture on his desk, and he walked away, he came back, and the book was upside down, and he saw this, and he said, oh man, that baby's just turned it upside down. That's where the story is, but I think he made it up. But nonetheless, it's just a simple maneuver of lifting the baby up that way. So this is a great story. This is Yanina and baby Rob. Yanina was a mom. They lived in Orange County, California, which is about 60 miles south of my office. And she called me at 34 weeks, and she said, I have a breech baby, what should I do? And I said, well, you don't need to do anything with me right now. Baby will probably turn on its own, but go ahead and all the things that we tell breech moms to try to do. Again, sometimes I think it puts them in a panic to do it, but spinning babies, chiropractor, acupuncture, moxibustion, inversions, all those things. And I said, if you get to 37 weeks, your baby's still breech, then call me and we'll do a consult. But I wasn't going to make her come up and do it. There's no point in doing a consult at 34 weeks. So about 3 weeks later, I have a woman in labor that isn't my client. It belongs to my friend Alex. But I used to have a package that I called the Dr. Stu on the Couch package, where for a lot less money than me being their primary caregiver, if they wanted me at the birth at the time, around the delivery time, they could call me and I would come and I would sit on the couch and literally be available just in case. So I had that morning, Elise was in labor, and Alex called me to say that she's in labor, and I said, okay, I'm in the office today. I just said, call me when she's getting complete and ready to start pushing. and I'll wrap up and come over. And she was in Beverly Hills, which was really only about 10 minutes from my office, so it was a very convenient location. So about 10 o'clock that morning, I get a call from Yanina telling me that she broke her bag of waters, and she's 36 weeks and 6 days. So I haven't met her yet. And so I asked her to have her midwife come and check to make sure she'd broken her bag of waters. And unfortunately, she said her midwife won't come because she's breech. And then breech, of course, freaks people out, and certain midwives they don't want to even have their name on the chart when a baby's breech. But the question I would always ask is, how did the midwife know she was breech? She might have been breech last week, doesn't mean she's breech today. So shouldn't you come and save the woman from driving 60 miles to just tell me if she's really ruptured or not? Because if she wasn't breech, she could have stayed home and her midwife could have come and delivered her baby. She wouldn't come. So I made Yanina and Rob drive to the office, and it took them about 5 hours to get to the office. They probably took their time that morning. It can be as much as a 2-hour drive, but they got there. Just as before they got there, I got a call from Alex telling me that Elise, the woman in Beverly Hills, was complete and starting to push, and I should wrap up my office and come over. I said, okay. Then Yanina shows up at my office, and she's calm. And I said, so what's going on? She says, oh, I'm still leaking. I said, are you having any bloody show? No. Do you have any contractions? Yeah, they're about 8 minutes apart. They're not very strong. I go, okay. So I have her go to the bathroom, and I have her get in the exam room, and I have her get undressed, and I put her up so I can do what's called a sterile spec exam. I don't know if you know what that is, but just wanted to see if she's really leaking water or not. And I put the speculum in, and all I see is the baby's butt. So I take the speculum out, I do a vaginal exam. She's 8 centimeters. Okay, she's 8 centimeters. She's like +1 or +2 stations. She's frank breech. And so now I've got a dilemma. I can't send her home because 60 miles, 8 centimeters, can't do that. Plus, I'm sort of stuck up in this area. I can't send her over to Cedars-Sinai, which is the hospital I worked at the time, because they would section her. And again, I'm a home birth. Well, I actually wasn't working but it was the closest hospital. And I was doing home birth at the time, so I wasn't at the hospital anymore. But they would have sectioned her. So one of my staff offers her house, which is not far away, but I say that's not going to be any good because I got to go to Elise's house. So because we have a great community in the birthing community there, I called Elise's partner, and I said, can we use your guest room? And he said, well, they had a big house, and they had a guest wing, and they said, can we use your guest room? And he said, yeah, just don't tell Elise. So we came over, and we got there about 5 o'clock, I guess, and we went to the other wing of the house, and she labored there. And to shorten the story, Elise delivered at 6:30 even that evening, and Yanina delivered at 7:02. 32 minutes later, in the same house. They couldn't have been more socioeconomically apart. This were blue-collar immigrants. This other woman's father-in-law was the United States Secretary of the Treasury. So you think about that. I mean, they had a place in the Hamptons and a private jet, and they had a house in Beverly Hills, and they couldn't have been, but because everybody in the birth community was tight and there was mutual respect, we were able to do that. So it's a great story. Eventually, when they were ready to go home, they went over and said hello to Elise, found out they were there, and they went hello. But this woman that's pushing with her right there, that's Elise's doula. So Elise had delivered, so this doula walked over and was helping her, and then it's just me and Bliss is in the picture. Bliss was my student at the time. So, but this is just an example, a nice story, but it's just a nice example of the Brock maneuver, and a little bit of love set, and a little rotation and an arm sweep. So let's watch. Okay, hold on. Now listen quietly. Is there sound?
She's conducted.
Where's the sound?
Okay. So now the baby's going to come out slowly, and we don't want you to tear, okay? So I'm going to have you give me a push. Okay.
So beautiful.
So this baby's coming out very similar to Aurora's breech home birth in the one in the documentary. She chose that position. And remember, I just met them 3 hours earlier. I had never met them before. So I violated pretty much a lot of my, well, she wanted a home birth. She was going to have a home birth anyway.
Nice. This is called frank breech. It's coming out with the feet wet by the head.
Okay. Nice.
That's Bliss before she dyed her hair.
underneath. Bring your arm underneath. Yeah. Good. Bring it underneath. Good girl.
I think if she was upright, this baby would just be hanging there, like you saw in all those beautiful videos. It just came out by itself.
Nice, you got it. Yes, there's a little leggy. There's a little leg. Good work. Good job.
Now, when the baby's coming to bum like that, you know where the arms are. They're right in front.
Good girl. Good
So what I'm going to do is I'm just going to rotate it very easily to get that arm out.
Let me know if you need a heart.
She's touching her baby.
No,
Cool.
Good. Okay, sweetie pie. Good, good.
So that's a little bit of a love set maneuver to get the shoulder.
Push, push, push.
I can see the armpit. So instead of coming up the back though, I just sweep it out. I should have come up the back.
She's moving all over the place.
Touch, touch, touch.
That arm's out. I don't even bother rotating it. I just go get the other arm.
You got her.
There's a lot more room posterior.
Yes, honey.
And then I just lift the baby up,
Come on, baby.
and the baby just comes out.
Yes.
It's a puppy, baby. I love you.
She did a reverse flip.
I love you.
Like, watch the cord, watch the cord. There we go.
Yes, good girl.
Yeah, I couldn't have been any nicer.
Perfect. Great work, baby.
So think about their day that day. The start of the day, 36 weeks and 6 days. And later in the day, they delivered in the house of the Secretary of the United States Treasury. Right. Lithotomy position. Yeah, no gravity. Right. That's the only indication. And again, remember, that's how all breaches were done until they came back with the upright breech delivery. All breaches were hands-on, which is why the response to hands-on was the pendulum swinging too far to hands-off. And, but yes, and remember, this is how I was trained. It's always worked for me. So, you know, that's just, it's like driving on the right side of the road, okay? Yeah, you're very comfortable driving on the right side of the road. Suddenly you're driving on the left side of the road. It's like not this. It's slightly different. Okay. Yeah, sure. Sorry.
When you're lifting the baby up, do you still have your hands on the same?
When lifting the baby up.
No. Once the arms are out, basically, once the arms are out, I just lift the baby up, and a baby with good tone, the head's going to follow, and it just comes out. This will work really well with the simulators tomorrow. You'll see, right? It's, again, the maneuvers you need to know a rotational maneuver, whichever one you prefer, or a couple, because the baby you may start down here, and the baby may lose tone, and you may move up here. That's it. You need to know the arm sweep, and then you need to know your head maneuver. And if your arm sweep is the same, if a woman is upright and you're doing your rotational maneuvers, you're sweeping the arm, except when I tend to sweep the arm that's in front of me. So when a woman is upright, the arm that's in front of me is the baby's posterior arm. When a woman is on her back, the arm that's in front of me is her anterior arm. There's actually more room posterior, but I'm looking to see the armpit, which is in front of me. It's easier to see the one that's right here than to go look under here and try to figure it out. But you're right. When you people ask this, well, when you put your hand in anteriorly when they're in lithotomy position, aren't you like right near the clitoris? And the answer is yeah, you're right under the pupil going to the clitoris. But it's, again, how it's worked for me for years. I don't try to overthink these things because it's worked so well. All I want you guys to do, I don't want you to overthink it. Breech Without Borders is a course where you can overthink stuff. And I just think, and I just love the way what Rick's has done, but they're always coming up with new stuff. Like initially they did the shoulder press, and then they come up with the rock and roll, where they were pushing the shoulder press more and more. And now she's told me they're phasing out the rock and roll. So why didn't you just leave the shoulder press alone the first time? You know what I'm talking about, people? Yeah. This rock and roll thing where you're just pushing a little bit at a time to get the head to slowly come out. She told me at the Kentucky Breech Conference they're phasing that out. You know, I never needed it in the first place. Okay. Anyway, let's keep moving, or we're never going to get. What time is it? 4? 10 past 4. All right. Let's go for like another 10, 15 minutes. Then we'll take another break. Okay. Okay. Got to keep moving. Okay. Hang on this way. Other rotational maneuvers we talked about. So you can see from the Lewin maneuver that when the baby's not quite far enough out, the thumbs, just in the diagram there, they're up inside the vagina. So I prefer to move the baby from down below if I can, so I don't have to stick my thumbs in mom's vagina. That's all. And then prayer hands maneuver is a very nice maneuver. And again, prayer hands maneuver, if the baby's only out this far, then prayer hands maneuver means your hands are going up inside mom's vagina. But the nice thing about this is that you have really control of the baby's torso this way. And so listen to what she says. She says, if the rotational maneuver is not complete and progress does not resume with spontaneous maternal movement, assume one or both of the arms are caught up on the pelvic inlet. You can encourage rotation with your hands at the bony prominences of the pelvis, much like love set maneuver, which we talked about. But if this is not easily effective, do not risk torquing or twisting the fetal spine. Instead, use prayer hands. With your fingertips against the bony prominences of the shoulder girdle, palms flat to avoid fetal organ damage. Make sense? Just like this. Okay. Then she says, elevate slightly to disimpact. So reduce station a little bit. Then rotate the fetal torso. Again, you're going to keep tum to bum, so you're going to rotate it this way. So the shoulders are in the transverse diameter. Descent should resume then following rotation. Once you have started to intervene, continue to assist the head to be born by manually flexing the head. So if the arms aren't out, then you're going to rotate the baby this way, with the fetal, and then you can sweep an arm out, come back up, rotate the baby this way, sweep an arm out, and then because you've done that and now the baby's hanging just like it's supposed to, don't just assume, well, now the baby's back to its cardinal movements, I'm not going to do anything. She's very clear about that. Once you have started to intervene, continue to assist the head to be born. And that's going to be with shoulder press in this position, or it's going to be, if it's in this position, it's going to be Brocked and potentially Marcel Smelly-Veit maneuver. Not complicated. It's not complicated. The Marcel Smelly-Veit maneuver is just where you generally want to, you're doing a Brock maneuver, but before you lift up for the Brock maneuver, you put your finger in the baby's mouth, with your middle finger in the baby's mouth and your two other fingers on the cheeks, and you keep the head flexed. You're not yanking on the jaw. You're keeping the head flexed, and then you're moving the baby with your other hand, and the head has to follow. You don't have the baby up here and then put the finger in and then try to yank on the jaw. Now, people will say, if you yank on the jaw, you're going to break a jaw. I've never seen it happen. Theoretically, I suppose it could happen. So then they came up with this thing called the modified Marcel Smelly-Veit maneuver. And that's where you put your fingers on the cheeks without anything in the mouth. But I will tell you, you can try that tomorrow, but it doesn't work. It's way too slippery. Baby, it's useless. So again, it's somebody overthinking the issue. They're thinking like, we never want to break a jaw. Have you ever seen a broken jaw? No, but I don't want to break a jaw, so I'll do it. I'll change the maneuver. You don't really need to do that. Again, it's not you're yanking on the jaw so much as you're holding the chin against the chest, and then you're lifting the baby as a unit going up. So this is another shot where you can actually see, it looks like the baby's being, but the whole baby is coming up and around. So they tried the modified Marcel Smelly-Veit maneuver. We're not going to waste time on that. Oh, one more maneuver I want to talk about is the Pinard's maneuver. This is the maneuver that you use for a baby that's in trouble that's just beginning to rump. So if you have a head down baby and you got this much head down, and you have a baby that suddenly has a bradycardia at this, and you don't have a vacuum, you don't have forceps because you guys are not allowed to, you should be allowed to, but you're not allowed to use a vacuum. What do you do at home? What do you do? Push? Is that what you said? Yeah, or fundal pressure maybe, to get the baby far enough out, potentially where you can actually Ritgen the baby's head out, that sort of thing, where you can get the baby far enough, because once you can get the head out, then you can do anything you need to get a baby out that's in trouble. But if you only have this much out and you push fundal pressure and nothing happens, you're sort of screwed. I don't know what you'd do. Cutting a large episiotomy isn't going to really help. That's not what's holding it up. Yeah. You had that scenario? So, yeah, it sounds like you've got an experienced, you've had your share of things happening to you. What did you do? Oh, we're talking about the bum? No, we're talking about the head.
Oh, no, I'm just
yeah, we'll get to the bum in a second. I'm just saying it because I'm comparing the Pinard's maneuver to the problem with the baby when you only can, there's nothing to grab. Do you understand what I'm saying? You can't grab the head. What's that? A deep squat, tough fundal pressure, whatever you have to do to get that baby out, because by putting the baby in calling an ambulance and stuff like that, if the baby's having a bradycardia, your baby's toast. So you can't.
The fundal pressure for a Catholic baby.
European countries do, I think.
They do, yeah. They put a hole with the fundal pressure, and they get a bed sheet around the woman's fundus, and they pull
Okay, well,
really hard.
that's fine. I mean, maybe again, I've never had trouble using my forearm for fundal pressure. I mean, if I have to do it. Now, the same thing occurs if the baby's coming down rump first. You have no handle. If all you're seeing is like baby rumping like this much, you have no handle. So what you need to do is you want to be able to get the far enough down so you can get your fingers in these two joints right here. Once you get your fingers in these two joints, you got a handle now. And so all you're trying to do is convert a baby that you're barely rumping, and sometimes you have to do fundal pressure, have mom push really hard just to bring it down far enough to get your finger in the posterior one, because it's not as easy to do. And I only do this, and I probably would recommend you only do this. I would turn the woman over for this and do it in lithotomy position, because then you have access to fundal pressure. That's what I would do. Because you're not waiting for gravity anymore, because once you do a Pinard's maneuver, you're going to do the entire maneuver you're going to entirely deliver the baby. Remember, once you start rule, you don't stop just because now you've got the legs out. You keep going all the way through. Everybody get that?
Section.
What's that?
I've seen people use it at section if they're having trouble with a breech extraction.
Yeah, you've seen that, and yeah, that's how they get a frank breech out the same way. Same maneuvers, by the way, by C-section. They have to know their maneuvers. So, and then what you do, this is the one maneuver where you're actually rotating and pulling at the same time. You're rotating back and forth far enough to when the legs come out, and then you ease the legs out, or, as you'll see when I show you this maneuver, in Sarah and baby Knox had no tone left, so the legs just kind of fell out, and they just lumped down. You'll see how easy they came out. And then once you get the baby's legs out, you're no longer with this little thing showing. You now have a baby that's out this far, and now you know what to do. Now you do your rotational maneuvers and get the baby out. So let's watch, but this is how they describe it. You guys have read that while I've been sitting there, I hope. Okay. And as for frank breech babies, unfortunately, cesarean delivery has largely replaced it. Yeah. So this is Sarah and baby Knox. Sarah's a mom in LA. She had a baby who's about 4 years old. She was having twins. The baby girl was born in the water almost an hour and a half before Knox came out. And she was just hanging out with baby girl on her chest, and everything was fine. And we were just waiting for labor to come back. Been about over an hour. And we were listening to baby Knox once in a while. And every now and then we started to hear little variables. And then the heart rate was just down. Again, it's hard to explain. There was no abruption. There was no cord prolapse that we knew of. It just went down. And we don't really, we don't know why, but I've seen this with twins before. Part of me emotionally thinks that he suddenly realizes his sister was gone, and he's freaking out. But for whatever reason, she was in the water. We got her out of the water and put her on the nearest thing, which I think was a couch that was covered with plastic and towels and stuff. And what you can see is, all you can see is the baby's bum beginning to emerge. The cord that you're seeing there is actually the baby girl's cord, because she's a twin. So what you're going to see a Pinard's maneuver. You're going to see a bit of a love set, not really. Once the baby's out, it has no tone. I wasn't going to try to rotate it. I just went up and found the arms. And then you'll see a Marcel Smelly Vite maneuver, and we'll watch the baby be delivered. Okay? Let's watch.
Good, Mama. Good. Do it again. Do it again. Just take a couple breaths and do it again. We're not stopping now. Okay? I'm going to do a breech extraction here once I can. Okay.
Come on, baby boy. Come on, baby boy.
The baby's not quite far enough out yet for me to get my fingers in there.
Push, honey, push.
So I actually I actually get one finger in anteriorly, and then I do almost a Ritkin maneuver. I don't go in the anus, though.
job, Mama.
It's the kind of Ritkin maneuver you do sometimes for the chin.
Keep going.
And I get the baby to come around the corner. And then I know I have to keep thumb to bum.
Go. Stay right with it. Good
Right,
job.
so now I get my fingers down. I'm just going to rotate the baby.
Okay. All right, hold on.
And you can see that I can easily get the legs out there, and there's just nothing. There's nothing there.
Okay, breathe. You're good.
I'm trying to figure out which arm I can get, and so I just go up and get that left arm. And I ease that arm
We're
out.
good, we're good.
Yeah.
Baby's not helping at all because the baby's floppy. Trying to keep calm in the room. So here I got to go up over the back because the baby's arm is way up over the top of the head.
There it is, there it is.
Booger, what'd you put your hand
Arm
over your
out,
head for?
And then little Brock combined with Marcel's smelly vibe maneuver.
Come on, there he is.
There you can take a baby that's in trouble and you use your hand, you get the baby out in about 20
You put your feet on
seconds.
me, okay? Just put your feet down.
Please.
So I'm watching some of you and you're all looking a little squeamish and stuff like that. But again, these are rare events. We're seeing a lot of them because this is what we want to learn. But these things don't happen. But with second twins, sometimes you have to do a breech extraction on the second twin, or you have to do maneuvers on the second twin. And this is why you're here, I hope. This is why you're all here. Any questions about what we did there? Yep. I don't, Mom can do, at this point, Mom does whatever she wants to do. I never tell her not to push. Well, actually, occasionally I tell her not to push. But no, if she feels like pushing, she should push. If she doesn't feel like pushing, it's really not necessary. It's not changing anything. Once I got my hands on the baby, whether it's Lovestead or it's Pinard's or whatever, then really I'm providing the propulsion of the baby. But if she feels like pushing, it's absolutely fine. Quite frankly, at that point, I'm really not focusing on what Mom's doing. If she's pushing or not pushing, it doesn't really change me. I'm focusing on getting the baby out.
And so for that baby, because it was bum to tum, you were just going up for the arms.
Yeah, I could have rotated from side to side, but again, that baby had no tone. You saw when the legs came out, they were just flopped. So if I was trying to rotate that baby from down here, because this baby was out about this far, and if I was trying to rotate that baby from down here, I'm just going to put torque on that baby. So the baby's out about this far, and so what I did was I just went in with my left hand, actually, and I just swept this arm out, and then this arm was way up over the head, so I went up inside and I got the arm and I just brought it down, and now they're out. I didn't have to pull, I didn't have to rotate. I knew where the arms are. I mean, the arms are connected to the shoulders, which is connected to, you get that song. It's really true, everything's connected. So once I get the arms out, then it was just a matter of getting the head out. And the way you get the head out with a baby with no tone is not just the Brock maneuver, because the head's just going to lay there. So I put my finger in the baby's mouth and lifted the baby up at the same time. That was it, yep.
Perineally, you said you weren't going anus.
Yeah, you guys know what a Ritkin maneuver is without going in the anus. It's just sort of going behind the anus. So when a baby's coming out vertex like this, it's coming out by extension. Can you see? You see? It's coming out by extension. Sometimes to get it in order to go around, to get it to come out by complete extension, you can actually just find the chin posteriorly, not inside the anus but behind it, and then just push up on the chin. It brings the baby around the corners. I'm not going inside the perineum, inside the vagina. I'm not going inside the rectum. I'm just on the outside of the skin. Is that what you're asking?
Yeah.
Yeah. Just on the outside. It's just behind the anus.
Yeah, some midwives would use that practice years ago called chinning, but sometimes it was.
Yeah. Well, I have never actually ever put my finger in the rectum during a delivery. David likes the Ritkin maneuver. I'm not a fan of it. I just think that there's so many other things you can do. The idea just bothers me. Maybe it's my Puritan Minnesota sensibilities, but I just don't like the idea.
But I did breach without orders with David, and he only advocates for Ritkins with the right indication. He's not sticking his finger up everyone's butt.
No. No, but I'll tell you, when he's teaching, when I see him teaching at like in Kentucky and stuff like that, everyone says that he really he likes that for when the shoulder press isn't working, is to go in with the yeah. What's that? Yeah, and I'm not saying it isn't. I'm saying that I've never used it. Right.
A good maneuver.
Again, remember that I'm not competing or comparing because there are many different ways to get to the destination. And these things have worked for me for all these years. If I can stay out of a woman's anus, I'm going to stay out of a woman's anus. That's just me. Okay. I'll make them beam. I'll make them beam like that. So.
Can I ask you, so the one that I had, the breech that I had with the bum that got to that point, so basically like we could see
The anterior butt cheek. You see generally see
the anterior butt cheek
yeah.
and the anus.
Yeah.
So probably like.
Yeah. So you're again because she's upright, so you're seeing this butt cheek and the anus. So you're seeing like that.
Yeah, that's what we can see.
Yeah.
And it just wouldn't move from there.
But you didn't have a bradycardia?
No, we didn't have a bradycardia. We had a like relatively normal fetal heart rate, but it was like 45 minutes like that. And the mum was getting really exhausted, and the contractions were getting further and further and further apart. And we just had no idea what to do.
Okay. So here's what you could have done. And again, you shouldn't be waiting 45 minutes. Breech babies should steadily progress.
Yeah,
you should never have.
We weren't waiting because we wanted to. We were waiting because the mum said no to transfer.
Oh well, then okay. Yeah, if the mom says no, then that's no.
And we were doing position changes and every other thing we could think of.
But if the mom says yes in this situation, and she's upright, and so here's her back, here's her pubic bone, and she's upright like this. What you can do is you can even get a finger in here, and you can hook that, and then you could do fundal pressure, and the baby will come down a little bit further, and eventually you'll be able to hook this one too. Once you get your fingers hooked in here, you have the baby.
I wish we did that.
Right, you can, because then you just rotate the baby out. Again, if you pulled it straight out, you're going to lock an arm or something on something. So this is one of those things. This is the only one that you rotate and pull at the same time. The love set maneuver, the shoulder maneuver, the prayer hands maneuver, you're not pulling as you're rotating. You're rotating and then gently pulling down. Rotating and gently pulling down. Again, I know this all is a little bit spatially confusing right now, but I'll tell you, learning this today and then tomorrow morning when we're doing it, it makes sense very quickly. So just bear with me.
What was the outcome?
I'm sorry?
What's the outcome of this?
Oh. Yeah, good question.
After 45 minutes, the second midwife, the primary midwife, just cracked it and was like, "We're going to the hospital right now." And just
Outcome
was like
was
and she got
that
up
the primary midwife
and she had
took her to the hospital.
Caesar, GA,
Code Caesar, GA, T-intersection, T-section.
See?
The 35-minute transfer and no monitoring.
Right. How was the heartbeat during this whole 45 minutes?
Pretty good.
Perfect. Yeah, it's just such a shame. Because again, if she says no, you have to say no. But bottom line is, if she had said, "Please help me,"
It was more that we didn't suggest that we did something. We suggested we transferred because we didn't know what to do.
Oh.
Before breech, and we didn't have.
Well, that.
The mainstream hospital breech training.
And in our minds, there wasn't enough baby to do the manoeuvres that we knew how to do.
Well, there's going to be now. Right. And if that baby had been if that baby had been down there, but there'd been a foot there, and the baby was completely dilated. Again, you got to assume they're completely dilated when they're down that far. All right. Then that's an easy one. Because now you got a handle. You pull that foot out, you hold on to that foot, you go up and find the other foot, you pull the other foot down, pull the baby out to about this far, you do your rotational maneuvers, and out comes the baby. Right. But when you only have a butt cheek, like you only have the top of the head, it's a little more difficult. But at least with the butt cheek, if you can get it far enough down, you can get your finger in this joint here, and then if you can get your finger in the posterior joint, now you have something that you can maneuver that baby with.
She would have been totally happy for us to be hands on the baby.
Well, she would have been cool with that. She just didn't want to go to the hospital.
She didn't want to go to the hospital.
Oh, I missed that. I thought you said she didn't want you touching her.
No, she would have been completely fine with that.
Yeah, well, you only know what you know. And if you don't know that stuff, then that's where we get into trouble. And that's why breaches get a bad name, is because people, sometimes they're surprise breaches and the people don't know what to do, and then there's a bad outcome and they say breach is the problem.
And it was a surprise breach, and we only turned up when she was in the second stage.
Yeah, but breach isn't the problem. It's the lack of skill that's the problem. Seriously.
Yeah, our lack of skills was the problem in this case.
Yeah. Thanks for admitting that, by the way. A lot of people won't ever admit that there was a lack of skill that would do that, so I admire you for that.
May I ask, Stu, just quickly, so the one that you were talking about was only this much bum on view, but a bradycardia and poor tone, which was why that baby wasn't descending. A baby with a good heart rate at this point in time that won't get past here, what is it stuck on? Is it?
Wait.
What?
So what's stuck on?
Why is this baby not descending? Is it a?
Oh, that's a really good question. Why do some women who have head down babies reach a point where they're just beginning to crown and then they don't get any further?
It's not an arm.
No, it's not an arm thing. It could be the contractions have lost tone of strength. It could be something going on with a dystocia somewhere higher up. I don't always know why a baby does that sort of thing. I mean, who might know that would be somebody like Gail Tully or Nicole Morales, because they have a great understanding of the pelvic inlet, mid-pelvis, and pelvic outlet, and the musculature and how babies come through. I've listened to their lectures many times. I still can't quite figure that out. It just does. My brain doesn't click around that what they're trying to express. Just like listening to that diabetic lecture yesterday. I got some points from it, but it was way over my head. And that sort of thing. Again, I am a simple clinician, a tactician. I can do these things, but if you're asking me exactly why something gets stuck or whatever else, other than I know why the arms get stuck, I don't know, because I know that why does a baby sometimes come down face or a mentum, chin? Why do they do that? Why are so many babies asynclitic? Some people understand that. I really never quite. Some of you probably understand that. It's the way their pelvis is, or the way they've been stuck in bed for so long, or they've been on an epidural and they're not moving, and so they can't help their baby to flex and move. Because the baby's got to do these movements inside the uterus, these reflexes that it does, and if it's hindered by something, it can't do them.
I think in our situation, once we realised, once she knew the baby was breech, she just was like, went into like a fear state.
She checked out? Yeah.
And her pushing wasn't effective.
How did the baby do in the long run? Do you know?
I don't 100% know, but it's at kindergarten.
It's what?
Kid goes to my school.
I didn't hear what she said.
Oh,
his child goes to school.
It's at the kindergarten.
Not special school.
No, not special.
Okay.
So
Yeah.
it's at kinder and functioning as far as I know.
Okay, good. It's good to know. All right, so
Stu?
yeah.
I was just thinking with that story then, if I was to encounter that at home, I think I'd be concerned about why baby's not descending from that point, and be thinking about transferring
Okay, but what if she's that way and you listen to heartbeat and it's 80? You're going to transfer?
It's not time.
Right. You have to get the baby out. And a lot of you are going to work where you don't have at some point in your life, you might be in a place where you don't have the luxury of being 17 minutes or 6 minutes from an ambulance or hospital. So if a breech is completely dilated and the baby doesn't have any anomalies, like hydrocephalus or something like that, then if you can get your hands on the foot or the pelvis of the baby, you can get that baby out. And by the way, if you cause a brachial plexus injury, if you break a clavicle, if you break a humerus, those things heal. Doesn't heal. Well, cooling, they're doing some remarkable stuff with the cooling and stuff like that, but most of the time the brain doesn't heal. So if a baby's hypoxic and you're waiting for an ambulance to come, and there, by the way, I'm going to teach you tomorrow a maneuver which you'll probably never use. But if you have a baby that's like, at 0 station plus 1 station head down, and it's got a bradycardia or there's a sudden cord prolapse, and you're, 20 minutes, 30 minutes, an hour from a C-section, you can actually turn that baby to a breech and pull it out. It's called internal pedalic version. And you just basically reach in and you push the head back up inside. And you find a foot, you pull the foot, and you get the foot and you pull the foot down. and then you reverse the baby and pull it out by its feet, and then do your rotational movements. We're going to practice that tomorrow. And even though it's not something you will ever do, it'll get you used to putting your hand up inside. Plus, you'll bring the baby down, and you'll have to practice your floppy baby maneuvers anyway. So, but yes, if you have the option of transporting and everything is stable, and you don't feel comfortable doing that, that's what you should do. You should practice to the limits of your comfort. However, if it's going to make a life or death difference for the baby, then you should give it a shot and try to get the baby out. And if you get yelled at for that afterwards, you know you did the right thing, so you have to live with yourself and your God. And that's how I would justify it. Yeah. Okay, we got it. Let's see. What time is it?
Can I ask one more thing? Sorry, I know.
Yeah, this is why it takes all day. So.
Are you a bit of a? Do you wait with just a drop foot, no sign of the buttocks for however long that takes? Because that's the other educators say, you know, in a hurry. Then if it's just a foot through, but no sign of rumping yet, and it's because you know it's a complete or incomplete.
Yeah.
There's plenty of time. We don't have to.
Yeah, if the baby's with the foot sticking out and the baby's rump a little higher, that's okay because you're still listening to the baby's heart rate up here. If the baby's fine, that's fine as long as the baby's making progress. Doesn't have to be fast. I've had foot sticking out for more than an hour sometimes.
I feel like that's what they said too. Yeah, you can.
Yeah.
It's not starting that pushing stage yet. It's just the foot there.
If she doesn't feel like pushing, I wouldn't coach pushing as long as the heart rate's fine. If the heart rate wasn't fine and she was completely dilated and I saw a foot, I got a handle. I'm going to pull the baby out if I have to. Now, remember, when you pull a baby out, you're probably going to cause an arm to go up, and you're going to have to do you can't just pull it all the way out. I mean, with the Sophie models, you probably could because they're so stretched out, but in real life, you can't do that. So you pull a baby out to the point where you get it this far. You'll see how it works. And the Sophies are very, very realistic for a lot of the things. Obviously, the situation isn't realistic because your heart isn't pounding. You know the old saying about the practitioner's heart rate is inversely proportional to the baby's heart rate? Have you heard that? Think about it for a second. Yeah. The lower the baby's heart rate goes, the higher your heart rate goes, right? Because because your adrenaline is flowing.
Would you say that's quite normal physiology for a drop foot to sit there for an hour, or is that quite unusual?
Yeah, it can be. It can be. And again, if early in your career you have this and it makes you uncomfortable and the baby's fine and you want to transport, there's nothing wrong with that. There's nothing wrong with that, but you realize you're transporting her in for a cesarean section and a potentially more horrendous course with a teat incision or a jade incision or whatever they did to her.
The situations I've seen, there was 10 minutes of CTG tracing when she got there. So it wasn't terminal, it wasn't great CTG, but it wasn't terrible. I think the heart rate was like 170. And then she had a GA Caesar and they had to push the baby back in. And they couldn't get it out, so they had to cut her uterus that way. And so it took 15 minutes to get the baby out. And then they blamed us.
Yeah.
The baby being more blamed.
Right.
And nobody knows.
No, they'll always blame you. Don't you know, I know this from a fact because in my family and in my situation, it's always my fault. Everything's my fault. No, but of course they'll blame you because you let her labor. How dare you let her labor? Look at the situation you put us in.
Even though the family only called us when she was pushing.
Well, I didn't understand that.
And they blamed us and they said that the main reason why was because we didn't diagnose the breech. But they only called us when she was pushing. With a bum on view.
Wait.
We weren't there for her labour. We didn't see her in labour. They didn't call us to come.
Oh, so they didn't call you until you got there and then you noticed it was breech.
Yeah.
And then it wasn't moving, so then you called. Right, so because you didn't diagnose it was breech the day before, it's your fault.
Yeah, and I saw her the day before because her waters had broken.
Yeah. What are you going to do? Right. I'm sorry about this, guys, because this is my profession that's stupid. They're just stupid. All right.
They have such a strong influence on the families as well, though. Like, that impacted this family so intensely, and then the family blamed us as well.
Yeah.
Because they told the family that it was because of us.
Well, the number one reason why people get sued in the United States, we believe, is because somebody else tells the woman, a friend, a family member, a doctor family member, or whatever, tells them that they would have done it differently or they did something wrong. and they don't, I mean, again, like I'm saying, they don't know anything. I've seen so-called medical expert after medical expert say the wrong thing, not know something. It's a world we live in, and again, as my partner Howie used to say, getting sued is a cost of doing business. You just have to know you're doing the right thing. And we have to live, it's a fact of life as a birth worker, right? So unless you guys all go on strike and say, we want indemnity, and we want to be able to take care of anybody we want, and we don't want the government in our face, this is going to continue, this kind of thing is going to continue. We got to move on, guys. So do we want to take a break, Joe? Yeah. All right, because we still got a ways to go, so. You're a great group and you all have great questions. Sometimes I can't hear them very well, but I'm going to try to streamline it now and go through things so we can get through what we have to get through, okay? Let's just take 10 minutes. Arr.
Stolen by the thieves, but you wasn't in life, found a hole in me. The taste of cigarette is never gonna fill you up the way the candle sway. Could we run with the wolves if this love is the one we choose? Are you ready to release me now? Won't let the sky fall to the ground. Could we run with the wolves? You swept me up in evergreen, a color that I didn't know existed. And I got caught in the hollow sea. We're all following time instead of taking what we need. The taste of silver rain is never gonna fill you up the way the candle sways. Could we run with the wolves if this love is the one we choose? Are you ready to release me now? Won't let the sky fall to the ground. Could we run with the wolves? Are we brave enough to change the love that's gonna make us brave? Are we brave enough to change a heart we couldn't breathe without? Could we run with the wolves if this love is the one we choose? Are you ready to release me now? Won't let the sky fall to the ground. Could we run with the wolves? Could we run with the wolves? Could we run with the wolves? Could we run with the wolves?
with a couple days of clothes and some wine to stop the cold.
Oh. I was going to just tell you, David does like the Reteach Breech, by the way.
He probably.
Yeah, he does. Right. So,
He does talk about it a lot.
yeah,
And I heard him talking about it at lives and stuff. So.
yeah, he likes the maneuver. So, I mean, it's sort of become a
He says,
teasing thing.
he says the anus is right there and it's open.
Yeah. You know what, he's probably right. I just have an aversion to that.
Yeah, I get it.
Right.
Me too.
Are people going outside? Oh, no, that's fine. We're going to get started, though, so come back right away. Okay. What is she going to do? What does she do? Oh, really? Oh, okay. What kind of thing? What's a formal for? What does she have a formal for? Oh. Okay. All right, guys, let's... So, just to remind you, we've been watching pathology. Just to remind you what normal looks like, this is Dr. Lewin from Germany, speaking German. This is just another vaginal breech birth. I just want to put this in here to remind you what normal is like, because we get off on a track and we're seeing pathology after pathology after pathology, and I want you to understand that what's normal. So let's watch normal.
Sehr gut. Sehr gut. Und jetzt puste dein Baby mal raus. Richtig feste.
So,
fantastisch.
This baby's emerging.
Willst du einen kleinen Schub noch mitgeben, mal Bauchmuskel
Looks
anspannen?
like right sacrum transverse. Everybody sort of see that?
Fantastisch, super gut. Jetzt einmal nicht erschrecken, das kennst du jetzt. Jetzt halte ich nur einmal hier oben fest. Nicht erschrecken. Und zweite, du sagst mal, was passiert. Nee, kommt schon. Versuch trotzdem mal das Becken weit zu lassen.
Super.
Schieb.
That means push.
Schieb weiter. So, die Beinchen fallen gerade raus.
Cleavage right up the middle.
Voll. Schieb nochmal. Schieb weiter. Schieb weiter. Komm, schieb mal gegen mich.
One arm.
Schieb gegen mich.
And the head
Ja,
comes out
fantastisch.
faster than you can
Gut. Guck mal zwischen die Beine. Herzlichen Glückwunsch.
I want to remind you that that's what you're going to see most of the time, despite the fact that we're spending so much time on pathology. Baby was right sacrum. Let's see. It was right sacrum transverse. It rotated tum to bum. The legs delivered. The cleavage ran right up the middle. Baby did a small tummy scrunch. One arm came out, the other arm came out, and the head delivered by flexion, but it happened so fast you couldn't really see it. That's your typical birth. And one of the things I'll emphasize at the end today is if you're going to start doing breeches on your own, I strongly recommend, and sadly I say this, but I strongly recommend you start with multips. Get your resume up, get your confidence up, work with multips. They're more forgiving. Success rate is about 100%, well, in my practice, but it's going to be a high 90% for multips, whereas with primips you're going to be 80%, 78%, that sort of thing. So why deal with transports and other things and get your skills up? So start with multips. Let's keep moving. We're going to have to move. So this is a very rare case. You just showed me of a sacrum posterior. Sacrum posterior is a very rare. I've seen it once in my career, and this was it. Now I've seen it twice because I just saw a video where that one resolved by itself. She what? Oh, she was a multip. Okay. So this is a situation where Sandra, this is her second baby, so she's a multip. She was on the floor pushing on all fours, doing great, and there was sudden bradycardia. Now, did she have an occult cord prolapse or something? Maybe. I don't really know, but we tried changing positions. We tried all the things that we would normally try to do to get the baby's heart rate to come back. It did not come back up. So we put the baby on the end of her, we put her with mom in lithotomy, because that's my go-to position to have to do stuff, on the end of the bed. So she's on the end of the bed. The thing that looks like a rug in that picture is actually the sleeve of the doula's shirt. So that thing there, it's not part of the bed. It's just funny looking because it just fits her leg. So she'll move out of the way. But all you can see in this picture is essentially 1 foot and the balls. That's it. So I have to get a baby out with 1 foot in the balls. So at this point, my heart rate is going 100 miles an hour. And so what I do is a breech extraction. I get both feet, I get them out. I pull the baby out, which is what you're going to practice tomorrow. Except the one thing you don't want to do when you pull a baby out is make the mistake of rotating the baby to sacrum posterior. You could pull the baby out sacrum transverse. You could try to rotate the baby to sacrum anterior. But when the adrenaline's flowing, even an experienced breech practitioner can make a mistake. And then I've timed this thing a million times. It takes me 23 seconds to recognize that the baby's upside down. And so then what you do when that happens, and we'll practice this tomorrow, is if a baby is upright, so the baby's facing you like this, it should be this way when the mom's upright. But let's just do lithotomy position because that's what she's in. So you'd like to see in lithotomy position, you'd like to see the baby come out this way, just like you did with Aurora or with Yanini, that sort of thing. But when I pulled the baby out this way, I pulled the baby out and it came out directly this way. Right? So I got a baby sticking out like this. Now I'm thinking, great, it's not transverse, it must be fine. And I'm trying to rotate the baby. I'm trying to do my love set maneuver. However, then it's not going anywhere. So then I try putting torque, and I try reaching up to see if I can get an arm, try turning the baby. Then finally I realize it's upside down. So what you do when a baby is sacrum posterior is stop monkeying around like that, turn the baby around. How do you turn the baby around? You put one hand on the belly, one hand on the back, and you just shove the baby back up a little bit, and you rotate 180 degrees. And you watch how easy the baby comes out once I figure this out. It's good, you know, I mean, I think, I have to show this all the time, but I still get a little embarrassed by the fact that I did not recognize it. But again, you can see what happens when your adrenaline is flowing. So let's watch and see what happens. But that's the theory. I still don't know why the heart rate went down. A lot of people, these things are happening. You ask the questions, and you see this sometimes, and you just don't know why that it happens sometimes. Because she was on all fours pushing.
Hold it in your mouth. Take a deep breath, now hold it.
So again, all I've got is a foot.
Oh, that's scrotum.
Okay. There you go. Okay,
There we go.
Okay.
Now I should have rotated the baby, but I pulled the baby straight out.
Deep
Now
okay.
I'm trying love set maneuvers.
Okay.
But you can see it's not going anywhere. So I'm still thinking that I could just swoop
You're
it
doing
over.
great.
Okay.
Got it.
Okay.
Push it up, push it up.
Yeah.
Push, Sandra. You're doing great, you're doing great.
She's German, by the way. She might be shouting.
Baby's the wrong way.
Okay.
So I said the baby's the wrong way.
Should she
Push.
turn over?
Okay.
No, it's 23 seconds.
Be quiet.
So what I'm going to do is I'm going to put one hand on the baby's back
Towel? Can I get a
and
towel?
one hand on the baby's front.
Okay, be quiet. I need.
Go for it.
I'm going to push the baby back up inside. I'm going to turn the baby 180 degrees. Now the arms are right where they belong. They just pop out. And the baby comes out with a Marcel Scully vice maneuver. And the baby comes out.
Give me a push one. There we go.
There he is.
And that baby did
All
fine.
right, somebody listen to the heartbeat.
Because this is baby Drew. That's the baby there, all right, with his big brother. But again, to show that these things can happen, and you've got to try to keep your cool. I sort of didn't like. I don't exactly know. I don't try to remember why that I wasn't thinking very clearly there. I think it was just the adrenaline was flowing because the heart rate. She'd been doing great, and then and she's a multip and she's a breech, and it's like this is great. And she's starting to push. I'm starting to see a foot, so I know I'm in good shape. And then suddenly the heart rate went down, and I got her up on the side of the bed, and there were a lot of people in the room, which is also a little bit added pressure, I think. And then, you know, I pulled the baby out, and I just didn't realize it. It took me 23 seconds. Once I realized it, it really wasn't that hard to just turn the baby over and then get the baby out. So, what's that? Who said that? No. Oh, she wouldn't have known that. Really? Oh, well, we're wasting time, but let's watch it again, all right? Tell me when they said that.
Hold it in your mouth. Take a deep breath, now hold it.
What's this? Oh, that's scrotum.
Okay. There you go. Okay, let's go. Okay.
You got mom and dad in pain, too.
Deep breath.
Okay.
And push. Ready?
Okay. Okay.
Tell me when.
Okay.
You're doing great.
Bear with me.
Got it.
Okay.
Push it up.
You're doing great. You're doing great.
Oh, push it out?
Maybe it's the wrong way.
Okay.
Yeah, she didn't say push it back in. She didn't.
No, she can't try it.
Push it in?
Push it up. I had push it up, push it up. But that's what I'm hearing. I don't know.
I wonder what she was saying.
Yeah, she's saying push it out.
Push it up?
Out.
Oh.
Yeah,
She has a German. She's got a German accent, so.
It makes sense that she would say push it out, but when I heard her say push it up, I was like, yeah, you should.
Yeah, I don't know. She did clearly she didn't know what was going on, and clearly I didn't either. So that's the way it works. But again, once you figure it out, it didn't take that long to solve the problem. So that's the important thing is that sacrum posterior babies, unless they're really rare conditions, are not going to deliver by themselves, and they're going to end up in real problems. So you need to be able to just turn them around, just reduce station, get the spoon out of the drawer, and then open the drawer. That's all you have to do.
And does it matter which way you go? Like with that one, we both thought we'd go the other way and then the baby came out the other way. Does it matter which way you rotate or it doesn't?
It shouldn't matter when you reduce station. You should be able to rotate either way. Obviously, whichever hand's on top, you're going to rotate toward that direction. Otherwise, you're sort of going like that. That's not convenient. You're going to tomorrow. When you try some of these rotational maneuvers, you'll put your hands on the wrong way, and then you'll realize that they're the wrong way, and you'll fix it. You'll see. You'll see. Okay, shoulder press, very straightforward. You've seen shoulder press done before, a couple of births already, but there are many different ways to do the shoulder press. I sort of just like doing it with my hands underneath, so when the baby comes out, I've caught the baby. But sometimes you'll push from here and the baby will fall on the bed. Other people, Rixa sort of likes this one where you push from here and the baby falls into your chin. I just kind of have a good feeling about it, but it really doesn't matter. All you're doing is pushing the baby backwards, causing the head to follow and deliver by flexion. It's very simple. So,
In the early ones you were showing us of the midwife who was birthing at home with her breech baby with her husband and her son, and you said a back press. Did you mean that she just...
No, she did a shoulder press from the back. The baby was hanging like this, and all she did was pull the baby this way.
Oh, okay, thank you.
So essentially, if I was behind her, I'd be pushing the baby this way. That's what she did.
Yeah, thank you.
Right, she knew exactly. She was basically delivering the baby's head by flexion. She was doing the head by flexion. Okay, so I hate the fact that we're going to run, we've got to move, but this is just a midwife in North Carolina, Brooke. Oh, hang on, you know what? I'm going to do this. I'm going to save a little bit of time here.
Yes, you got it. Good.
So you can actually see capillary filling on this one.
Great, baby. You're doing so great.
Oh my God.
You got it.
So great.
See how white it is? And it turns purple.
She's coming.
She's a Frank Breech. Yes, she is.
So this is a completely unnecessary shoulder press by this midwife, but it's actually a good example of a shoulder press. So
Keep pushing.
Oh, you're doing so great.
Yeah.
Keep pushing, baby. Here she comes, baby. You got this.
Keep pushing, baby. Keep
You're so
pushing.
great. I love you so much. Keep pushing.
Come on, Marcy.
So there's absolutely no reason she needs to do that.
Beautiful. That's it.
Gail Kelly likes that bringing them up maneuver, and then the shoulder press. So again,
Oh, yes, baby. Oh, yes, baby. Oh, my gosh. Oh, my gosh, you see it?
no reason she needed to do that. Gluteal lift, we don't even have to talk about. Going to move on. There's no reason she needed to do that, but it's such a perfect example of a shoulder press I wanted to show you. But ultimately, that was unnecessary. There was no reason. That baby was going to deliver by itself. If she would have given it another 30 seconds, it would have come out by itself. This is Kayla and baby Cambria. A very similar situation. At this point, when the baby's arms are out, I watch for like a few seconds and I say to the mom, you can push this baby's head out, or I can give you I can help you. And you can't really hear her, but her response was, help me. So again, I'm giving her the option of letting her help me. I'm letting me help her. And that's why I did a shoulder press here. I could have waited a little longer, but I always want to let them know that there's an option that I can shorten things for them if they want. Some people say you shouldn't just leave her alone and not say anything. It just depends on the relationship. This is a woman who I got to her birth about 9 minutes before she delivered. So this was at a birth center. So let's watch, because it's a very cute little scene with her son comes into this picture here. Why isn't it going?
Baby's coming.
Oh, here's the baby.
This baby. You can bring the camera over here if you want.
I'm right here.
Oh, okay. Keep breathing. Just keep breathing. So we have great tone and capillary filling.
Keep breathing. Good job. Keep breathing. Good job. Keep breathing. Keep breathing. You're doing a good job. You're doing a good job.
It's so great that these kids just it normalizes birth for them.
Nice big breaths. Nice big.
So we watch for the
So
tone.
this is one where, because she's
rotated
complete
almost
breech,
and,
rotation actually takes a little bit longer.
So that means the arms
So
are properly
whoever asked that
aligned.
question earlier, I forgot who was that asked that question. Was it you?
Big breaths. Big breaths. Good. Big breaths.
Baby's
Try to relax.
stretching a little bit.
Good job. Big breaths. Good job. Big breaths. Good job.
It's not quite tum to bum.
Baby's half out.
Everybody agree?
This is baby.
Right.
Yeah.
But I'm just waiting for her to push. Now, she doesn't have to wait for the next contraction. At this point, she can just push.
Yeah, isn't this cool?
Here he comes.
There
Okay, so we got the cord.
Now, the baby actually is rotated. The cord is way over to the side. But see, there's cleavage running right up the middle.
You don't have to wait to push now, hon. There's a scrunch. Here comes one arm, and the other arm is going to come out. They're both there. One arm, two arms.
Okay.
Good. Perfect. It's going well. It's going well.
Nice tummy scrunch. Bring those arms down.
Yay!
Keep breathing. Keep breathing.
Good job.
Come on.
Keep breathing.
Okay.
Keep breathing. Keep breathing.
So you can give us a push, or I can help the baby out now. Okay.
Push,
You wanna
Kayla.
You can push.
Give us a piece of push if you want.
Push, push. Push.
I'll get my head out of the way.
That's all.
Maybe
There you
take it
go.
out. Okay, so it's just a
Help the
shoulder.
baby in front. Who's
All
going to
you're
take the
doing is
baby?
pushing parallel to the floor. Push the shoulders back. The head has to follow by flexion.
Right, Mom, just sit back.
Okay. Gotta keep moving though. So, hands off the breech does not always mean always. So, one of the complexities of our profession is often a fine line between our desire to support and honor our clients' wishes and let breech birth just happen versus when our in judgment and sometimes from our own past experiences and innate anxieties we believe we must intervene, which is why sometimes you'll see maybe you would have waited, I would have intervened. Maybe you would have intervened and I would have waited. It's an art. It really is an art of midwifery, an art of obstetrics. We have to do. However, what happened was breech used to be taught that the use of hands-on and extractions was necessary for every baby. Every baby had that happen. Piper forceps to every baby. So in response to this overuse and meddling came the mantra, hands off the breech. What is true is that neither extreme is a substitute for experience and good judgment and skills. Okay. So I'm going to show you some where maybe hands off the breech was not a good idea. All right. So let's watch this one.
Go, go.
Oh, hang on, I can't. Oh.
All right, okay.
Actually, you know what? Let me escape from this one. And let's watch it so I can move things along, okay?
Go, go.
Oh,
Okay.
hang on, I can't. Oh.
All right, okay.
So this is a
That's
midwife.
the
They
way.
sent
Yes,
this
you
to me
can.
for review.
Yes, you can.
You're doing it.
You are absolutely doing it.
That's it.
Beautiful, beautiful. Go on, go on.
And you're going to see everything's
Push
going
baby right out.
going nicely.
Bit more.
That's it.
Come on, baby.
You're
Go
doing
on,
it.
go on.
Come on.
That's the way. Keep it coming. Keep it coming.
Come on.
So mom's in sort of a lunge position. She chose to be there.
Yeah, go on, that's it,
Yeah,
that's it, that's it.
That's it, come on. Come on,
Yeah, go on. Tiny brains, look at it. Beautiful. Well done. Perfect, perfect. If you can. Up to the knees.
So the baby's rotating, everybody agree?
Well done. Okay, that's the legs, okay? Legs are out, okay?
With the scrunch, you've
Well
got
done.
baby tum to bum, the cord is off to the side, but the tum is directly to the bum.
Yeah, she's filming. Yeah, she's filming. I'm
Okay.
taking pictures.
So that baby's out to that far
just
at
carry on if you want to.
1 minute and 30 seconds.
If you can push a little bit more, you can. If you want to wait for the surge, the baby's
Another
doing
scrunch.
it now. Baby's doing it.
Breathe now.
Baby's doing it. All right. Baby's
Breathe now,
turning.
get ready for this.
The baby's doing it itself. Don't worry.
Come on.
Perfect. What a clever baby. Look, first arm.
Clever
Baby's
baby.
coming out.
First
So you notice the
arm
tone?
is out.
Okay. So we notice the
You're
tone of the
doing it.
baby.
You
So
are
that's the
doing
first
it.
arm is out at just
Here
under
comes
2
the
minutes.
second arm.
It's it. Baby's coming out anyway.
Baby.
You can give it a little
Now you can
extra
see the umbilical
because,
cord off to the left. It was never really that robust, but it's
It's fine.
harder to see. There's still some coils in it. There's still some blood flow in it. But the baby's tone doesn't look very good.
It is a weird sensation, yeah. Do you want to try a little push to see if we can nudge this second arm out? No, there's nothing?
Now, one of the things that Sean Walker likes to say about timing is that if there's a pause for more than 90 seconds, it's unlikely the baby will be delivered without some sort of help. But again, I don't like to use exact time. But I'm looking at a baby here that doesn't have a lot of tone. And it reached a point where that arm got there, and then she's helping the arm out. So now she's helping the arm out at a little over 3 minutes. Okay, so at 3 minutes, the baby makes what looks like actually a little bit of a gasp.
Right, we just need the head now,
So
okay?
we're at 3 minutes, baby has no tone,
Yeah, if you want to push,
and it's
yeah.
just sitting there and the arms are out. So everyone in this room would do what right now? Shoulder press, 100%, okay? So to save time, that's 3 minutes. Let's go to 4 minutes. Here's 4 minutes. Yeah, I know, here it comes, guys. Let's go to 5 minutes. Let's go to 6 minutes. Hardly any, but there's no reason to wait for them, obviously. Right. And nobody's telling her to push. Because at this point, there's really no, at this point, this baby needs to come out. So we're 3 minutes out. Now let's go to 7 minutes. So now we're 4 minutes out from both arms being out and one of the arms being assisted, even though it wasn't much of a maneuver. All right, let's go to 8 minutes. So finally, let's go back a little bit here. Let's go to here. So we're at, let's see, yeah, oh, can you see it? Oh, it's running there? Oh yeah, you guys can see it better than I can. Right, so we're about 4.5 minutes, excuse me, since the baby's arm came out. And she's finally deciding, she's thinking about doing something, but she's still not doing it. Oh yeah, it is. Okay, hang on. Is it moving? Now she's moving. Okay, there we go.
No surge. Come on, Serge. I'm trying to see the push anyway.
What's that?
Yep.
Right, there's no reason that matters. There's nothing in the uterus anymore. The likelihood that the baby's head will come out and the placenta will come out together is significant, is moderately high. So now we're at almost 8 minutes, or almost 5 minutes since the arm came out, and she decides to do a shoulder press. And she does a shoulder press, the baby's head comes right out easily. So then they put the phone down. So. Okay, so again, I just want to reiterate that that's hands off the breech way too long. And and I don't know the midwife. I just got the film to look at. I don't know the midwife, and I'm not there's no judgment here. It's just that 4.5, it was like 4.5 minutes beyond when the arm came out. There was no tone, there was no tummy scrunches, there was nothing. She's waiting for a contraction. Everyone in this room knows that that would be incorrect. And even before that other arm came out, when she reached up and got the other arm at 3 minutes, and a minute before that, the baby didn't look so good. So the baby's not looking good, it's not going to get better. So get the baby out. Okay? No, there was nothing, right? And maybe she would have pushed and it would come out because it came out pretty easy, right? That baby did fine. Yeah, that baby did fine. Babies are kind of remarkable. We have one where the baby didn't do fine. We have that coming up. Well, actually, I just have stills of that. Just to reiterate again, these are the reasons to intervene. We will all look at them again, but it's just important to notice them. Whoops. Okay, so we saw that one. Let's watch one, the opposite, where the midwife assesses the baby and immediately knows there's something wrong and does something about it. So I like this one. I love this midwife.
Oh, beautiful.
Okay.
Oh!
He most definitely is coming. There you go.
The baby's rotating nicely. In this situation, there's one thing that I would tell the mom to do, and that's to get up off the bed, right? It doesn't do any good to have gravity if your baby's butt's sitting on the bed. So they actually tell her to rise up.
There you go. Beautiful.
And you guys all knew that. This is good.
Good job. Keep going, keep going.
Now again, right now there's no reason to wait for a contraction. Mom is deciding to push on her own. Okay, so baby's thumb to bum. Cord looks good. Lighting is bad. Baby doesn't look like it has much tone. Everybody agree with that? Okay. So watch what the midwife does. She doesn't like it.
Help this baby out, okay?
So she goes in, she knows the arm, she doesn't have to do much because she knows the arms are right there because the baby's thumb to bum, so there no rotations are necessary. She gets both arms out and she does a shoulder press. And she gets that baby out literally in about 12 seconds. That was the right thing to do. Baby was doing everything right, it rotated right, the arms were coming down, but she noticed the baby had no tone and she went right in and got the baby. So, hang on, get rid of that. Oops.
Stu, with that baby, when she did the shoulder press,
Yep.
there was a lot more pushing. Does that mean that head was a much
Yeah,
more?
well, there's no tone either, so baby's not helping itself anymore. A lot more pushing. But there's no reason to cut an episiotomy for that. You can get the baby out. And if worst case scenario, the baby's head was way back, you could have someone do suprapubic pressure. You could maybe try to get your finger in the baby's mouth. Or the last thing you could do is theoretically do a one-handed crowning touch, which we'll work on tomorrow. As well, I don't have any pictures of crowning touches. I have never used a crowning touch in my entire career. Yeah, Betty Ann likes with its two hands if they're upright. But sometimes if you have to do a shoulder press at the same time, you can do it with one hand. And you can actually put your whole hand in and curl the baby's head forward to flex the head as you're pushing the shoulder back and it comes out. You can get your whole hand in there if you have to. Okay. So we'll talk about that. Just a reminder, again, of what's normal and what needs help. So this next one is what a primip does when the baby doesn't, this is a primip, Sabine and baby Raphael, all fours, frank breech, where rotation doesn't happen, and you can watch what happens. The only problem with this video is that the husband edited it and put it to whale music. So I'm going to play a little bit of it, and then we'll let you guys go ahead and I'll just turn off the whale music because I can't handle it for 6 minutes. I get, you know, LA is filled with filmmakers, so this was his way of being artistic, I actually think. Right? And then he fades, whenever the contraction's over, he fades out and fades back in again. So he did a lot of editing, so I'm just going to do this. Right. So I can talk about it. So this is much more like a primip. This is much more like a primip head. It comes out, you think it's going to make it, you think it's going to come, and it goes back in again. And then he fades out, then he comes back in with the next push. We have my friend Monica, my midwife Monica, was very fastidious here. This was, actually, there's a funny story behind this. This was supposed to be a birth center birth, sanctuary birth center, but both rooms were taken. So we actually are doing this birth at Monica's house, the midwife's house. And this is Monica's first breech. So that's three contractions. Here's the fourth contraction. It's definitely going to come this time, right? Nope. But she's making progress. And we are intermittently listening to the heartbeat between contractions. It's just the husband fades out, fades back in again. Once the baby's rumping and is out, then there's no point in really listening to heartbeat anymore. So what I'm hoping you get from these videos is that you can see, okay, this is a normal rotation. This is not normal rotation. This is not normal rotation, but the baby looks good. Let's give her another push, or let's see what happens. Or it's not normal rotation. The baby doesn't look good. I'm not going to sit here and wait any longer. And it goes back in again. One more time. What's that?
Is the baby almost posterior?
Nope. It's hard to tell until now you can tell. All right, the baby's right sacrum transverse. Okay? Now, right now, if the baby didn't have an arm in a problematic position, you'd expect the baby to already be beginning to turn. The capillary filling is excellent. The baby has a lot of vernix too. But the baby's color is good. But at this point, you already know that it's not going to rotate. If we pop those feet out, the baby isn't suddenly going to go, whoop. It's not going to do that. So which arm is the problem in this baby? If one of the arms is a problem, which one would it be? The right arm, correct. The one on the pubic bone side. Because it's usually the pubic bone arm that gets stuck. And that would be the baby's right arm. When they're right sacrum transverse, right? It's this arm over here. So what Monica and I are talking about now is what are we going to do? And what we're going to do is we're going to gently release the feet and rotate the baby to do what we can. But you'll see with this one that actually, you know, when you say we rotate the baby till we can see an armpit, remember what I said that with the love set maneuver? Well, you can actually almost already see the baby's left armpit. So there's no reason to rotate that baby. So watch what I'll do is we'll get the feet out and then I'll just go get the left arm. And then instead of taking the baby up and rotating 180 degrees, I just go in anteriorly and just sweep that arm across. And as I do that, the baby rotates to tum to bum and then shoulder pressed and comes out. So I'm just going to help the feet out. But now we're essentially up to the shoulder. So just that arm was just sitting right there. Just gently rotate it out. Mom tried to walk up the bed. No, what I could normally do is I could pick the baby up, rotate the baby 180 degrees and do the other arm, or I'm just going to go in anteriorly, behind the head. I'm going to get that arm off of the pubic bone. I'm going to just gently bring it down over the abdomen. And I can tell how much as long as I'm easing, pushing, and it's moving, then I'm fine. If I was pushing, I wasn't moving, then I would lift up and rotate. But that arm comes out, but you'll see as that arm comes out, the baby's missing something. And it's missing tone is what it's missing, right? So there's no reason, I would not stop there, even though now the baby's tum to bum and everything, because once you start rule. So I'm just pushing, steady shoulder press, there's the chin. See the perineum bulge? You know the head is flexed. It's a very gentle, slow shoulder press, trying to preserve her perineum. You know, it's a 9-pound baby, and it comes out of a primip with no tears, right? And the baby needed a couple of rescue, like a little bit of rescue breathing, but it actually did quite well. Its 5-minute APGAR score was normal.
On that note, supporting the baby when it's born, obviously, like the preceding factors like tone and colour is going to influence whether you're more likely to offer respiratory support than a baby that's like got normal turgor in the cord and colour and reperfusion.
Wait, I'm sorry, I didn't catch the question part of that.
So, like, the preceding minutes are going to influence the likelihood that you're going to offer respiratory support when the baby's born. Because you said, it's really normal for breech babies to be born and have a lower APGAR score, and your tolerance for that will obviously
my tolerance grew as time went on, but I will tell you that if I have a baby that comes out completely floppy like that, I'm not going to sit there and watch it. It's just not my nature to do that. That's not the culture I grew up in. So this was earlier in my breech career, but as I got bolder in my career and learned more from the midwives that were with me, I would learn that I didn't have to do stuff. And a lot of times, by the way, with a teamwork setup, is that if I'm responsible for the mom, the midwife's responsible for the baby. That's how we did things. So if the midwife was doing the breech birth, then I would be responsible for the baby. But in this particular, what I did in the future was if the midwife's responsible for the baby and I trust the midwife, I let the midwife do her thing, almost always. And sometimes I'd step in anyway, because I just couldn't watch a baby sit there. Some of you are better at it than I am. I think that I'd like to see the baby come around. It's why I like to intervene a little sooner. I'd rather have a baby come out with a little bit of intervention with better tone and better APGARs. I don't care about the APGARs, but less acidosis than waiting a little longer, just so I could say the mom delivered the baby without anything. And again, this is the art of what we do. When to intervene is based on our experience and our anxieties, mom's desires, all these things you have to weigh. Each of us, that's the beauty of our continuity of care type practice, for those of us that have it, is we know our clients, and maybe we can talk about these things ahead of time. Okay? So, physiologic breech breathing, hands off, mostly. All fours or upright positioning is the best position to be in. There's no hurry. I don't like timing, but again, you from the time they reach the umbilicus, you generally have 3 to 5 minutes, but sometimes you don't. And then sometimes, like you saw that baby that first, when those arms came out and we just sat there and watched it for 4.5 minutes, or whatever it was hard to watch. And you knew it, and it was hard to watch because you knew there was something that was going on and you all would have intervened upon that baby. Observe and be ready to react. Know your maneuvers for arms and head. Be prepared. Be prepared means having your trays ready, your resuscitation tray, that sort of thing. Is it a primer or a multip? Things are going to go faster with a multip, and maybe you can give a little bit more leeway with a multip. There's no substitute for experience. Selected term breech birth succeeds or does not, for the very same reason that vertex birth succeeds or does not. So, using your judgment and offering a little help is okay. Let me just get out of this one here. Let me play this. Okay. Just saved us like a couple of minutes there. Oh, hang on. You know, we're watching a normal breech, frank breech, rotate beautifully. Again, lighting and stuff makes it hard to assess color. Color is useless pretty much.
So good.
But everybody in this room should feel really good about this breech baby because it's rotating beautifully.
Very nice.
Oh, did it freeze again? I don't know why it's doing that. Let's try that again. Right arm's coming out.
Perfect.
Good tone? Really good tone. Cord is right up the middle, cord is robust. The baby is like saying, I'm okay. So Sally is a midwife in Texas. And what she decides at some point is that left arm isn't really coming. So I don't know what she's saying to the mom or anything like that, but maybe she's not saying nothing. Maybe she's saying, you know, maybe I'm going to help the baby's arm out. I don't know. But she decides, makes a decision. That's a personal decision for her. Because here's the head coming out, and the arm is still inside. So she says, okay, I'm going to get that arm out of the way, and then the head just basically falls out afterwards.
Oh my God.
You're done. You're done.
She didn't have to do that. She chose to do that. There's nothing wrong with doing that. And you get a good baby out of it. This one's a little harder to watch. This is from Breech Without Borders. Some of you may have seen it if you've taken the course. I'll let it narrate itself, but I'll comment on it. Again, I'm sort of going through these a little bit more rapid fire so that we make it through this. This is spontaneous multip. She's a multip. Frank breech. She has a bicornuate uterus, which doesn't really matter. She's a doctor. She thinks she's a good candidate for a vaginal birth. Her doctor laughs at her and says, no, you'll have a C-section.
Perfect. Good. You're good. Perfect. You're okay. You're okay. It's just your baby. You're okay. This little butt is out.
So when we get a little bit further into this, I'd love you guys to comment
Good job, Mama. Good job.
on what you might do differently than what they did. Outcome was really good. It was good, but I just want you to give me a comment. Pasty toothpaste like meconium is a great positive sign of descent. It's normal.
Okay. You're okay. You got this. Good. Good.
Not all meconium is evil, but it's often in the medical model they're worried about meconium. They see meconium, they're worried about meconium aspirations, and the two really have nothing to do with each other.
You got this.
I'm sorry?
You got this.
Wait, hold on.
You're okay.
What? Oh yeah, sure, I can. Problem is I can't move it forward, but that I can do that. Yeah, I can do that. No, I'll do it. I'll just get it going again. See, now I can't, I have no space bar, so we have to watch all that over again. We can watch it over again, that's fine.
Perfect.
Just for the sake of time, and some of them I'm trying to move the space bar ahead. So.
You're good. You're good. Perfect. You're okay. You're okay. It's just your baby. You're okay. His little butt is out.
You notice how her knees are inward and her legs are outward. It's like the right position to really be in.
Good job. Good job. Beautiful job. Beautiful job.
You know, for years we told women they had to have their legs back and push them back like that. I did all those things.
Okay.
When your knees are inward, your pelvis opens up more, like that. The baby's rotating beautifully.
You got this. You got this. You okay? Everything is perfect, Heather. Everything's perfect. Move the pillows.
Hard work, huh?
Missed you?
No. No, most of you have children in here? Did somebody go blink? Yeah. Well, you can see baby's leg is out. Baby has good tone. Keep an eye on the umbilical cord, though. Just watch the cord. There's no reason to do that, just so you know. I don't think it causes the cord to spasm. Nice crunches. Very reassuring. Here's the other leg.
Beautiful, Heather. Beautiful. The feet are out.
Okay, now just to
Creasing
me,
the chest.
anatomically, what I would like to do is
Tummy
have this
crunch.
mother do what?
Beautiful.
Yeah.
Yeah, baby's doing what he needs to do.
What would you? What's something you could have the mother do? Yeah, rise up. Yeah. It just seems like the baby has to come around a sharper angle when she's down like that. If she were up on a ball, leaning on a ball, it would be a little bit easier. That's my take. It might help to flex the head too if she came up a little bit. But she's doing great. The cord is starting to look a little different though. Can you see the cord?
Perfect.
To me, it's looking a little bit paler, but maybe I'm just already biased.
Yeah, awesome.
Yeah.
Everything looks beautiful, Heather. You're doing so good.
Another tummy scrunch. So the baby's telling you it's okay. The cord is still certainly getting to me a little bit flatter. Another scrunch.
Beautiful. Second arm is coming down. Nice and slow. Beautiful.
Lower abdomen is hurting?
They call this gasping, and it sort of does look like gasping a little bit. And the cord is pretty much flaccid. And there's no tone. So that's at, we're at 350,
Yep, the other
about
arm's down.
350.
Yep.
What's that? No, they're not encouraging her to push. They're not encouraging her to rise up.
Can't
The
tell right
baby's
now.
got
Before you
gasping
come in next
movements, the
time you
cord
push.
is flaccid, and there's no tone.
Whenever you feel
So
ready.
everyone in this room would probably be doing a shoulder press at this point. Right. Now the heart rate's 64 at 417, and they do nothing. Now, I don't know this. I don't know the situation. Is this a hands off the breech scenario, or is this because the mother's a doctor and she told him I don't want anybody doing anything? We don't know. But I just want you to look at this and know that this is not how you should manage a breech birth. I mean, ultimately, what are we waiting for here? So the fact that the midwives aren't telling her to push, the fact that I'm just assuming they didn't really know. They knew some of the basic rotational maneuvers. They knew the baby was coming out fine. But I think they really went to the hands off the breech thing way too far.
Beautiful. Push your baby out, Mama. Beautiful.
Yeah, there's no flow. The baby's getting no exchange right now. It hasn't been for a
Finish
while.
this project.
But she does deliver it by herself.
Push your baby, go for it. Push. Start the timer. It's a little bit going over on this part. Just a little bit. There we go.
So now the midwives have more patience than I would ever have. They're letting mom do this, and the baby's just sort of laying there.
Yeah.
I think that's very sweetly said, but I'm not exactly sure that that's what I would call that. So about 47 seconds, the baby opens his eyes, 46 seconds. And then at 53 or 54, it takes makes its first cry.
Oh, there's your eyes. Hello. Welcome to the world.
So technically, it was all under a minute. It's just, I don't know if you guys could have watched that, but I couldn't probably have watched that. I would have wanted to make sure that baby comes out, make sure that baby doesn't end up in secondary apnea.
Heart rate 140.
Okay? So I'm gonna, well, they actually have the summary here, so.
It's easier when they're head first.
Okay, so there we go. All right, so this baby didn't come out. This baby actually passed away. This was sent to me. I have a whole bunch of just pictures. I don't have a video. But you can see that the baby was sacrum transverse at 9:09. And 11 minutes later, it's got an arm out, but it's still sacrum transverse. There is absolutely no reason to do that, to let that wait like that.
Do you know if the baby's alive at this point?
Oh, no, I don't. Yeah, I'm assuming it is. There's no way to, I don't know. I don't think it came out dead. I think it just didn't make it. Because again, I don't have the video, so I don't know. And I don't know the thought process. I'm emphasizing that there was the baby was sacrum transverse above the umbilicus. Everyone in this room at that point would say, that baby isn't going to rotate, I'm going to help that baby out. Now, before it becomes a real problem.
So that's 10 minutes in between those two.
11? Almost 11 minutes. So this is where that hands off the breech thing can be carried way too far. And it's sad that it became a mantra for a while in response to the hands-on everything on the breech. But now I think we're back to where we need to be, where we know when to intervene. We've gone through those things, when to intervene. We make a judgment that it's time to do something, then just do it. And we know what to judge, we know what to look for. And again, even if the baby's color looks crappy anyway at 9:09. But even if it wasn't, it was still doing crunches. When it's sideways like that at that point, it's not going to come out by itself. So don't wait until you have a baby that is in trouble. I think I beat that horse to death. All right. I didn't put this up there to scare you guys. This becomes algorithms. I'm not an algorithm type person. I told you that. This is from Sean Walker and Anka Ritter. And they do these things. They did this one and they did this one, which is even more complicated. Some of you may learn from these sorts of things. And so these are available, and you'll get these slides, and you can look at them. You can also go to the papers. The references are on there. You can go to the paper and read them and stuff like that. They don't help me at all. Because I don't care if something's been 3, 5, or 7 minutes. If the baby is not progressing, if the baby's showing signs of problems like tone or color or capillary filling or whatever, I'm not going to wait 3, 5, or 7 minutes. So that's not how my brain works, but I think it's fair to put that out there and to talk a little bit about what they found in the paper. This was looking at 42 videos that were submitted to them or from the internet of breech birth. So remember, the end number is only 42. And I'll talk about that because Betty Ann Davis wrote a rebuttal to this paper, which I have a summary for it, and we'll talk about it. But some of the things they found were the physiologic breech algorithm designed by Walker accounts for expected timings in a normally progressing breech birth, as well as time required to perform certain maneuvers in cases of obstruction. They suggest, this is the problem, because this is not a clinician talking, they suggest that can be used to guide further research and key clinical documentation points such as the time of rumping, birth of the fetal pelvis, birth of the umbilicus, and encouragement of maternal movement to confirm obstruction before initiating hands-on intervention. This is not how a clinician thinks. I'm not going to sit there and chart time of rumping, time to umbilicus, time to nipples, time to this. I don't care. Now, if you're trying to study breech, okay, fine. They can do this in academia, but here's the problem when they do something like this, and then they publish a paper. Well, before I even tell you what is the problem when they publish a paper like this? What do you guys think is going to happen for a paper like this? Right. They're going to be looking at their clock, and then the problem, of course, is what Betty Ann Davis says here, which is upright breech birth. New video research risks reviving Friedman's curse. Not Friedman's curve, but Friedman's curse. Right? So what she says is, the Writer et al. Study was based on a convenient sample of 42 videos acquired by solicitation and chosen from the internet. Protocols for safe and effective upright vaginal breech birth have been developed over a decade and a half through extensive clinical experience, introspection, and research by pioneers in the field. Evidence of effective care in upright vaginal breech birth without mandated time limits from buttocks to birth has been demonstrated in 3 published cohort studies and in their data presented in this paper. Developing time limits on breech descent inferred from a small convenient sample is epidemiologically inappropriate and worrisome. We have spent many decades freeing women, we haven't really done it yet, from the iatrogenesis, which by the way is a great word, the iatrogenesis associated with Friedman's curve. It would be a mistake to fall into a similar clinical and legal straitjacket with upright vaginal breech birth. Unfortunately, obstetric guidelines quickly become entrenched, often used in a rigid manner, never intended, risking pathologizing the normal and driving litigation. Evidence and experience teach the limitations of time guidance. The focus should be on observation of the woman and the baby, not the clock. I can't stress how I love Betty Ann Davis for saying that and putting that in writing. Because what happens when academics put this stuff out is that risk managers and hospitals, they adopt this stuff. And this is how they teach. And that paper that I mentioned briefly from Sweden, their results are based on this protocol. And this protocol leads to maybe they're waiting way too long because they're giving 3 minutes to a baby that doesn't have 3 minutes, or 5 minutes to a baby that doesn't have 5 minutes. So pearls of wisdom from Anka and Sean are these. The data suggests that delay of 90 seconds or more at any point after rumping indicates a completely spontaneous birth is unlikely. In this sample, even most assisted births were completed within 3 minutes of the birth of the rump. So in other words, if a baby rumps and nothing changes within 90 seconds, and mom should be encouraged to push, there's no reason to wait for contractions, and the baby isn't moving, then it's very unlikely that baby's going to be delivering spontaneously, and you're going to consider that a need to help. So there is a bit of wisdom there. Again, 90 seconds is timing. You don't necessarily need to look at your watch and wait till 90 seconds is up. What I'm trying to teach is to look at the baby and make your judgment from that. Oh, they didn't differentiate between primips and multips in their paper, which I think is a flaw in any paper who looks at breech or twin birth, because they're completely different. Our work suggests that the strategy of instructing a woman to breathe through her urge to push while waiting for the next contraction should be reconsidered. And I think everybody in here agrees with that. There's no reason to do it. Let the mom follow her body, but if she's not pushing and the baby's out to here, then you tell her to push. You need to tell her to push. Again, most of the time, you won't have to tell her to push because her body won't be able to resist pushing. Unnecessary delay may increase the chances that the placenta will detach from the uterine wall before the birth of the fetal head. And then this one I'm not sure makes any sense to me because I think they're thinking too much again. When upright and confronted with a delay of fetal arms in the mid-pelvis, clinicians in the sample tended to attempt to release the sacral arm first, or the posterior, what we would call the posterior arm first. We have begun to teach novices to attempt to release the pubic arm first. I don't understand why. Again, that's an academic thinking. Okay, so for the inexperienced, what is needed is the experienced rather than an algorithm or a mantra. The biggest concern is where that hands-on expertise will continue to come from for our breech mothers. And inexperienced practitioners moving forward, I have long been concerned about this in the UK, and I would say here in Australia and the United States and every other country. Where is the expertise going to come from? And that's what you guys are going to have it, and you're going to carry it forward, and the ripples are going to come out of here. All right, so this is a really great video because I met this midwife at the Kentucky Breech Conference. I saw her walking down the hall. I said, I know you, because I've seen this video so many times. This is a true surprise breech, and a midwife who knows nothing about breech birth, but has wisdom and just figures it out. She does what she has to do to get it out. So it's fun to watch. I mean, I clearly know, I know the answer to this question, but watching these videos, it's starting to come together right now. You actually, if you went home tonight and had a surprise breech, even though you haven't done a single sim, you kind of know what to do or what not to do. Right, already. Some of you already knew this because you've got, you know, some of you have had more clinical experience. You took the breech without borders course or whatever, but many of you haven't. So at this point, it could easily be a bald Caucasian head. It's inside the caul still. She hasn't ruptured her membranes yet. So, you know, that could be a bald white baby. What's that? No, mom's just putting pressure on her clitoris. I mean, she's putting counter pressure.
Now do you see the bag?
That's actually amazing.
Hey, I mean, if you're not looking carefully and your eyes see what your mind expects them to see, if you thought this baby was vertex, you might see that and you say, yeah, that could be vertex.
Every little push brings them
What's
so
that?
much farther.
Yeah.
Great control, Marsha. That's great.
In a minute, you'll know that it's not, but okay. Okay. So she doesn't need to have her hands on the baby right now. She doesn't know.
Okay, go ahead and push.
But also notice how calm the midwife is. I was really impressed with her. Okay, so again, she's helping the legs out. Now look at what's the position of the baby? Left sacrum transverse. So the baby's great. It's crunching away and it's fine and it's got capillary filling. But at this point, everyone in this room would know that this baby is not going to rotate on its own because probably its left arm is stuck on mom's pubic bone. That's probably what's going on. Look at that baby go. So the midwife's trying to figure out, you know, should I do nothing? The mom tries to pull the baby out herself, right? That doesn't work. So everyone in this room at this point would be knowing we would just go ahead and rotate that baby. Baby's great, but there's no reason to wait because that baby's going to need help getting out. Remember, normal needs help. Normal needs help.
Push down into that, please.
The baby's starting to rotate actually the wrong way. Okay.
Go ahead.
Still got good capillary filling though. I mean, and it's still crunching.
Yep.
So at some point the midwife says, okay, I'm going to try to figure this out. So I'm going to try to get this baby out, but I don't really know what to do. So mom's helping.
I need you to push, okay?
So she's reaching up to try to find an arm.
Come on.
She's rotating the baby the wrong way. But eventually she finds the posterior arm and she gets that out. So then she doesn't even do a rotational maneuver. She just goes in with her right hand anteriorly under the pubic bone, and she slips that hand, and as she does that, the baby rotates to the right position, out comes the arm, and out comes the head. Isn't that great? Hello, baby.
Open it.
Oh, it's still, again. Oh yeah, you just, well, it would still be off the side, and you can angle it down, and even if the heart rate's actually here, but you could angle it, you could get it from here. Yeah. And again, your mind sees what you expect it to see. So if you don't, I mean, look at, I don't know how many of you have had a surprise breech. I rarely did because I did my own scans and stuff like that in the office, and I sort of knew, but every now and then it would happen. And yeah, so your heart rate's a little high, but your mind doesn't register. It's like pulling a baby out and going sacrum posterior, and not really, your mind doesn't register because you expect the baby to be in the right position. And then finally, your brain catches up with your expectation. Okay, so let's talk a little bit about water birth. Right? The whole point of being upright in water for breech birth is to have gravity. In water, you don't really have gravity. So this one, I'm going to escape this one, and I'm going to use this here because I know it's small, but I just want to say this was a birth center birth where I had never met the couple. I got called by a midwife for a surprise breech. They were at a birth center. When I got there, the mom was in the tub. The feet were already out a little bit, and there was about 5 or 6 family members that were standing on the end of the tub. So here I come in a room where I don't know anybody. I'm trying really hard to not take over the room and let things go. So I let things go a lot longer than I normally would have. I go about 5 or 6 minutes where the baby's out to with one arm out and one arm still kind of stuck in like that. And eventually, or maybe 4 or 5 minutes, and eventually I just go in and pull that arm out, and then I try to do shoulder press under the water. But as you try to do a shoulder press under the water, the mom goes across the tub. So you end up having to have someone hold the mom still, and then you can do a shoulder press. But I waited a long time because, one, it's hard to tell tone under the water. When the baby's moving, it's great. You can see the baby moving. You can see the cord underwater, but you can't really see color or tone very well underwater. And me, having spent 30 years in the hospital and home without ever doing, or hospital basically, without ever doing a water birth, I didn't grow up with water birth. So I became a little bit more involved with water birth as time went on, but early in my career, I wasn't a big fan of water birth. I didn't really know what to do with a water birth. So this is Amy.
As soon as you can, okay? There
you go. And again, I'm just gonna go like to 1 minute here.
Here comes an arm, I think.
Okay, so the baby's out, both arms, there's an elbow right there. Can you see my thing? Yeah, you can see it, okay. There's an elbow right there. Baby's doing tummy crunches, it's good. You can see both elbows are out. What's really interesting is the left arm comes out, but the right arm, even though the elbow is out fairly far, never comes out. It's trapped by the perineum right here at the wrist.
Pull in between into your front.
Look at the baby doing. Look what that baby's doing.
There's his arm.
A crunch and brings out his left arm.
Look at him working hard to get out of there.
Oh. Oh.
Now again, you think about this. Had she been out of the water?
Is he doing that?
Yeah. The baby's doing tummy crunches like that? That right arm would have come out.
Hi, baby. Oh.
Okay, so that was at about 1.5 minutes.
Are you filming?
Can you push a little? Can you give it a push?
Well, a little bit less than 1.5 minutes. A little bit more than 1.5 minutes. Okay, so now we're at 2 minutes. Let's go to 3 minutes.
Do it again.
Okay, let's go to 4 minutes.
You can help this baby out.
So this is me letting do this, partly because I didn't want to. I didn't have a relationship with the family, so I didn't really want to do this. I was hoping that things would just go the way they wanted it to. Let's go another minute.
Gonna touch your butt.
Oh, I try a gluteal lift just to see if I get that arm to come out. I'll just let it play from here.
We're doing it, Amy.
Is this baby good or not good? What? What? Hard to tell.
Can you rise up, Amy? Can you rise
Hard
up?
to tell. Cord still looks pretty good.
Get higher up so that he's hanging more. Just like that. A little higher if you can. There you go. And
Try to get a little more gravity.
Push now.
Now push it down.
But there is no gravity.
Push like your poopy. Push like your poopy. Don't let your breath out. Push like your poopy.
So we're now 3.5 minutes since the left arm came out.
His tone isn't very good anymore, so I'm going to go ahead and...
So now I'm just going to pull the right arm out, which came out just like that.
Okay, I want you to take
And I'm going to try to do a shoulder press.
on the shoulders and push straight toward mom. Lift it, rise up, rise up, honey. There you go. Don't go away from us. Come back here now.
It hurts.
Come back here.
Can you do that?
Here, put your fingers in
I'm going to have somebody steady her, and now the baby comes out.
Amy,
Very
you
easy
need to,
with
yeah, Amy, you need to stay in one place.
Okay.
Okay, there you go. Forward. There you go. Okay, hand the baby to the front.
Baby. Get your baby. Oh my God.
And come back to me. All right.
Okay, so that happened at about 5.5 minutes. So it's 4 minutes from the
You are such a beautiful
basically
breech, and you didn't even have that cord around your
one
neck.
arm out, one arm in. That's too long. Again, the idea that you should see progress and stuff like that, and that really, I love her face. Looking at her family, and that's cool. But I just like the idea that if you're in the water, the purpose of upright is gravity. You don't have gravity, and I ended up having to do stuff that if she'd been on land, I wouldn't have had to do. So it's a decision. She wanted to be in the water. That's where she wanted. And again, I didn't know her well enough. I didn't really have a say. I got there. She's already in the water. And I would never tell her not to get in the water, but I would just explain to them usually beforehand what are the issues. So in the next one, yeah. Right. So that's a very good point, because in the next one, what Brooke does, this is the same midwife, by the way, who did the unnecessary shoulder press, but it was really nice shoulder press, so I showed it. This is the same one. She has a baby that's coming out, and she realizes the baby's floating upwards. So what does she do? She turns the mom over, and the baby floats upward into the sort of the Brocked position and just pops out. So let's watch that. It's really quick, so it doesn't take long. I tell you, there's nothing like the thrill, by the way, of a breech birth when everything's going the way it's supposed to go. It's so fun to watch.
Roll over so we can get the head out.
She just has to roll over, and the baby, she lifts the baby up instead of shoulder press, and the baby just comes right out. All she does is lift up the baby, which is like doing a shoulder press from the front. And the eventual ceiling shot that you get. Okay, one more. And this one was all over the internet too. I don't know if you saw it. This is she was a friend of Bliss's, and she discovered, she had a tough story. This is Raquel, Raquel is now my personal assistant with the podcast and stuff. But Raquel has she has a two-family thing. She's got 2 older kids. She has a bicornuate uterus. Her first pregnancy was when she was very young, and she had a breech baby, and they did a section on her. And they gave her no choice. Her second baby was her daughter, who's a couple years younger than her son. It's both are like 19, 20 years old, and was a vertex baby, but she was not told she could have a VBAC, and so she had another C-section. Her third baby was with her new husband, and she was breech again, and she was told, "You're breech, we've had 2 C-sections, you can't have a vaginal delivery." So she had a 3rd C-section. And she never knew anything. She didn't really know much about it. She's now become a doula, and she's got really so she then did some investigation. I think she found Bliss, she found us, she listened to the podcast. She realized that she'd been robbed sort of the chances that she deserved to have a baby. She got pregnant with her 4th baby, and she sought me out, but I was on sabbatical. And Victoria Flores, my colleague, was the only person doing breech and twins in Southern California. So Victoria was her doctor. I barely knew Raquel. I kind of met her once maybe. But Victoria was going on vacation. So I told Victoria I'd come back to LA and I would cover her for a week while she was on vacation. And Victoria left for a vacation at 4 o'clock in the afternoon, and at 5 o'clock in the afternoon, Raquel calls me and says she's in labor. So Victoria left me with no team. I found Alex, my midwife friend, Alex Evangelidi. She came, and because I was sort of just hung out to dry a little bit. We know how that might happen sometimes. And so I was the lucky one. I was the one that got to be involved in her birth and give her this redemptive H-back after 3 C-section home breech water birth. But it's a bit awkward at the end here because the baby's coming out. It's tum to bum. But eventually underwater, I can't really tell the tone. So I check, and this baby's got no tone. So I have her get up to get out of the tub. And at that moment, she has a contract. She has to push. And she starts pushing. And so I help the arms out. And I try to do a shoulder press across the tub. And again, it's sort of embarrassing. It's quite awkward. Then eventually, because I have a bad back, so eventually I have her turn the short way of the tub. If you have a birth pool in a box, never try to do shoulder press the long way. Always turn them the short way so that you have more room. So let's just watch. And then the baby came out really floppy. And this is a baby where I was really chomping at the bit, but Alex was in charge of the baby. So I watched and I watched and I watched, and finally I'll show you. It's kind of funny.
So we're fine.
What I did.
All right. We're fine. It is a girl.
But this is one of those serendipitous moments where, because she went on vacation, I covered her. I met Raquel, who is now like so good at taking care of things and actually thinking up new ideas. What is that? Is that actually on the video?
Slow down your breathing. Slow down.
I don't remember that.
You're going to pass out. There you go. No, we're okay. We're at the umbilicus now.
She looks for things. It's just very lucky that she didn't go into labor the day before or a week later.
Slow down. Slow down. You don't have to wait for contraction now. You can push when you want to.
Well, I try it one-handed initially, and I can't. I almost fall into the tub doing it. And again, if I had a better back, I probably could have done it.
What's that?
Good.
You know, my mind and my heart are really willing, but my body, between my knees and my back and my eyeball, it's like just
turns white.
Yeah, you're good. Take a breath.
So again, what I'm saying, so I couldn't tell what the heartbeat was, but the tone wasn't really good, so I have Alex just checking, and she says it's over 100.
What? You can feel it? Okay, good. I'm glad.
Yeah, I sometimes just flick the foot to see if they do that, and at some point she doesn't do that. I check it. I think I check it here.
Yep, I know. Yep. Here we go. Down. Yep. Bring those arms down.
So again, it's been about a minute and a half. There's been no change, no descent, nothing. That's another sign that something's going on here.
There you go.
So now I'm just checking the tone, and I don't like it.
We don't really have any tone right now, so let's get out of the tub really quick. Really quick.
She gets up, and then she has to push.
All right, stay right there, Mama. Stay right there.
Should have moved around the side of it.
It's okay.
You got it. Right on you. A little bit more.
You're so close.
So get both arms out. Now, get both arms out. They come out. Now I try to do shoulder press across. This is what you're talking about?
You're so close. You're so close.
So I try the one-handed shoulder press. That's not working.
I can't. Turn her this way.
I almost fell in there.
There we go. We're good. We got it. I got
Turn
it.
her sideways.
We're good.
Almost there. Good. Almost there.
That wasn't bad. You thought it was that?
And she gasped.
Yeah.
Okay. She's floppy though, so let's get her.
Yeah, that was not a very difficult shoulder press, right?
Around there. Hold their tongues.
Talk to her. Let her know she's out. Let her know she's here. Tell her it's okay to breathe.
That baby had one of the longest umbilical. That baby has a really long umbilical cord. So why are they filming the side of the tub where there's nothing there? You always wonder, like they're watching and the camera has gone over here. Right? So that's Alex. She's in charge of the baby, and I'm supposed to just bite. I'm supposed to take my hands and sit on them.
Yeah.
150s.
God, it's 6:17 already?
Oh, Mama.
Holy shit, how did that happen? Did we move dinner? Did we move dinner, or what are we doing?
Sorry, what? The baby's gone?
We're like, you're welcome, baby girl.
Did we move it?
Yeah.
Coming. Keep it coming.
Yes.
What? So at some point I can't take it anymore, and I just pick up the baby, and
You don't have a big toe.
I don't like that baby that way. Alex is telling me to leave it alone. I'm just wondering, can we push dinner back to 7? So what should we do? Gad, bless it. How far are we from the restaurant? Oh, okay, good. All right. All right. All right, I'm going to skip that anyway. I give the baby a little pat in the back. So let's review the cardinal movements. We're in triple speed here. Okay, you've seen all these things, you know them. Remember these cardinal movements? When that happens, you have to just basically hand the mom the baby. This is another one. I'm gonna play this one really quickly, but I have to get out of this mode. Okay, I'm gonna start at 7 minutes. Okay, so we have a baby that's coming out, and I'm just gonna watch. I'm just gonna go forward.
Good job.
Here we are at 8 minutes. Good. 9.5 minutes. Okay, so we're at 9.5 minutes. The baby's sideways. Let's go to 11.5 minutes. Baby's still sideways. 12.5 minutes. Baby's still sideways. Okay. Again, we all know that that's not what we would do. So the baby has no tone, the baby's sitting there, but what's really amazing about this baby is watch what happens. So she checks the tone, and then she still doesn't do anything, so eventually she does. But watch, she picks up this baby, and the baby's actually, well, hang on a second. I think she was going to do something, then she stops. But explain this to me. This baby's been sitting there doing nothing for 5 minutes, and the baby's got tone.
A little bit, okay?
Oh,
I know, it's a
She
lot.
rotates the baby
It's
the
really
wrong
intense.
way.
We're gonna help him come
It's
out,
kind of
okay?
like, oh,
You're
where's
okay. You're okay.
the mom with the with the posterior baby? Where'd she go?
Got some tone.
Oh, there you are in the back.
That's it.
She rotates the baby the wrong way, and it still comes out beautifully. The arms come out.
I
She
know.
unlocks
That's
something,
it.
and the
All right,
arms
there's
come
your
out.
arm.
Okay.
Okay.
And this baby did fine.
There you
A little
go.
floppy. But
There you
you're
go.
saying baby sat there for 4 minutes with nothing, and the minute she touches the baby's got reflexes and tone. I can't explain that one. Let's see, let's skip that. Oh, we're going to skip my paper. We don't need to skip my paper. I mean, we can skip my paper. 2 more things. This is just Sarah and baby Jack. This is a woman she's a forest ranger, very strong. She's in lithotomy position. This is something you don't see very often in lithotomy position.
Get his foot. Take this finger here and just gently pull this foot out with it. Gently just go pull the foot out.
She can't take it anymore, so she's kind of like Shelly and says, God damn it, get out. And she pushes the baby out in lithotomy position. The baby's a little bit stunned when it comes out. So next is a word on bruising. It's very important to understand that breech babies come out and they can be very, very bruised. And the reason I say that is because there was a case in Florida where, again, it was racial profiling. I'm 100% certain of it. A couple had a home breech birth. About 4 hours after birth, they thought the baby was breathing a little fast. They decided to transfer the baby in. It was not an unassisted birth, but the midwife said transfer. They took the baby to the ER. The husband is black and has dreads. The mom is white. And the baby came in, and the bottom looked bad. So they obviously called some expert down from the OB floor, who immediately called Child Protective Services, accusing the father of abusing his four-hour-old baby. They took the baby away from them, and they came and took the other child away from them. It took them almost 6 months to get their kids back. That's my lovely United States government. Florida, that was in Florida. So it's important to understand that bruising does exist, and this is baby Freya at birth and 5 days later. So it looks pretty bad at birth, but at 5 days later, just so you know that that's a normal thing. And then the last thing let's watch is the birth that we saw at the very beginning. So let's watch Shell and let's get our shoes on. Where are my shoes?
Beautiful, yes.
So now watch, we're gonna watch, this is not a footling breech, we know that. This is a woman on a birth stool, which is a little awkward positioning, because technically, even though she's using gravity, you're seeing her as if she's in lithotomy position. Because you're seeing the back rotate toward you instead of the tump. Then you're also seeing late rotation, because the baby's complete breech.
You got it. You got it. You got it. Here it comes. Sliding.
And then this baby's head does not deliver by flexion.
Good.
Kind of like Sarah's baby, Jack's baby that you just saw, where she just blew it out. This baby is also just blown out. So she did not tear, Sarah did not tear, but in likelihood you could get a nice tear when the baby doesn't come out by flexion. See how the baby's rotating a little bit late, but now it's rotating? God, the time just, sorry about that.
Good.
So again, in this situation, because she's in this position, somebody should actually pick the baby up this way. And then the baby would deliver by flexion. She's just so strong, she just blows the baby out. That's not a cardinal movement. That's a shell movement. Okay. Let's see. That's it. We didn't miss that much, but let's quit. Let's go to dinner. And tomorrow, if it's okay with Joe, I would like to be here just before. Can we come here just before 8, Joe, and set up? Yeah. Was that a yeah? Enthusiastic yeah? And then if you guys can get here, people can get here from 8:15 on. Just waddle in when you can, and then whoever's here first will start. And I'll do some demos until everybody's here, and then I'll do some more. But I want to get people started because we have such a large group, and I want everybody to feel satisfied tomorrow, because tomorrow's a day where you're going to really get to do hands-on stuff. But I hope you all learned stuff today where you now feel like you know why we're at where we're at, and that if you had to do a breech baby tonight, you could probably do it. Okay? Okay.
Take this time to get out, live confirmation. Cause I've been moving, I've been moving, I'm blessed, so I had savings. I will run if I had sadness. Look, good drama, I'm being honest. Just a little drama, I'm being honest. You can tell that I ran out of time. You can tell that I ran out of time. Unavailable another times. Unavailable another times. You can tell that I ran out of time. You can tell that I ran out of time. Unavailable another times. Unavailable another times. I've been moving, I've been moving. This money can never, this has been enough for you. My